Yeah. Tell me. Yeah. Yesterday is okay, man. Thanks. உங்க கேமரா பக்கமா எப்படி கேமரா பார்த்த மாதிரி அந்த சைஸ் வரும் அதே அதே தெரியல தெரிக்கணும் அதே அப்படியே இருந்தேன் ரெடி நைஸ் சார் வேற ஓகே சார் ஓகே
Hi, Matt. Good morning.
Morning, Jazz.
Hey, good to see you.
Great to see you,
Matt.
mate. Yep, very excited.
Hi. Yeah. Thank you. Thank you for giving us your time to present this. We're really looking forward to it.
No, thank you so much for having me.
We had some discussion around AI. We have been having it since yesterday, so we're looking forward to this one. So Hamilton was supposed to do the first talk in person, but he not in person, but online.
Yeah.
But he has sent us a recorded version. He couldn't do
Okay.
it.
Sure.
So are you happy to start first?
Perfect. Yeah. Perfect.
Okay, beautiful. So I think we're just waiting for Jesus. So we'll start in 5 minutes. Okay.
Amazing.
Thanks, Matt.
Jazz, I've just requested to share my screen with my slides.
Yeah.
Perfect.
Hi, Matt. Can you just unshare your slide so we can put up your introduction slide to introduce to the audience?
sure.
Yeah.
Sure.
Busy household, Matt.
Yes. Yeah. I've got my son here, but he's just watching something.
No, not to worry, no worries at all.
Have the intro slides, please.
So welcome everyone. Today is the second day of our annual neuropsychiatry conference. So it has been a great time so far. So we are hoping to have a very interesting and engaging whole day today, full of quite a few talks. So we're starting the day today with Dr. Matt Lennon. Dr. Lennon is a conjoint lecturer and postdoctoral fellow at Center for Healthy Brain Aging, UNSW Sydney. He's an emerging leader and early career researcher with expertise in dementia, clinical trials, and artificial intelligence. He has published reviews of potential genetic therapies for Alzheimer's disease and has experience as part of the investigational team in a range of Alzheimer's dementia clinical trials. He has 45 publications under his name with 1,140 citations. He has won a national award for best trainee research in old age psychiatry in Australia, best early career investigator presentation in INA in 2024, best oral presentation on prevention and diagnosis at Australian Dementia Research Forum in 2023. It's a great honor for us to have Matt giving his valuable time on the weekend. So thanks, Matt. We're looking forward to listening to this.
Thank you so much for having me. I'm just really so honored to be a part of this fantastic conference, because I've been in and out of a bit of the program, and it's just a phenomenal program that you've put together. I might just get into it. Is that all right, Jazz?
Yes, let's make it start.
Perfect. Awesome. All right.
Jesus is chairing the session, but he will be joining us in 5 minutes.
Perfect. Not a problem. Not a problem. So the talk I want to give today is really about the future. Because everything we hear about these days, whether it comes to the stock market or the medical market or the future of work or driving or employment, it all seems to come back to AI. And it's this idea that artificial intelligence will take over many of the roles that we currently do. And really, the question is, how do we engage with that thoughtfully? And what does the future look like realistically in psychiatry? Because on one hand, many people will argue that computational things like coding or like driving or other things that computers are good at will move to more AI base. But for something like psychiatry, you do wonder, to what extent can the emotional reciprocity of an individual be emulated by a computer? And the answer, as we might find, is to a reasonable extent. Actually, there's a capacity for it to do that. So I did. In this talk, I did have an idea that we were going to make our own machine learning algorithm using data from the audience, but I think it's probably beyond the scope. But what I want to talk about is where machine learning currently sits in medicine. What are the challenges in prediction and treatment of psychiatric illness? What are the types of machine learning approaches? Because often people talk about AI, machine learning, without actually specifying what do we mean by that, and what are the actual statistical procedures, or what is a fundamental understanding or a basic understanding of the statistical procedures involved in machine learning? What are some examples of machine learning and how they work? And what are some of the pragmatic and ethical challenges we have to overcome before we see this implemented? So we're just going to skip over that. But I want to talk briefly about where AI is, or where machine learning is currently in medicine. So when we look at something like radiology, which is one of the more programmatic or computational specialties in medicine, we already know from meta-analyses that the diagnostic specificity and sensitivity of these AI algorithms are around 79% and 88% respectively. And an 88% sensitivity is very good, and these algorithms routinely outperform specialists, so they're very good, and I'm sure they routinely outperform registrars as well. So they are becoming more and more routine in radiology, and obviously you still need radiologists to kind of tick off and approve and finalize these, but you're going to need fewer of them, and so a lot of radiologists are nervous about their future. The ICU specialists, they are using, so we're already seeing AI algorithms being used in ICU, and they have achieved accuracies. The current algorithms have achieved accuracies of 87%, and they're currently used to inform practice. Insofar as decision-making algorithms, there aren't really any currently in clinical practice, but we certainly have AI applications. So, AI scribes are everywhere in psychiatry. They're everywhere in medicine at the moment. But in machine learning or AI is being used in other specialties is in prediction of outcomes. And we know in psychiatry, we are very bad at predicting outcomes. We're very bad at predicting suicide. We're very bad at predicting
Sorry to
depression
interrupt
outcomes.
you, Matt.
Jess, can you hear
I think
me?
we're having
Yeah.
a breaking. It's not very clear. So maybe you need to bring
Okay.
your mic a bit closer to you.
Sure.
Or maybe the Wi-Fi issue.
It might be the Wi-Fi. Can you hear me clearly now?
Yes.
Yeah. Okay. I think it's the Wi-Fi. The Wi-Fi just ducked out just a little bit. But is that
You
okay?
you can consider switching the video off if you want.
Yeah, I might turn my video off. Okay. Is that any better? Hopefully.
Yeah.
Yep. Okay. Anyway, sorry to get back to what I was talking about. So in psychiatry, we're not seeing a lack of clinical implementation because of a lack of need, because we know we need to get better at predicting outcomes, better at predicting which patients will respond to which medications, which patients will have which particular kinds of adverse effects to medications. We need to get better at predicting suicide risk because we're not very good at that. We need to get better at predicting relapse rates or relapse risk in people with psychotic illness. So we really need good machine learning algorithms in psychiatry. So when we think about decision support in psychiatry, we need to understand how we make decisions in psychiatry previously. And really the two ways are clinical gestalt. So we look at the patient, and based on all of our previous experience, with a particular weighting usually to more recent experience, we make a judgment as to what we think will happen. And it's just kind of a holistic gestalt approach. The other way that we make treatment decisions is traditional statistical methods and guidelines. Now, clinical gestalt, there are lots of problems with that. So we have confirmation bias, recency bias, false correlation, overconfidence bias, immediate gratification bias. And traditional statistics, that is, for the most part, randomized control trials, which are an excellent statistical instrument, but has its problems. The issue with those is that they give very little data on the probable individual effect. So, for example, the STAR-D trial had some very interesting results and showed that antidepressants were effective for some patients with depression. And so on the whole, we're like, well, we should give antidepressants. But in the first line, only 18% of people with depression achieve remission with first-line therapy. So, and other studies have shown at best a remission rate of 30 to 50%. So the average population difference does not mean that you will achieve a difference in your individual patient who's sitting in front of you. The other problem that we have with these traditional statistics is that often the level of granularity is the diagnostic label and maybe like some effect by age, but generally the way that we're diagnosing, the way that we're prescribing treatments is we have a diagnostic label, but we don't tend to modify the drug treatment or the dose based on age, sex, weight, symptom severity, clinical biomarkers, comorbidities, genetic profile, metabolic profile, or personality. And that's partly because we just can't think in ways that are that complex. So what is machine learning? They're computational approaches to analyze patterns in data and consequently adapt current models without explicit programming. So it's a program that continually updates itself based on ongoing data input. The advantages of machine learning is that it's based on prediction rather than inference. So what that means is rather than going from the specific to the general, that's inference. So with inference, you're trying to demonstrate a principle, like say that this particular antidepressant is effective based on a number of individual instances of the antidepressant being effective. You're just really looking at the individual, so it's more deductive, and so you're really just focused on what is the likely outcome here. The other advantage of machine learning is that you can achieve much more in terms of its flexibility and scalability, because the machine learning algorithms can take very large numbers of data points and high dimensional data. So not just one or two data inputs, we're talking about hundreds, sometimes thousands of different data inputs for each individual person they're trying to predict for. So let's talk about a couple of different machine learning models. The first that I want to talk about is called the support vector machine. And in a very simple way, this is it's a machine learning model that considers a number of variables. And here we just show two, but you can have 50, 100, several hundred. And the algorithm has identified, say these are two groups of responders and non-responders based on a couple of different variables. And they've identified a number of groups, and the algorithm essentially calculates this line called the hyperplane. And the hyperplane is there. It's placed, and it's not necessarily a straight line. It can be a curvy line, but it's essentially an algorithmic placement that maximizes the distance from these groups of people. And the idea is that you try to make the hyperplane as specific as possible so as to differentiate these two groups, and so that you can achieve an appropriate prediction outcome. The next one I want to talk about is a decision tree. So rather than looking continuously at data, this is often used for sets of categorical data. So you'll have a number of different variables, sometimes up to several hundred, and you're essentially looking, say the first variable might be sex. So you're saying, all right, male, female. If it's a male, and then you're looking at age group, above 65, less than 65, and you go on and so forth until you get to the end. And if this decision tree goes on and you get to the 10th or 11th level, you can predict then with a great deal of specificity, if you have large numbers, and sensitivity, that this person is a responder and this person is not a responder based on all these different variables or descriptors about them. The next one is a random forest, and this really this demonstrates the power and more the direction of machine learning and AI models, that rather than using an individual model, they tend to use consensus models in many of the papers that are out there today. So the random forest is a combination of trees, and essentially they'll train the data based on several random samples. Sometimes they'll have 10 or 20 or 30 or however many trees they have, decision trees, and they will get 10 different decision trees trained on random samples of the training data. And then to make the decision, they'll run the individual case through every single one of those trees. And whether or not someone is a responder or a non-responder will be decided by the consensus of the trees. So however, if the majority of the trees say they're a responder, then they're a responder. The next one is, this is one of the more common commonly used ones now. This is the gradient boosting machine, also often denoted by XGBoost. And essentially what this one is that it can use a number of different models, but often they do use forests or trees, and they will run the data and model with equal weights. After they run it, they'll have a look at the output and see how well it performs, and then they'll reweigh the data. So they'll reweigh some of their connections. It's a little bit technical, so it's hard to explain simply. And then they'll run the data with the new weights. This is so all of these previous ones are what are called supervised learning models, and they're called supervised because we already know the outcome in the training data set, and so we've predefined these outcomes, and then we train the data to detect in new data, so in new samples, what those outcomes might be. But K-nearest neighbor and a number of other ones, they are unsupervised models, because essentially what this kind of model is doing is that it's looking at data that is unlabeled, and it's grouping individuals based on how they relate to one another. Now, the artificial neural network is a very interesting model, and essentially this one is really important to understand, because this is what many of the so convolutional neural networks is what most of their facial detection software uses. Artificial neural networks is also what a lot of the better prediction algorithms use. And essentially what it does is it has a number of different inputs. So, this might be age, sex, years of education, weight, and you will multiply whatever the value of that is into many different, using a weight, into many different radial basis functions. And what a radial basis function is, it might be that if it's negative, then you eliminate it. It might be that you times it by 2. It might be that you take the natural logarithm of it. It might be that you, do a linear regression of it. There's lots of different functions that you can do in these artificial networks. You will take the weights, and this is a shallow artificial neural network because it only has one layer. But often then you'll reweight all of these second layers into another layer, and then you'll run another radial basis function in that. You'll reweigh those into another layer and keep going until finally you get all of the outputs of the last layer. You reweigh them, and then you get a final output. I hope that made sense. But they have a complicated way of training these. One of the ways, at least that I learned, was called backpropagation, but that's kind of a whole other topic. So, where is the research at? Where have we seen this applied? How effective has it been? What has it shown? So this is one of the seminal studies that had been done to date. So this is done by Adam Chekroud. It was published in Lancet Psychiatry, I think, in 2016. And essentially what Chekroud et al. Did is they took the existing data from STAR-D, which had 4,000 people, and another clinical trial of antidepressants that had 150 individuals, and they were trying to predict remission of depression. So that was final score of less than 5 in the QIDS 16. They had 25 input variables. There was a combination of demographic data and clinical depressive questionnaires at baseline. And using this gradient booster machine in study, they achieved a prediction accuracy of 64%. And when validated in the escitalopram of COMED, they got in the kind of other one, an accuracy of 59%. So it was significant. It was better than chance. Although they didn't achieve an accuracy, they didn't achieve a significant result in the venlafaxine mirtazapine arm of COMED. Now, an accuracy of 64% in kind of predicting outcomes, that was very significant, mind you, doesn't necessarily sound all that good. It is very interesting that this paper was the basis of a company called Spring Health, that Adam Chekroud now runs that is worth $3.5 billion. And essentially they're a company that does AI-supported diagnostics and treatment of mental disorders. So it is a big industry, and there's a lot of interest in this. And Adam Chekroud is really trying to grow this. It's not clear how what in their company is based on this science in this study, and what is private, protected information. What is their own private product that they have copyrighted? This is another similar study that used the STAR-D trial, and they trained a whole family of machine learning models. So I can't remember exactly, but yeah, sorry, here we go. They used a random forest. So I-squared penalized random forest, gradient boosted decision tree, gradient boosted machine, and elastic net. So they used 4 different ones, and then they looked at what the consensus of those models were to decide whether or not someone would be a responder. And the accuracy for various antidepressants was between 64 and 71%. And when applied to an alternative data set, so of another antidepressant clinical trial, they found an accuracy of between 64 and 67%. So not bad. The AUCs are still not great, like 0.69 to 0.78, 0.60 to 0.73. Like, it's not something that you would really hang your hat on and say, this is something we're definitely going to go with. This is a more recent study. So this is a paper done in 2023. And if you haven't heard of this tool, I would highly recommend having a look at it, because it is phenomenal. So the Maudsley group, and this study was led by Toby Pillinger, but it's David Taylor and Alan Young, and so the guys who wrote the Maudsley guidelines, as well as some other really big names in psychiatry like Stefan Lucht and Christoph Corell. They have gone through and gotten all the individual participant data for almost every randomized clinical trial of antidepressants that has ever been done, as well as for schizophrenia. And what they've done is they've created a really fascinating machine learning model that allows you to log in there, put in each of your patient's individual characteristics, as well as which side effects you want to avoid and you're most worried about. And it will tell you which of the various antidepressants or antipsychotics, which are most and least likely to cause particular side effects. So it's a phenomenal tool. So it's free to use as long as you make a login. It's called Cymatic. So that is a useful application. One of the other advantages, so the previous studies that we looked at, aside from the Cymatic tool, they had 4,000, 5,000, these reasonably smallish sizes. But one of the other advantages with these machine learning algorithms is that they allow us to have a look at treatment dropout, and they allow us to have a look at larger retrospective cohorts, because we're not necessarily, we're very interested in looking at how people do in real world clinical samples. So in this 2020 study, they had 50,000 people this is electronic health record data. And they used 2 classifiers, so logistic regression and random forests, to try to predict discontinuation for 9 different antidepressants. And they use a couple of different variables, including age and sex, diagnostic codes, procedures, medication data available. And the main outcome was predicting medication discontinuation. And what they found was the models actually did pretty well. So they predicted discontinuation for the 9 medications on average of 0.69, which was modest. But for escitalopram, it had an AUC of 0.80, which is getting better. The worst prediction kind of outcome was for paroxetine with an AUC of 0.62. When they tested it in an external data set, it performed comparably. So AUCs of between 0.67 and 0.70. So this was a similar study that looked it looked at a retrospective sample. I'm pretty sure this is electronic health record data again of 81,000 individuals with a similar AUC of 0.63. So the problem with all this, though, is that none of them have tested the efficacy of their machine learning algorithms in to see whether or not they actually improve patient outcomes in a clinical trial setting. This is one of the few studies that has done that. So Michael Browning and Catherine Harmer are based in Oxford, the Department of Psychiatry there. And they, a couple of years ago, ran this PREDICT trial. It was a very interesting trial. Essentially what they did was they had an effective interpretation task where people would look at emotionally ambiguous faces at week 0 and week 1. And they thought that there was a hint of whether or not someone would respond to an antidepressant at week 4 based on their ability to interpret faces, so emotionally ambiguous faces at 1 week after starting the antidepressant. They use a support vector machine algorithm to predict symptom remission based on the response to those effective interpretation tasks. And based on that machine learning algorithm, there was a decision support tool that would suggest to GPs either keeping the medication, increasing the dose, or changing the medication. They had a predict arm, so people who had their decision support tool with their GP, and they had a no predict arm, so people who didn't have the decision support tool with their GP. And what they found was that there was people at week 8 had no significantly better depression scores at any point. But when they got to week 8, there were significant improvements in anxiety scores. And at week 24, there were better functional outcomes for those who'd been treated with the predict support and decision support tool. And that is an impressive outcome. So they didn't meet their primary outcome, but it is an impressive outcome given that the algorithm only had a balanced accuracy of 57%, showing that even when models are only modestly better than chance, it can still possibly improve outcomes. It was also impressive because the GPs only took the algorithm's recommendation in 65% of cases. So a lot of people just looked at it and said, no, that's a silly idea. I'm mindful of time. So these other studies really there are a couple of other points, and I'll send through these slides, but essentially they show that you can get things like EEG data. This is a very small study of 51 people that has tens of thousands of data points because you're having millisecond to millisecond data point input. And this one study was able to predict outcomes with an accuracy of 88%. Very small study though, and that used a random forest machine learning approach. And in this study, they used cognitive outcomes. So they used this computerized assessed cognitive function and socio-demographic data to try to predict depression remission. And again, they got a accuracy of 72%. So that's all very good. But what are the problems that we face? So obviously we have practical hurdles of getting accurate, scalable, inexpensive, acceptable, and comprehensible to clinician, algorithms that are comprehensible to clinicians and patients. We also need to know where we're going to be relative to other fields. So in radiology, the algorithms are routinely getting between AUC values between 0.86 and 0.94. In ICU, it's about 0.91. In psychiatry, we're still at 0.7. And I think we do have to accept we won't achieve the same predictive accuracies. But given the limited predictive capacity of our current disposal, even modestly accurate algorithms may improve overall patient outcomes. There has to be some degree of acceptability of these model inputs. So at the moment, a lot of the studies look at pretty simple model inputs like clinical or demographic data or cognitive data points that are scalable and inexpensive. But maybe to get better accuracies, we will need less acceptable, less available data points like structural and functional MRI, electrophysiology, or more comprehensive assessment. We really need. There was a review recently done of machine learning and psychotherapy, and they found that only 3 out of 51 studies externally validated their models. So it's a big problem that people have these cohorts that are sometimes smallish, and they overtrain their models, so it's overfitted, and so they're not generalizable and they're not particularly useful. But one of the big problems is that a lot of people are developing algorithms, and nobody actually gets their algorithm and puts it in a randomized control trial, because it's very hard to fund and it's expensive, and sees whether or not it makes a difference to patient outcomes. And that's really where we need to move. There's also, lots of different ethical questions, including what the burden of responsibility is. Who, if a decision support tool is used and it results in an adverse outcome, who's to blame? Like, is it the doctor? Is it the individual? Is it the company who made the decision support tool? If algorithms become better at predicting outcomes than clinicians, if we don't follow the model recommendations, could we be considered negligent for not following best practice? We know that machine learning requires huge amounts of data, concatenated, sensitive personal data about people's mental health. If there is a breach, then that information will be internally disseminated, and that is a massive problem. So there's problems with data privacy. So just to bring it all together, we know that machine learning and our AI algorithms are going to shape much of our day-to-day lives. Already, it's changing the face of medicine in places like radiology and ICU, and potentially we see it in the future changing things, as it being a decision-making support tool in psychiatry. We hope that it will be better at predicting outcomes than we are, but we still need testing in clinical trials and validation in external data sets. And important barriers to this path will be, having a more widespread clinical implementation, including a delineation of clinician machine responsibilities, and a kind of a setting of a firm line of clinical freedom, as well as patient data protection and security. Thank you.
Okay, thank you very much, Matt, for this excellent presentation. I think it's one very exciting topic. So I would like to ask the audience if there are any questions at this moment for Matt Lennon's presentation.
I'll see if there are any questions here on the floor. Any questions for Matt? No, we don't have anyone here. Jesus, is there anyone online?
Any students from the Department of Psychiatric AMC can also put on or unmute yourself and can ask the questions.
Yes. Well, for myself, Matt, perhaps I would like to ask you if you can make some brief comment on the last slides that, fortunately, perhaps due to time, were a little fast. You were talking about the dimensionality, and you referred to two concepts: cognitive testing and electrophysiology. Is it possible for you to make some further comment on those two slides?
Yeah, for sure. So, I mean, essentially, the problem that we have, if we just go back to randomized control trials, say we have a trial of 100 people, and we want to include lots of predictive variables to try to predict what in their like in terms of their outcomes, whether or not they'll be a responder or not a responder. Because we only have 99 degrees of freedom, we cannot have that many variables in the model, because it reduces our power, it reduces this statistical capacity. But that's because we're focused on inference. Whereas with the machine learning models, because we're focused much more on prediction, say we have an EEG measure and we're using QEEG, and we have a larger sample of a couple of hundred or a few thousand people, we can include many different EEG points. You can include you can input to the model in theory every millisecond EEG reading point for that individual over a 5-minute resting state EEG. Similarly, for cognitive measures, with cognition, often if we're inputting into a model, we're trying to use principal components analysis to reduce the number of dimensions and get it into like a single core concept. But with that, we're making it less granular. And so if we're thinking about these really large scale models that have a lot of data input, it can incorporate all of that complexity of the data by having, say, the 20 subtests or the 30 subtests in the cognitive assessment that we've included.
Okay.
Well, that's excellent. I wonder if there are no further questions from the audience, either virtually or from someone else. Perhaps we can go to the next presentation, right? By Hamilton Morin. We will go into the topic of brain-computer interface, which is another very exciting topic. So please, let's start with Hamilton Morin presentation.
Dr. Moran have sent his recorded
Hello,
presentation,
everyone.
so we will be
My
playing
name
the
is Hamilton
same.
Morin, and I am a Wellcome Doctoral Fellow at the King's College London Institute of Psychiatry, Psychology and Neuroscience, working in the Neuropsychiatry Research and Education Group with Drs. Tim Nicholson, Paul Shotbolt, and Professor Mark Edwards. And I am also a higher trainee working at the South London and Maudsley NHS Foundation Trust. Today I'll be talking to you a bit about the potential use of brain-computer interfaces to treat functional neurological disorder, FND. It looks like we have a pop-up. Whilst it is an oversimplified dualistic Cartesian term that we do tend to use to explain FND to patients, I like to joke that I am setting out to answer the question of whether we can use hardware to treat quote-unquote a software problem, with the latter term being no doubt familiar to those of you who have experience of working with individuals with FND. So, to start us off, I will be giving a bit of an explanation about brain-computer interfaces, or BCIs, and their applications, with the caveat that I am a clinician researcher, not an engineer. And I'll then talk a bit about FND and the evidence behind why BCIs might offer a suitable form of treatment in the disorder. I'll then present the results of our N of 1 feasibility case report using a closed-loop motor imagery rehearsal BCI to treat the patient with motor FND, before finishing by telling you a bit about my PhD project, the BRAVE FND study. But before we go any further, some of you in the room may be wondering, what on earth is a brain-computer interface, a BCI? Well, as it is the fashion these days, I asked ChatGPT to please generate an image of a neuropsychiatrist treating a patient using a brain-computer interface, and this is what it gave me. Now, I must say, the image generated is of a considerably higher quality compared to when I first gave a version of this talk in May of this year. You can see the patient is wearing some sort of cheap plastic 3D printed looking EEG array. I'm not entirely clear on what type of montage we'd be looking at here, given it appears slightly wonky and asymmetrical at points. And I have to say, I'm slightly uncomfortable with the proximity of the neuropsychiatrist's pen to the patient's face, as well as the noise she would no doubt be generating with her hand on the electrodes. Perhaps that's why he's keeping his eyes closed. In any case, the term brain-computer interface was coined in 1973 by UCLA computer scientist Jacques Vidal, and it is sometimes used interchangeably with the label brain-machine interface. So BCI refers to any device that measures brain signals, typically in the form of EEG or ECOG, and translates these signals into computer control commands in order to carry out a function, such as directing a computer mouse cursor, controlling a robotic limb, moving a wheelchair, or producing speech, for example. With closed-loop BCIs, there is then feedback to the brain, typically in sensory form, which in turn affects the brain's activity and continues the cycle. Broadly, BCIs can be broken down into two main categories: invasive or non-invasive. Invasive BCIs come in numerous shapes and sizes and are most often brain surface electrodes or brain-penetrating microelectrode arrays. Perhaps the most well-known example of an invasive BCI in the public eye, for a number of reasons, would be the Neuralink 1024 microelectrode array, which, as of this month, has been implanted in 12 individuals, a number of whom are quadriplegic secondary to spinal cord injury or with ALS. In the case of the first participant, the Neuralink microelectrode array was shown to allow this gentleman to play games on his computer ranging from chess to Age of Empires. Whilst this application of BCI technology to control a mouse cursor isn't particularly novel, what is impressive is his ability to be able to do this any time of day in non-laboratory conditions. BCIs can also be non-invasive, with non-invasive BCIs most commonly using EEG recordings, though approaches using FNIRs have also been studied. As you can imagine, this approach is more appropriate in certain populations in whom neurosurgical procedures may be contraindicated, including individuals with FND. Now, while the term invasive is used in the literature, this is very much a spectrum, and I should note that BCIs like the Synchron stentrode can be administered intravascularly and sit comfortably in the superior sagittal sinus. Now, there's a wide array of different potential applications of BCIs, and whilst I won't have time to go into them all, I thought I would mention a few. The first being the restoration of lost function through a neuroprosthesis. There's well over a decade's worth of work exploring the use of BCIs to control robotic limbs and exoskeletons, where typically imagined movements, i.e. mental motor imagery, mood wave activity over the sensory motor cortex, is decoded to allow for control of a robotic limb. Quite excitingly, there has been a lot of recent progress in the world of BCI speech neuroprostheses, with a New England Journal of Medicine paper from last year describing how in an individual with ALS and severe dysarthria who was unable to use a keyboard, they achieved 90.2% accuracy using a 125,000 word vocabulary on only the second day following surgery, and how this allowed them to communicate in self-paced conversations at a rate of approximately 32 words a minute. There's now several decades of work on BCIs for vision, from early trials of cortical microstimulation and retinal implants to more recent systems like the Argus-2 and high-density visual cortex arrays, which show that patterned electrical stimulation can reliably elicit phosphenes and even simple shapes or letters, supporting basic object recognition and navigation in blind individuals. More recent decoding work using fMRI and deep learning has gone in the other direction, reconstructing seen or imagined images from activity in the visual cortex, hinting at potential future bidirectional systems that both read from and write to the visual system. In hearing, cochlear implants are often cited as the most successful example of a neuroprosthetic BCI to date, converting sound into patterned stimulation of the auditory nerve and restoring functional speech perception to hundreds of thousands of people with severe to profound deafness worldwide. Experimental auditory brainstem and midbrain implants extend this approach to cases where the auditory nerve is absent or damaged, and emerging research on decoding imagined speech and inner auditory experiences suggests the possibility of future devices that combine restored hearing with direct brain-based communication for people who cannot speak. Closed-loop neurostimulation offers a nice approach for detecting brain states in real time and administering focal stimulation to target sites in order to rapidly terminate neurological symptoms. The NeuroPace responsive neurostimulation system was FDA approved in 2021 and measures epileptiform discharges to deliver targeted stimulation to known seizure origin sites. Depth leads are inserted into deep brain structures such as the hippocampus or amygdala and are commonly used for mesial temporal lobe epilepsy, whilst cortical strip leads are placed on the brain surface to target neocortical seizure foci. More recently, Medtronic received approval for their adaptive deep brain stimulation closed-loop BCI, which detects excessive beta band activity associated with Parkinson's symptoms of tremor and freezing of gait. It then stimulates deep brain regions such as the subthalamic nucleus or globus pallidus internus. By offering this targeted time-limited stimulation, this can reduce side effects of dyskinesia as well as cognitive and emotional side effects. In the realm of non-invasive BCIs, there is a whole body of research on the use of neurofeedback-based approaches as a form of brain training for children and young people with ADHD. It follows principles of operant conditioning, where individuals are expected to focus on a task and are exposed to a visual representation of their EEG, where they receive a reward for increased beta activity suggestive of a focus state, and no reward for theta activity suggestive of a non-focus state. Now, whilst I was reading into this application of BCIs, I happened across a news story from 2019 about a classroom in Jinhua City in the Zhejiang province, where US company BrainCo had rolled out a program to monitor EEG signals in a class of children, with a light changing color to red if children were not paying sufficient attention. Of course, the headset used had only 3 electrodes, so it's highly questionable whether they were measuring anything apart from temporalis muscle activity, and the photo tells us a lot about the positioning of these headsets. But the story ended interestingly in that the project was halted after parents complained about data being stored and sent to BrainCo without their consent. This brings me on to my next related anecdote, which is that, interestingly, in 2021, Chile became the first country to introduce a law protecting brain activity as well as the information from it. Neuroethicist Marcelo Ienca, who co-originated the idea of neuro rights in 2017, perhaps put it aptly when he said that brain information is probably the most intimate and private of all information. But coming back to BCI applications, perhaps the most studied clinical application of BCIs is that of their use for motor imagery rehearsal paradigms for rehabilitation in neurological disorders such as stroke and spinal cord injury. Despite there being a multitude of experimental studies and meta-analyses in stroke, to date there have been no studies exploring the use of BCIs for rehabilitation in functional neurological disorders. So what is functional neurological disorder, or FND? Well, for the sake of today, I will keep it brief, as I know many of you will be highly familiar with FND. But it refers to the presence of neurological symptoms such as weakness, seizures, or tremors in the absence of any structural lesion. It is incredibly prevalent, being the second most common reason for someone to visit a neurologist after a headache, and it is often, but not always, comorbid with mental health conditions such as anxiety and depression. Some of you may recognize the website on the left, neurosymptoms.org, which is an excellent resource for patients, clinicians, and members of the public on FND, run by Professors John Stone and Alan Carlson. Now, I alluded to this earlier, but a common model through which FND is often explained to patients is that of a software, not a hardware problem, i.e., it isn't a breakdown in the physical structure of the nervous system, but rather a mismatch in communication between the brain and the body, where, in the case of functional motor symptoms, there is a loss of sense of agency over movements, difficulty distinguishing between voluntary and involuntary actions. Taking this one step further, current conceptual models for FND, including the hierarchical Bayesian inference model of FND proposed by Professor Mark Edwards and Carl Friston, recognize the role of predictive processing errors contributing to generation of functional symptoms, where the brain's top-down sensory motor predictions override bottom-up sensory input, and the weighting of these prior beliefs can in turn be shifted by sensory experiences, with the classic example being that of a prolonged period of exhaustion from a viral illness leading to an extended post-viral fatigue. So why might BCIs be suitable for FND? Well, in their 2017 study, Nahab and colleagues looked at 20 patients with FND and 20 healthy controls. Participants underwent a virtual hand illusion behavioral experiment in VR, testing their sense of agency, feeling of control, over movements of a virtual hand that would or wouldn't follow their movements. Through functional neuroimaging, they found selective dysfunction of the self-agency neural network, whereby the dorsolateral prefrontal cortex and presupplementary motor area on the right did not respond differentially to the loss of movement control. There are also a number of studies looking at EEG markers such as contingent negative variation in FND. Contingent negative variation, or CNV, is a marker of motor preparedness that can be observed between a pre-cue and a cue to complete a motor task in healthy controls. In their papers, Teodoro and colleagues have demonstrated that CNV is reduced in motor FND at baseline, but increases following a course of physiotherapy. And of course, more recently, there have been a number of studies showing findings that perception and action integration is impaired in FND. So, our hypothesis is that perhaps by demonstrating to patients that movement is indeed possible through a course of BCI rehabilitation, might we be able to leverage plasticity to shift the weighting of overly precise prior beliefs, and therefore enhance sense of agency over bodily movements. So how are we looking to do this? Well, we are working with a BCI company, perhaps one of the most well-established BCI companies, GTAC, working with their Recoverix closed-loop BCI, which has been CE marked for neurorehabilitation and studied for use in stroke, Parkinson's disease, and MS. It's a simple 16-channel EEG setup, which detects motor imagery over C3 for right hand and C4 for left hand, as well as CZ for the contralateral foot, and it's possible to detect motor imagery from both hands or one hand and the contralateral foot. If you remember the motor homunculus and the close proximity of the two feet regions, you'll understand why, given the lack of spatial discrimination in EEG, it's not possible to compare laterality for both feet at the same time. And individuals are given auditory and visual cues for motor imagery rehearsal, and after this they have to imagine moving the hand or foot, and laterality of motor imagery is detected, and they receive visual feedback from non-screen virtual avatar that moves if they perform the motor imagery successfully, and they receive tactile feedback with functional electrical stimulation triggering real-world movement of the hand or foot with wrist extension or ankle dorsiflexion. So, how does this look in practice? Well, as mentioned, individuals see an on-screen visual cue, so they'll see an arrow appear pointing to one of the hands or feet, and they'll hear an auditory cue, right or left, to imagine limb movement for the next 8 seconds. Common spatial patterns are then identified, and linear discriminant analysis distinguishes between left and right motor imagery, mu wave, event-related desynchronizations and synchronizations. This online classification and control of the FES and avatar are updated every 25 milliseconds, and offline classification accuracy is estimated via a 10-fold cross-validation. And this refers to partitioning a sample of movements into 10 complementary subsets and validating the analysis on one subset called the validation set, and training the common spatial patterns and classifier on the other subsets. The accuracy of the motor imagery performance is detected, and if motor imagery is detected for the correct side, then the BCI triggers functional electrical stimulation, causing wrist extension or ankle dorsiflexion. And at the same time, they see an avatar perform that movement on screen, so they receive visual feedback. And after 8 seconds, they receive a cue to relax, and then the next cycle starts. So, as part of preliminary work exploring excitability, we were very fortunate to be able to conduct 10 BCI sessions with a patient who we'll call S, who had experienced left-sided functional motor weakness for over 6 years, and she had tried several forms of treatment in the past, including physiotherapy, talking therapies, and even some TMS. And as mentioned, the left-sided weakness was particularly mostly affecting the lower limb, more so than the upper limb. And she herself often fluctuated in the intensity of her symptoms. On some days, some visits she'd be able to mobilize with crutches, but on other occasions she would need to use a wheelchair. She herself noted that her symptoms were worse during periods of difficulty, citing difficulty during the COVID pandemic when she had to remain indoors during lockdown, and noting that at that time she really struggled, as well as unfortunately after the death of a friend, which led to her having a fall and a worsening of her difficulty with mobility. She was living with her ex-partner, who was also her main carer, and her daughter, who interestingly was a police cadet. And as I mentioned, she had had previous forms of treatment, CBT, physiotherapy, TMS, all of which she felt were helpful for a time, though unfortunately the benefits she experienced were not sustained. And she very kindly took part in 10 sessions of this non-invasive closed-loop motor imagery rehearsal rehabilitation using the RecoverX BCI. So I'll just play some short videos from some of our sessions. So this is from session 3. I want you to pay attention to her right hand and her left foot, as well as the screen.
Relax. Right.
She receives the cue to imagine right movement.
Relax.
There you can see the stimulation being delivered.
Right.
A small ball appears above the hand or foot,
Left.
and it's very subtle. We don't want the stimulation to be too strong, but there's a very gentle dorsiflexion of the left ankle.
Relax. Left.
And you can see just the
Relax.
toes kind of raising off the ground more.
Relax.
And this is from our 8th session.
Relax. Left.
And you can see, interestingly,
Relax.
even though the instructions are to not perform movement, just to imagine it, she said she found it helpful to
Relax.
try and use an approach she learned in neurovisual feedback therapy of rocking her right foot at the same time as when she was supposed to move her left foot. So she personally found that helpful. And I think what we've learned is clearly some of the approaches and protocols that are used in stroke and other populations, we might need to be a bit more flexible or open to some potential modifications based on the needs of the patient in front of us with FND. So the first thing to say is that S attended all 10 of the rehabilitation sessions, which is highly encouraging in terms of feasibility. Over the sessions, we noted there was a gradual increase in the accuracy of her motor imagery rehearsal, which started at 57% in session 1, went up to 70% in session 10. And similarly, there was also a mild increase in the explicit, so Likert scale, 5-point scale for report a sense of agency over movements of her left foot, which started at 1 in session 1 and then ended at 2, but at its peak was at 4 for 3 sessions. So, of course, this is an N of 1 case report, primarily doing initial work around acceptability, so we can't really say anything in the way of efficacy, but it's worth noting that the patient's short form of the functional movement disorder rating scale remained fairly steady, and though it dropped very slightly. What is of particular interest is that in the first session, she couldn't trigger any functional electrical stimulation of her limbs or movement of the avatar at all, which she found quite discouraging, until I informed her of the fact that I had also used the device, and I too couldn't get the avatar to move at all in my very first session, after which she felt encouraged and was willing to continue with the rest of the sessions. So data points are nice and all, but perhaps what was more encouraging for the patient was that after the 6th session, S showed us that she was able to, for the first time since her symptoms started, consciously flex and extend the toes of her left foot. This was maintained through to the final session. And thankfully this video is muted, because otherwise you'd hear me let out a yelp of excitement. But yes, she, whilst this wasn't an enormous change in terms of function, for her she took this as a positive sign of potential future improvement. And overall, her perception was that her symptoms had slightly improved, and she reported having had a very positive experience with the BCI therapy. Said she'd be open to future BCI-based treatments. And as mentioned, she said that she found the first time experience very overwhelming, that it started to get easier after the 3rd or 4th session. She found it helpful to have sessions or continuity of staff between sessions as helpful factors. And I thought this was an interesting choice of words, but 2 months later, when she was seen in an outpatient follow-up clinic, she said that the progress kicked her out of her depression. So what's next? So I am currently setting up, and in fact I've just received an NHS ethics approval for our BRAVE FND study, or Brain-Computer Interface Rehabilitation and Virtual Environments in FND. So for this pilot study, I will be recruiting and screening 24 individuals from the South London and Maudsley Neuropsychiatry Service, and at the start and at the end of the study, participants will undergo a VR-based assessment of their sense of agency over bodily movements. And between the 2 VR assessments, participants will undergo 10 motor imagery rehearsal rehabilitation sessions with the Recoverix BCI. And we'll be looking at a number of outcome measures, including outcome measures around mental health and function, motor symptom severity, sense of agency, both implicit neurophysiological markers and explicitly reported agency, and we'll be assessing acceptability through a semi-structured optional interview. So, in summary, as you can see, there has been considerable research to date on the applications of BCIs for neurological conditions. There has been some closed loop and attentional neuromodulation modulation neurofeedback work relevant to neuropsychiatric disorders in this space. Clearly there's potential for their use in FND, particularly in the context of functional motor symptoms through the motor imagery rehearsal with closed loop feedback paradigm, and our feasibility and acceptability trial is currently underway. So I'd just like to thank my supervisors, Drs. Paul Shotbolt, Tim Nicholson, and Professor Mark Edwards, and I'd like to thank some other collaborators, including the charity FND Hope. And if you would like to contact me, I'm very happy to answer any questions. My email is there. But otherwise, thank you very much for listening, and I hope you enjoy the rest of your conference.
Okay, so that was an excellent presentation on a very exciting topic, and I'm afraid Dr. Hamilton is not present at the moment to take any questions. But if someone from the audience wants to make any comment on the topic, now would be the moment to make those comments. So, anybody?
Hi, so
Okay.
I think using the BCI, especially in the rehabilitation, is jumping, gaining the leaps and bounds when we talk about the recovery process and how faster. So, we have our co-chair here, Dr. Sparsh Jaiswal. So he works with the spinal cord injury stimulation, the SCS, where the implant has been put. And so it's like brain, spine, computer interface. I just wanted to have a comment from him that what do you think that how the BCI and SCS makes a difference in the recovery when we look at the patients?
So actually, the recovery depends on how the patient's muscle power is. And what we do using these BCIs and SCS is we provide the pathway to the electric current or the brain inputs which are coming from brain to the periphery, like extremities for rehabilitation. So what we do is we just bypass the damaged area using these implants. These are generally invasive procedures in which they have electrical chips like 16, 17 from the same manufacturer, Medtronic. So what it does, it from the pre-damaged area, it picks up the signals, it amplifies that signals and send it to the post-damaged area. So brain perceives it as a complete feedback, and that's how we get results in the neuro rehab using BCI and the implantations. Thank you.
Thanks, Dr. Sparsh. Any other
Okay, so
questions?
excellent. Well, so I think that that would be all for this session, and I guess that we will move on with the program for the next session, which will be related to epilepsy and neuropsychiatric comorbidities and epilepsy in children as well. Is that correct? I think that the next chairperson is
It
Dr.
is.
Anthony David.
Yeah. We have to, he is express his inability to join. So we have Dr. Shrikant Srinivasan to chair the session along with Dr. Anusha. Yeah. But thank you, Dr. Diaz, joining us literally a midnight. I think it's 12:30 over there, AM.
Yes, exactly. I'm very sorry that I didn't
No,
present it immediately, but I'm very grateful for the opportunity to be here with you right now.
thank you.
Thanks,
Bye
Jesus. We
bye.
very much appreciate it. We might have to swap the speakers. I can see Helen is there.
Yeah.
I've just contacted Maria. She's a bit late.
Chairpersons, Dr. Anusha and Dr. Shrikant Srinivasan.
Yeah. No, that's fine. Just if Helen could, if it's okay with you, Helen, and if you could do the first session.
Sure. It is. There was a bit of confusion over time zones, so it may be that she thinks it's a bit later. So
Yes, I think that's what happened.
yeah. Okay. So thank you very much, and thank you for having me in this.
Sorry, Helen. Sorry, Helen. Just give us a few minutes. Just a
Okay.
couple of minutes.
All right.
Can I have the slides? Yeah, so to chair the next session, I have Dr. Shrikant Srinivasan, who is a senior consultant neurologist in Apollo Hospitals in Grims Road, Chennai. 30 years plus experience in general neurology and specialized care. He was a senior resident from NIMHANS, Bengaluru, neuropsychiatric training at St. George's Hospital and National Hospital Neurology and Neurosurgery, London. Dementia training, memory and aging, and University of California, San Francisco. So welcome, sir. Please join the table. And Anusha. Dr. Anusha, neurologist from Apollo Hospitals, and very keen observer. When you came to our OMR center about looking for the neurofeedback. So I like definitely we should be involving you in our dialogues on epilepsy. So our first speaker, can I have the introduction slides of Dr. Helen?
Good morning, everybody. So it's a pleasure to introduce Professor Helen Cross, who's a very widely known name in the field of epilepsy. She's currently the director of at the UCL Great Ormond Street Institute of Child Health. She's also the Prince of Wales Chair of Childhood Epilepsy at UCL London. And she's also the current president of the ILAE. She has innumerable publications, which are numbering 300 plus. The chief awards and recognitions that she has are the Order of the British Empire awarded in 2015, Lord Hastings Award in 2022 for epilepsy action, the Sidney Carter Award in 2017 from the American Academy of Neurology, and the Frank Ford Award in 2018 from the International Child Neurology Association. A tremendous lifetime work in child neurology. So we are all eagerly awaiting for inputs on child neurology and epilepsy. Over to you, Professor Cross.
Thank you very much. Just need to make sure. Great. I hope you can see my screen. So thank you very much for asking me to speak in this conference. 40 minutes on childhood epilepsy and the comorbidities is relatively limited, so I'm just going to give an overview, particularly in relation to the comorbidities that are seen in association with childhood onset epilepsy. So what I'm going to do is look a little bit at the new definitions, and particularly as there's been a change, and everyone sort of groans with regard to classification over the past 12 months. The role of the electroclinical syndrome diagnosis in childhood epilepsy, the increasing role of etiology. We'll talk a bit about the concept of developmental and epileptic encephalopathy, and then more broadly about neurobehavioral disorder in childhood epilepsy. So I don't probably need to indicate to this audience the prevalence of epilepsy. It's a common condition, but the problem that we have is that it's not a single condition. It is diagnosed clinically. It can therefore be difficult to diagnose, and we don't have a single treatment. And therefore, misdiagnosis rate is high, not only from a diagnosis of epilepsy, but the diagnosis with regard to type of epilepsy. If we look at the current definitions, they, of course, have not changed. An epileptic seizure is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And this, as per the definition that was put forward in 2005, and that's really sits where we are at the present time with how we define it. Epilepsy, of course, is defined by at least 2 unprovoked seizures more than 24 hours apart. But in the more recent 2014 operational definition, there was a slight expansion of that, not least because we may wish to consider a diagnosis where there has been 1 seizure and a probability of, or very high probability for further seizures, as indicated by perhaps the underlying cause or indeed the syndrome. Whether we talk about the seizure type, which of course is really useful for trying to classify the epilepsy, is really important. And we had in 2010, originally it was put forward the definitions of the type of seizure, although in 2017, as I'll come to, we classified the different seizure types more clearly. So generalized seizures, a lot of debate about whether they really are generalized, but the way the definition comes across is they originate at some point and originate at some point within and rapidly engage bilaterally distributed networks, which could include cortical and subcortical structures, but not necessarily the entire cortex. And then we have focal seizures, which of course originate within networks limited to one hemisphere, which of course may be discretely localized or more widely distributed. So having defined the 2 broad types of seizure, it was then realized that perhaps we really needed to look at the different types of seizure and also look more broadly at where this sits within the classification. So these are two papers that came out in 2017. The original, on the right, the description of all the different seizure types, and on the left, the overall classification framework, which I will come to, and the reason why it's so helpful with regard particularly to childhood onset epilepsies. So in 2017, this is the basic version of the classification of seizures. And we talk about focal onset, generalized onset, and unknown onset. And then at that time, we were talking about, with regard to focal onset seizures, whether they were aware or impaired awareness. So whether awareness was retained. And of course, also whether they were motor or non-motor onset. We also had a change in when we were talking about distribution of the seizure in looking at focal to bilateral tonic-clonic seizures to replace those terms secondary and secondary generalized. And of course, there was a much more expanded version and indeed a glossary to describe all the different seizure types, both focal generalized. And then, of course, we have the unknown onset, and those were unclassified. But after this was published, there was a lot of discussion as to whether this was applicable in all circumstances. The International League Against Epilepsy, the global organization for professionals, all professionals involved in the care of those with epilepsy, had put forward the classification system. And essentially, this needs to be broadly applicable in all circumstances, and hence why we have the basic version and then the more detailed version for use more broadly in a more detailed setting. But that said, there was a lot of concern, not least about the term awareness, because in translation to many languages, the words awareness, consciousness are the same term, and the nuances around that are not really recognized. And the second aspect was the surgical community, who felt that their requirements for different descriptors had not been incorporated into the more detailed classification. So in the last term, or the most recent term of the International League Against Epilepsy, and further task force was put forward to look at this in more detail, and acknowledging we didn't want to make major changes because it was only 2017 that the classification was indeed published. But an update was published in May of this year, where the term awareness with regard to focal seizures was changed to consciousness, whether preserved or impaired. The terms for the seizures came away from focal onset, generalized onset to focal and generalized, really being described all the way through as what each component was of the seizure. And that focal seizures were really described according to their descriptors, so that this could be expanded and utilized also to describe this, to make sure that the semiology was described and more about the focality of where the seizures were coming from could indeed be determined. And so the basic version hasn't really changed enormously, apart from the fact that we have focal and generalized, and then we have the consciousness preserved or impaired, focal to bilateral tonic-clonic as before, and then ongoing to describe the focal seizures according to descriptors. And then in a more expanded version to describe the different types, particularly within the generalized seizures, with terminology that had been used in the previous iteration of the classification. So acknowledging that seizures are predominantly diagnosed on a clinical basis, just to highlight that investigation, of course, is important. The EEG will, of course, give us some clues as to the type of epilepsy, but it's unlikely to be diagnostic with regard to epileptic seizures unless we actually record an event. And then, of course, investigation is really relevant when trying to determine a cause of the epilepsy, whether it be the MRI, to give us an indication of the structure of the brain, the genetic evaluation, or indeed metabolic evaluation. And why have I highlighted this? Well, this is the classification framework that was put forward in 2017, where, of course, we emphasize the seizure types for the first stage of the diagnosis. We then go on to the epilepsy type, and where possible, we look at the epilepsy syndrome. And this is particularly relevant with childhood onset epilepsies, although, of course, children grow up. And even and those who've had epilepsy since childhood, we're trying to determine whether indeed they have an epilepsy syndrome. But of course, within this framework, it's been really pushed that, of course, the comorbidities that we see alongside the epilepsies are integral to the condition. They are not a side effect of the condition. And of course, we're looking increasingly at the underlying cause, as outlined on the right, whatever the category. The cause we recognize as a cause of both the seizures, but of course also the underlying comorbidities that we see. And this just to highlight the different types. Of course, there are a wide range of different structural causes of the epilepsies, whether it be generalized as seen on the left, on top left, the lissencephaly, or more localized as seen on the top right, or indeed on the bottom right, something like tuberous sclerosis. And of course, there is often the consternation of when we're looking at the underlying cause, we think about tuberous sclerosis being structural, but of course it's also genetic. And another metabolic disorder, GLUT1 deficiency. Of course, we now know increasingly the metabolic defects are genetic, as well as being metabolic. And as I've said, thereafter, on deciding whether we have an underlying cause, we may look at the seizure type and ultimately the seizure syndrome. And the epilepsy syndromes are something that we've not to date had, until very recently, had not had an official classification of those syndromes, in the sense that they had been reported, there was widely described the different criteria, but there was no official description of what may be included with regard to criteria to describe an epilepsy syndrome. So in 2010 and subsequently 17, the definition of a syndrome had indeed been put forward, not least that it's a group of clinical entities that are reliably identified by a cluster of electroclinical characteristics. Patients whose epilepsy does not fit the criteria for a specific syndrome can be described with respect to a variety of clinically relevant factors. And it was in the 2022 position papers that were put forward after a full evaluation over the term 2017 to 2021 by the Nosology Task Force. Groups were formed to look at all the individual syndromes and come up with looking at the literature for a literature search, coming through with what were likely criteria, and thereafter having a Delphi consensus with regard to this for each individual syndrome. A series of 5 papers were produced. The paper with a methodology described and also a summary of all the syndromes, but then 4 further papers, one with onset for epilepsy's onset in neonates and infants, one for epilepsy's onset in early childhood, a further one about epilepsies of onset of variable age, and then ultimately the idiopathic generalized epilepsies. It recognized that there was a group of 4 syndromes: childhood absence, juvenile absence, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone, that required specific description and indeed a specific discussion. So if we look at those epilepsy syndromes that are onset in childhood, these are this is a summary, not obviously exhaustive, of the more common syndromes, ranging from now what we call early infantile developmental and epileptic encephalopathy, which encompasses a group of previously described syndromes, and then ranging, of course, ultimately to Dravet, Lennox-Gastaut, although we have also the self-limited epilepsies, such as self-limited epilepsy with autonomic seizures and self-limited epilepsy with centrotemporal spikes. For each syndrome, and I'm not going to go through each individual syndrome, there is a table, and this looks at the mandatory features for the syndrome to be diagnosed, as on the left. On the right, exclusionary criteria. So if those features are present in the syndrome, then this syndrome is not going to be the diagnosis. And then something that are called alerts, which are in the middle, which means if they're present or absent, as described, then we should really think again about whether this is in the syndrome. It's not exclusionary for the syndrome, but is unusual, and we need to think about it. And this table just summarizes what has been described for the self-limited epilepsy with central temporal spikes, what we previously called Rolandic epilepsy. And you can see that mandatory focal seizures with dysarthria, cylia, dysphasia, and unilateral clonic or tonic-clonic movement of the mouth in wakefulness or sleep, and or nocturnal focal to bilateral tonic-clonic seizures in sleep only, with the EEG mandatory features of centrotemporal biphasic epileptiform abnormalities and the mandatory course of the illness, remission by mid to late adolescence, where, of course, exclusionary criteria are an early age of onset or a later age of onset, amongst other features. There are new concepts, not least that we now refer to self-limited epilepsies rather than benign epilepsies. The term epileptic encephalopathy, of course, is not new. This was has been around a long time, not least since Gastaut originally described it within his population that we now know as Lennox-Gastaut syndrome, where epileptic activity itself contributes to severe cognitive and behavioral impairments above and beyond what might be expected from the underlying pathology alone. In 2010, this was recognized not as a condition, but as a concept that could actually be applied to all epilepsies, albeit the fact that in some individuals more prone to it than in others. But there is a slight issue with this in the fact that although it clearly states that it's where the activity contributes to impairments above and beyond what might be expected from the underlying pathology alone, there is still the perception that if we actually just get rid of the epileptic activity, everything will be fine, which is not the case in particularly many of the early onset epilepsies. So in 2017 and subsequently reiterated in the 2022 papers, the term developmental and epileptic encephalopathy was put forward to describe where both the underlying cause and the epileptiform activity are having an impact on the neurodevelopmental, ongoing neurodevelopmental progress and outcome. And there are a group of disorders, particularly of early onset, that we describe as the developmental and epileptic encephalopathies. This is taken from a review paper last year, but just highlights the different syndromes that we class as developmental and epileptic encephalopathies, and the fact that you can see that the majority of them have an age age of onset in early childhood. And the issue is here that they may be genetic or indeed structural in their cause, or indeed ultimately autoimmune. There are a lot of commonalities to the developmental and epileptic encephalopathies, albeit that there are some really distinct syndromes. And seizures may not, of course, are prominent in their presentation and are prominent in the ongoing issues for the family and the child. But essentially, there are a range of other comorbidities that are seen across this group of patients, not least their neurodevelopmental and neurobehavioral problems, but also motor disorder, feeding and gut disorders, sleep disorder, to name but a few. And although, of course, we've classically called these comorbidities, increasingly, we need to recognize that they are integral to the overall condition. With the genomic era, of course, there has been an absolute explosion of us understanding monogenic causes of the epilepsy. And in this most recent gene creation paper produced 2 years ago, to look at all the different genes that have been mentioned and determined to be responsible for monogenic epilepsy, you can see here that even at that stage, it was in excess of 900, and indeed that is rapidly rising. And as can be seen from the charts on the bottom, you can see that the developmental and epileptic encephalopathies form a large part of those where a gene has been determined to be pathogenic and causal. And why does this matter? Well, it's giving us an increased understanding of the underlying pathophysiology of these conditions, as we recognize what these genes code for, and indeed the different pathways for what they code for. And so we're able to look and see, really get to an understanding of the underlying pathophysiology and how we may move forward with treatment, whether that be the channelopathies, which of course been the most common that have been described to date, but also now increasingly the synaptopathies, also genes responsible for cell signaling metabolism, and this includes, of course, the mTOR pathway, and ultimately we've been looking at epigenetic regulation. But the developmental and epileptic encephalopathies are not only genetic in our etiology, and structural lesions can also, particularly in early childhood, cause DEE. The most classic probably is that associated with hypothalamic hamartoma, where they present with gelastic seizures. But then they may and often evolve to develop multiple seizure types, and ultimately also associated morbidities, including psychiatric disorders, rage attacks, and neurodevelopmental problems. And we know that only abolition of the hamartoma, whether that's surgically resected, disconnected, or indeed ablated through thermocoagulation or indeed laser therapy, is the only way that seizures can be ceased, and ultimately perhaps the multimorbidities prevented if we undertake this early. But other lesions can also cause developmental and epileptic encephalopathy. Here, a focal glioneuronal tumor of the right temporal lobe presenting in a child with seizures at the age of 14 months with atonic attacks, and indeed an EEG that is non-lateralizing and indeed quite encephalopathic. This boy going on to receive surgery and indeed with an ultimate cure of his epilepsy. And here, a boy presenting with asymmetric infantile spasms at 4 months, responding to initial medical treatment, but seen to have a focal cortical dysplasia in the right posterior region, and ultimately going on to develop focal onset seizures, cognitive problems, but with some degree of resolution with surgical resection. So with the increasing recognition of the etiologies and indeed distinct phenotypes as an association with those etiologies, we are also moving to etiology-specific syndromes. And such examples will be genetics, such as the phenotypes associated with CDKL5, developmental and epileptic encephalopathy, and PCADH19, clustering epilepsy, but also in association with structural lesions, such as mesial temporal lobe epilepsy with hippocampal sclerosis and gelastic seizures with hypothalamic hamartoma. And by recognizing these distinct phenotypes in association with these etiology, it means that we should be able to have earlier recognition in the future. And with the work of the current nosology task force of the ILAE is to describe those that we have in detail, where we really recognize specific phenotypes in association with etiologies. There are etiology-specific syndromes described in the original 2022 papers, predominantly with onset in neonates and infancy, but there are an increasing range being described and definitions produced in detail. So just to summarize this part, just to show that developmental and epileptic encephalopathies, for which we have not only the seizures, but the other range of comorbidities, is an umbrella term for which there may be further definition of syndromes below that, whether it be an electroclinical syndrome based on the seizure type and the EEG, or etiology specific, or indeed both, as in some individuals we may have both an electroclinical syndrome and an etiology specific syndrome. And you can then ask, why does this matter? Well, it has high relevance with regard to how we move forward in treatment, particularly as we get an understanding of the underlying cause and pathophysiology. It also provides an answer for families as to why the epilepsies occurred. It's likely to give us a natural history and prognosis that we should expect. We can then, if we know what the underlying cause is, we can give appropriate genetic counselling. And as I've mentioned, we can think about treatment and management. How do we move forward, and how does this influence our management of these patients? And there's no doubt, and again, I can't go into full detail, that precision diagnosis and gaining more of an understanding of the underlying pathophysiology is really changing our way of thinking, particularly with these early onset developmental and epileptic encephalopathies, as to how we move forward with treatment, recognizing that with our standard anti-seizure medication, many of them remain resistant, particularly with regard to seizures, and with no real impact on their outcome with regard to their neurodevelopmental and neurobehavioral outcome, that we really, perhaps if we can tackle the underlying cause, we can tackle both the seizures and other outcomes as well. And this may be etiology targeted, such as supplementation, such as vitamin B6 in the B6 dependent epilepsies, or indeed genetic therapies that are increasingly now becoming proposed and evaluated, but also the pathophysiology targeted repurposing of medication, such as in the channelopathies, where we might have a loss of function sodium channel mutation. We can avoid sodium channel blockers where we have a gain of function sodium channel mutation. We may utilize sodium channel blockers. And then, of course, the genetic pathways, such as in tuberous sclerosis and the mTOR pathway. And does it make a difference? Well, we can think about surgery being a targeted treatment. And we know that the shorter duration of epilepsy is the most strongest predictor of a good outcome, regardless of whether we're looking at pathology, the age of onset, age of surgery, or indeed location. And indeed, what has been determined, and this is work from our own unit, is that if we look in the longer term with regard to cognitive outcome following resective surgery, this graph on the right shows these, and the green are children who before surgery and after surgery having cognitive evaluation who are seizure-free, and the red who are not seizure-free. And you can see that in the longer term, we do have neurodevelopmental gains if they're seizure-free. But what the bottom chart shows, the green is seizure-free on no medication, the yellow seizure-free on medication. And so we think our medication is blameless, but in the longer term, if we achieve real cure with no seizures and off medication, we can see improvements in neurodevelopmental outcome. And this just gives an overview, albeit limited if we think about the 900 genes that we have responsible for the monogenic epilepsies, but it's increasing, looking at targeted treatments and particularly repurposing some medications in the treatments of the epilepsies associated with certain gene variants. And we can see here the long-standing knowledge about, for example, GLUT1 deficiency, utilizing the ketogenic diet, where we provide ketones as an alternative fuel for the brain. But others such as 4-aminopyridine, this has been long utilized for spasticity, but known that it could be a treatment for KCNA2, gain of function, potassium channel mutations, and then of course TSC, tuberous sclerosis, the increasing use of mTOR inhibitors. But we don't forget about the underlying electroclinical syndrome. And just to emphasize, this boy presented at the age of 10 months with focal seizures, increasing frequency into clusters and evolving into other seizure types, including what were described as recurrent jerks and more prolonged stiffening episodes from sleep. They came to us because they originally determined that he had a gain-of-function SCN2A mutation, but actually had not responded optimally to sodium channel blockers. And they were questioning, where should we go next? His EEG showed slow spike and wave with paroxysmal fast activity and sleep associated with stiffening episodes. And we could give the overall diagnosis of a Lennox-Gastaut syndrome, which had previously not been considered because the pathology had been pursued. And of course, this opened up a new other options that had not previously been thought of. If we look at the algorithm as to what can be utilized in Lennox-Gastaut syndrome, there's still a role for the electroclinical syndrome diagnosis as well as the underlying etiology diagnosis. And moving forward, and knowing that we're not going to have repurposed medication for all our different genetic etiologies in the short term, we really still need to continue to evolve and evaluate our medications more broadly. And so it was felt that we really needed an operational definition of developmental and epileptic encephalopathy which is the key features are described here, where there's frequent seizures showing frequent, and EEG showing frequent epileptiform discharges, history of developmental slowing or regression, and the underlying etiology also contributing developmental impairment. But just lastly, even though we have a group of disorders where the comorbidities are really prevalent, if we look at epilepsy in childhood as a whole, of course, psychiatric disorder is relatively prevalent. And this study, albeit undertaken quite some time ago, was a very large study undertaken in the UK, the British Child and Adolescent Mental Health Service survey, utilising the Strength and Difficulties questionnaire. And this extracted the results with regard to epilepsy as compared to diabetes, another chronic condition, and indeed the whole population. And you can see that looking at those with any psychiatric disorder, certainly diabetes was in with the same as in all the other general population. But for epilepsy, even what was described as pure epilepsy, no associated other problems, 26%, 3 times the rate of psychiatric disorder that was seen in diabetes or indeed the rest of the population. And epilepsy plus, where there were other features, then 56%, so almost 6 times that seen in diabetes and other. And you can see the range of issue. Of course, there was a higher percentage of severe learning difficulty in the epilepsy plus, but not seen in the pure epilepsy, and a range of different problems seen. There has often been a discussion about whether neurobehavior in epilepsy is being caused by the epilepsy or has been part of the underlying disorder, or indeed as a consequence. And there are several studies that have demonstrated that the neurobehavioral problems, even amongst what we might describe as idiopathic epilepsies, are seen prior to the onset of indeed the epilepsy, indicating that it's perhaps integral to the disorder rather than necessarily a consequence. We've undertaken 2 studies looking at the prevalence and indeed spectrum of difficulties in active epilepsy in school-aged children, and indeed, as I'll come to, in preschool children. And in this study, this was looked at looking at all children with active epilepsy in a clearly defined geographic area, a county in the south of England, Sussex. And this is where our team evaluated all children with a diagnosis of epilepsy with regard to their cognition, their academic achievement, and their behaviour. And they were able to review 74% of the eligible population, and also give a DSM-4 consensus clinical diagnosis where it was apparent. And the main findings are that there were a fair percentage who had significant difficulties. And what was clear was actually 80% had at least one DSM-4 diagnosis and or cognitive impairment. And many of them, as I'll come to, actually were undiagnosed. Only 33% of those with a DSM-4 behaviour or motor disorder had previously been diagnosed. With regard to cognition, a quarter had an IQ below 50, and with regard to behaviour and psychiatric disorder, 34% had an IQ below 85 and 1 or more DSM-4 disorders. And this again gives the range, and the blue bars are those that were previously diagnosed, and those in the red that met DSM-4 criteria, and the green is the general population. So you can see that the rates of disorder, and particularly with regard to ASD, ADHD, and DCD, were relatively high, and also in many unrecognised previously. And the way, as we all know, to gaining appropriate intervention is for such problems to be recognised in the first place. We then went on to look at preschool children, and not surprisingly, I suppose, and what we looked at here was not only at the group of preschool children, but also looked at them in comparison to a gender and age-matched group of children with neurodisability and no epilepsy. And we also looked not only at the children, but also the parents with regard to depression, anxiety, stress, sleep, and maternal parenting stress, which were notably high, particularly in the mothers, although I'm not reporting that here. But this just gives the overall summary with regard to child development and the epilepsy and the neurodevelopment group, that there were only around 42% who had no significant delay. But you can see that actually those with a more severe learning issue at this age group already with a diagnosis of epilepsy was relatively high. And this just giving the range of what was described as autistic spectrum disorder and ADHD in relevant whether it was the epilepsy group or the neurodisability group, and seeing that they were actually comparable. So in summary, it's a whistle-stop tour of childhood onset epilepsies, but not just to highlight that classification is important because it allows a common language amongst clinicians and researchers. And yes, it is constantly in evolution because of the new techniques that we now have available to make diagnosis. But we also recognize that we need to leave appropriate periods of time before this is rediscussed, and we won't be classifying in the near future. Further progress in imaging and genomic discovery have given us an increased understanding of pathophysiology, and we are really moving forward with looking how we treat particularly these early onset complex epilepsies. And the early diagnosis of electroclinical syndrome and etiology not only allows us to consider management, but also gives us appropriate information for the families. Rates of neurobehavioral disorder in childhood epilepsy, however, overall are high, warranting early assessment and intervention. And something that we're trying to move towards in the UK is that intervention, although recognition of resource limitation is there. Thank you very much.
Thank you, Professor Cross. That was a masterful overview of childhood epilepsy with the focus on developmental epileptic encephalopathies. Do we have time for questions? Or yeah, a couple of questions. Are there any?
Can you share your experience on forced normalization in children with epilepsy?
Sure.
Yeah.
I think it's something that, okay, so there's no doubt that we can see changes in behavior in different times of individual children. Some children appear to have behavior exacerbation at times when their seizures are prevalent. Others seem to have behavior exacerbation where their seizures are improved. And therefore, and some children, the parents recognize that they're building up with their behavior when they have a period seizure-free, and they almost need a seizure to, in fact, break that. Proving forced normalization, as the case may be, is more difficult. There's no doubt I have seen it in isolated children where we've had a sudden improvement in seizure and EEG in relation to a medication, but it has been isolated cases. So I think, you know, there's so much complexity with regard to behavior, whether it's, you know, the interaction between the medication, between the seizures, the underlying cause itself. Although we need to be aware that a sudden improvement in seizures may cause almost an awakening of the child. And it's something we actually also see in surgery. Their behavior may deteriorate immediately after surgery as they almost wake up, and their behavior needs to be managed and appropriately intervened with. So you know, to say it's definitely forced normalization is more difficult, but there's a real complex interplay amongst all these things.
Thank you.
The hand mic, please.
Yeah, thank you for the wonderful presentation, ma'am. I would like to know epigenetics in epilepsy, the role of environmental factors. Do you think that is it influencing the present issues? What you have seen in your experience when you started your practice and now, is there epigenetics as a role in epilepsy? Because autism, they say it's there. And what is your opinion on that? Thank you.
And I think that we have to think that there is a variability and a heterogeneity to some of the conditions we see with regard to their genetics and their presentation. I know, when we look at epigenetics, do we think about the impact on methylation, for example, or are we thinking more broadly about environmental factors having an impact on the ongoing presentation? I think there's certainly some information with regard to methylation that, changes in methylation may cause some of the comorbidities, and can we reverse some of that? And there's some studies, not least in ketogenic diet, that have demonstrated that. But I think more work needs to go on. And I think the issue is the degree of heterogeneity that we see. We feel that some degree of that may be the relation to epigenetics.
Thank you. I think that's all with the questions. Thank you very much for your presentation. Much appreciated.
So I invite the next speaker, Dr. Mariah Otto, to talk on epilepsy and neuropsychiatry. If we can have her credentials.
See them? Can you see them?
Yeah. So introducing her, she's a consultant neurosurgeon at Apollo Specialty, Chennai. Sorry,
I think it got.
there's a mistake here, I guess. Yeah. So she's the head of the Scottish.
Okay, the second
Yeah.
lines are okay. Well, show the slide. I
Share
think
her
the
slide.
second one is okay. Yeah.
So yes, yeah. So she's the head of the Scottish Epilepsy Centre and the lead clinician for NHS, and the chair of the Epilepsy Working Group and Scottish representative for the neuropsychiatry faculty, and also the ILAE UK Council member. So over to you, ma'am.
Do you have my slides? Yes.
You can share from your end.
Yeah. Is that it? Have it? Can you see it?
Yeah, we
Yeah.
can see it.
Yeah, perfect. First of all, I just want to thank Helen Cross very, very much, because I got the times totally mixed up. So I literally just jump out of bed when Jas texted me. So thank you, Helen, very much for stepping in before. And actually probably it's worked out quite well, because it's been quite logical, her presentation just before mine. So what I'm proposing for this session is to talk about the neurobehavioral comorbidities of epilepsy, and actually Professor Cross' presentation is just kind of, given the perfect kind of introduction. Let me see if I can. Right. So again, just as a, to set the scene a little bit, and probably mentioned that we know that epilepsy is a common neurological disorder, a disease of the brain. The incidence, and this comes from a meta-analysis of kind of incidence and prevalence around the world, that came with a 61.4% per 100,000. What we know is that epilepsy affects about 50 million worldwide, and most of these people would be in low-income or developing countries. When you look at both epilepsy and compare with the general population, the group of patients with epilepsy face more serious health adverse events. They are higher risk of premature death, in general, a worse quality of life, and there's also the issue of stigma, which hopefully this is improving, but it's still a big deal, particularly in some countries. As Professor Cross has said, the International League of Epilepsy, which is this global organization which for clinicians and scientists focusing on epilepsy, has now recognized that the cognitive, neurobehavioral, psychological, psychiatric complications or comorbidities of epilepsy are almost integral to someone having epilepsy, and this has been incorporated in the definition. And I would say maybe 10 or 15 years ago, when you went to a conference or to an epilepsy a course, this was kind of on the kind of very much, you know, an anecdote, whereas now this is recognized and as a major issue that needs to be addressed and recognized. So again, Helen's shown this. The emphasis I'm going to put in there is this: you can see at the side, you've got the comorbidities, and this is part now, integral part of a classification of epilepsy, something that you need to take into account. So the main, you know, we class or separate the neurobehavioral comorbidities in terms of social and adaptive behaviors, cognitive problems, which are a major source of concern and distress for people with epilepsy, and psychiatric comorbidities, which are no doubt overrepresented in this group. I will particularly focus on the psychiatric comorbidities, but I will also briefly talk about the social, adaptive, and cognitive problems, which are very relevant. So the mechanisms and psychosocial effects, and if you think about it, if any of you have done any epilepsy clinics or work with people with epilepsy, you'd be found this very familiar, this sense of the unpredictability of seizures, this idea that I don't know when or if I'm going to have another seizure, and that means that you can't relax, that this, you know, you need to be thinking about what am I going to do next, and this sense of not having control, which is, you know, there all the time and very stressful in itself, and means that you know what people would say is I have to plan my life according to this. Fear of seizures. Seizures can be, you know, people can have injuries through seizures. Seizures can be very unpleasant themselves. And you would certainly see people who are very fearful of their own seizures, that very unpleasant experiences or the thought of the consequences. And then you get all this avoidance or trying to minimize the consequences of having seizures. And again, if you talk to enough people with epilepsy, a recurrent theme is this theme of being a burden, being dependent, not being able to do anything on my own, always having to have someone with me. Again, this is there all the time, a big burden for someone who has to live with that, particularly someone with active epilepsy. We know that people with epilepsy are less likely to be employed, that they're more likely to be single, that they achieve less academically. So in general, there's this sense of kind of disadvantage, and also the stigma, which is perceived that people are embarrassed. I mean, people would say that if they've got diabetes, but people very rarely volunteer to say, I've got epilepsy. So all of this, as you can imagine, has a huge impact in someone's day-to-day life. So cognitive deficits in people with epilepsy, and here be very general. I'm just giving you a flavor of what it is. So cognitive deficits affect about 70 to 80% of people with chronic epilepsy. And if you ask people with epilepsy, almost 75% would say their memory is poor, although many of these people, when you actually with just standard test measure their memory, it is often within normal limits. As Professor Cross has said, that in children we know that there is evidence of cognitive deficits even before the epilepsy start or onset, but there is now some data in adults where measuring their kind of cognitive deficits or cognitive difficulties at the time of onset, even before they're treated for epilepsy. So not taking into account the effects of medication, there's already evidence of some cognitive deficits. This, certainly in adults, is multifactorial. Medication is a big is a big factor, so particularly in people with drug-resistant epilepsy, which tend to be in polypharmacy. Seizure frequency is another factor, psychiatric comorbidities, or structural brain lesions. All these factors would kind of influence these cognitive difficulties. In terms of the poor outcomes, in terms of the longer term cognition, so early onset of seizures, longer duration of epilepsy and frequent seizures, all of this would result in a poorer cognitive outcome. And presentations, and again, I'm being very schematic here, but just to give you a flavour, so slow processing speed, so these people who are just kind of slow and this is very much related to the sedation of medication. This is very clear also in certain drugs, but also in polypharmacy. In temporal lobe epilepsy, which is the most common epilepsy in adults, certainly in the UK, encoding and consolidation of information would be the most common problem. But working memory and attention affect people with most types of epilepsy. So we've now got the feel for all the social difficulties, cognitive deficit. So already, you have an idea that this is a chronic illness with a big burden socially, cognitively, and now I'm going to kind of expand on the psychiatric comorbidities. So there is no doubt that psychiatric comorbidities are overrepresented in people with epilepsy, and Professor Cross has showed that in children. This applies to adults as well. And when compared, there's a big kind of community study and a population study in the UK looking at people with epilepsy and comparing with people with without epilepsy in terms of the odds ratios of having psychiatric conditions. Social and agoraphobia, anxiety and depression were far higher when compared with the general population. The kind of peculiarity about epilepsy when we talk about psychiatry is that we classify the psychiatric or the changes in mental state or the psychiatric presentations according to the relationship to seizures. So we would talk about interictal, means in between seizures, and that means that your psychiatric condition, the depression, for example, has no relationship with seizures. So you're as depressed whether you had a seizure or not, or you are as psychotic whether you had a seizure or not. And then we talk about periictal. These are changes of mental state around the actual seizure. So preictal, just before. Ictal, which I'll talk about it, is just an ictal is a seizure, postictal changes right after the seizure. So in terms of preictal, and again, if any of you have worked with or done epilepsy clinics, you'd find that familiar and recognize that, because the carers, the family usually mention this. Is this a cluster of symptoms that sometimes is days or hours before a seizure? That does not translate to an EEG change, but is most likely related to the epilepsy. And usually the most common, what you see is a behavioral, often irritability, agitation, very marked, much very clearly in patients with learning disabilities or people with learning disabilities. The carers would say, we can tell they were building into a seizure. They need a seizure to clear the air. And then we talk about ictal. Here I want to stress very much that ictal is not, we're not talking about psychiatric, is a seizure that as a manifestation, the symptoms may look like psychiatric. And in fact, it's not unusual to get patients sent to my clinic or my center saying, oh, they seem to be having panic attacks, or they're very anxious, or they're having these unusual ideas that is this psychosis. And these are just the seizures themselves. So ictal change is a direct expression of a seizure. So the way to distinguish from what it would be a change of mental state or your mental state in general, this is an abrupt onset. Out of the blue, someone suddenly is sitting down, relaxing, and it just gets this intense, sudden feeling of fear, their heart's pounding, and they just don't know what's coming from. Short duration, that's the other key. Seizures are short. Seizures don't last in general for hours. Seizures are short. And stereotype, you'll get the same feeling, the same, wherever you are, the same kind of semiology, say it that way, or experience over and over. So, for example, anxiety and fear, you get this ictal fear, the sense that people will, this wave of sudden fear with kind of, your heart rate's going in temporal sclerosis, and that it's very unpleasant. It's instantly recognizable by the person because they're having, and is an integral part of the seizure, means the seizure's already there, or the seizures that you would express in psychotic-like experiences, so hallucinations, taste, smell, visual, but again, these are of short duration. The insight is preserved. So even, for example, and I remember this patient was sent to me because she was watching television, at one point felt that almost if the people in the television were acknowledging her, but this was very short duration. She had absolute preserved insight. In fact, she took a while to say because she knew this was very unusual experience. And also then there are other features. You'd have this experience, but then more than not, then you'll have some mouth automatism, some fidgeting, and some other head turning, eye deviation, other symptoms of seizures. So the ictal thing, these are symptoms that may resemble psychiatric, but the actual source of the symptoms is a seizure itself. So I'll give you an example, and this is someone who is sent to us. She has generalized seizures, she has seizures, but who was having these episodes that were kind of panic. I hope it works. So you can see that she looks fearful, she's hyperventilating, there's this big grunting noise, and it's not a very good video, but then she goes on to develop some, mouth automatism, she's fidgeting, she's disorientated, she's quite pale. So this is a seizure, which this bed, if you didn't know, you'd think that maybe she's having a panic attack. And then finally, in this term of ictal phenomenon that you may or may be confused by a psychiatric, change of mental state would be non-convulsive status. So in this case, people might be a bit confused, see things, say unusual things, but again, the key here is the person in general is likely to possibly have epilepsy unless it's de novo presentation. Although you could sometimes can have a simple conversation or exchange with someone in non-convulsive status, there's a sense of drowsiness, always a bit of confusion, and also would be very unusual not to have any other ictal features, like, again, I've said mouth automatisms, abnormal eye movements. However, this is something that you do need and is essential to confirm the diagnosis. So just to go over, we've gone through the pre-ictal, so this is kind of build up of irritability or change of behavior before a seizure. The ictal, which are the seizure themselves, that this is more to do with the differential diagnosis. And now we are moving to the post-ictal. So these are changes in mental states which are directly related to a seizure, just after a seizure. So what everyone would know and experience if you've had a seizure, even from a colleague or a family member, is this kind of post-ictally disagitation, confusion, which can last for minutes, hours, really mostly minutes. Important to make a point here, aggression is rare. So if the person is really post-ictally confused and someone gets in their way, allowed to push maybe away or to, because they're frightened and disorientated, but directed aggression is extremely rare, very, very rare. So, so again, people that would say that they're attack somebody and they're, because they're post-ictal, it's very unlikely. And then there's this phenomenon that you don't see very frequently, but you do see regularly when you have epilepsy clinics, and these people that describe that is after having a seizure, they would have this sudden kind of sense of depressed mood that would last hours or 2 or 3 days. Fleeting suicidal ideas are not unusual. The people that have this would describe this as worse and more disabling than the seizures themselves. And the only way to manage, there's no evidence of any treatment making a difference, just improving seizure control is what would improve that as well. And psychosis, which is probably what people know the most, it affects about 7 to 10% of people with epilepsy and represents of about 25% of the whole psychosis within people with epilepsy. And about 7 to 8% of patients in video telemetry for post-ictal psychosis. The risk factors is a long history, 10 or 15 years. Someone who's had epilepsy for 10 or 15 years, bilateral ictal foci, structural abnormalities, or past psychiatric history. And usually there is a trigger, and that's often important because if someone has recurrent post-ictal psychosis, and because there is no prevention or treatment other than improving seizure control, identifying a trigger will help you to be able to treat or to give some medication to avoid the escalation of symptoms. So usually the trigger would be a cluster of seizures or a long seizure. So typically, for example, someone is on for an assessment for epilepsy surgery, hasn't had a generalized seizure for years, months, the medication stopped, they then go on to have a prolonged generalized seizure, and this would be the trigger. Within hours or 24 hours, they might develop post-ictal psychosis or a cluster of seizures in someone who never has clusters. So what you then get is what's called the lucid interval. I'm not sure if lucid is particularly accurate. What you tend to see is the person is quite withdrawn, quiet, apparently normal. Insomnia is another good point. The person would say, the family would say, well, hasn't slept. And again, this is another point where there might be a window of opportunity to start giving people benzodiazepines to stop the progression to a post-ictal psychosis. The psychotic symptoms are florid. There are some papers would say, they have some maybe religious and ideas. is controversial and is not clear. What is clear is affect laden. So this postictal psychosis, the patients come across as manic. There is this affect, this kind of elation all over the, really kind of high, and there's no doubt that this is definitely a characteristic. And also, uniquely, this spontaneously resolves. So regardless the treatment, this would resolve more than not. Within 2 or 3 days, the person will go back to normal. Obviously, it's a very florid thing, it's very disruptive, it's quite scary for the person and the family, and you sometimes would give antipsychotics just to manage the symptoms, but there's no evidence that long-term antipsychotics make any difference or prevent this. It's just preventing the clusters or the seizures themselves. Okay, so moving on now to the interictal changes, mental states, and these are psychiatric symptoms that are completely independent from seizures. So the most common are depression, anxiety, and psychosis. I was going to mention, I see Helen, of course, has mentioned autism and ADHD, which is very prevalent in children and prevalent in adults with intellectual disabilities. I have no time to talk about it, but obviously this is another comorbidity that complicates matters and complicates picture and management of the epilepsy as well. So depression is there's loads of research showing depression is the most common in adults psychiatric comorbidity. So if you look at the general population in terms of the prevalence, depression is about 8.2%, and when you look at the prevalence within people with epilepsy, is about 22%, and this applies as well to anxiety. But interesting and crucially, when you separate actually the people with a well-controlled epilepsy in remission, or people with active symptomatic epilepsy, there's a huge difference. So the people with well-controlled epilepsy in remission, about 10%, and this is close to the general population, whereas if you look at the people with refractory or symptomatic epilepsy, it's closer to 50%. So clearly a big difference of the kind of underlying cause of this. So the epilepsy and depression, so that there is some risk, so frequent seizures, temporal lobe epilepsy, and the severity of the epilepsy, as I mentioned, are features that would put people at higher risk to develop depression. We know that depression affects the quality of life of people with epilepsy, and when in some kind of when asking people with epilepsy, sometimes people dread, or often people would dread depression as something that affects the quality of life beyond even the seizures. Being depressed and having epilepsy is a strong predictor of poor response to anti-epileptic drugs or anti-seizure medication, and also of having more side effects and being not tolerating the medication. And of course, there is a comorbid depression increases the risk of suicide. So there's the identification. Although now we're more mindful, this has been now discussed and people are more mindful that this might be an issue, but in general, clinical expectations that if you have a drug-resistant epilepsy, if you're on a lot of medication, the way you present is normal. You're going to be miserable. So this just comes with it. Or the other issue is the side effects of medication. Seizures themselves can give you symptoms that overlap with core symptoms of depression. So, for example, if you look at core symptoms of depression, so you've got so you've got depressed mood, loss of interest, reduced energy. So depressed mood with some anti-epileptic drugs, you can get the side effect, reduced energy, the medication, the seizure, someone has a lot of seizures themselves, reduced concentration, disturbed sleep, disturbed appetite, certain anti-epileptic drugs. So all this, you can imagine, it overlaps, so it's then difficult to disentangle what is the effect of the epilepsy, the effect of the medication, or is the person underlying depressed as well. So there are screening for depression that are valid, but the one that we use regularly and is used in a lot of the epilepsy clinics is the NDD-IE, and this has been validated for screening depression in people with epilepsy. So you can, if you can get that online, is a self-rated very quickly to self-rate. Values over 15 would indicate depression, and it's got a good sensitivity and specificity. So that's something easy that can be done in a epilepsy clinic to quickly screen for depression. And treatment of depression. So in here again, a little bit of, in the UK certainly, and despite the fact that we continuously say antidepressants are okay in people with epilepsy, there is still this reluctance and anxiety of treating depression with this idea that antidepressants would lower seizure threshold. And what we know now is, although there are not randomized controlled trials, but there's been enough studies and long-term studies to say that SSRIs are safe and well tolerated in people with epilepsy, and they're also effective in treating depression. Sertraline and citalopram probably be first line, mostly in terms of interactions and easiest to use, although you can use other SSRIs. It's important to let the patients know about the range of side effects of SSRIs, but from the point of the prescriber, need to be in mind that if someone is on enzyme-inducing drugs, Tegretol, phenytoin, oxcarbazepine, they're going to reduce the levels of the SSRI, so you might need to increase the dose, and this is important to bear in mind. But also remember, SSRIs would lower your sodium, and if someone is already on Tegretol, that might be problematic. So these are things that, so really bear in mind the interactions. But in terms of treatment and starting someone on a therapeutic dose of an SSRI, if they've got a depression, and of course, together with psychological therapy, this should not be an issue. There are some antidepressants, however, that do lower the seizure threshold, and this would be tricyclics at high doses, so you need to be careful. Meclobamide and bupropion, which again would lower seizure threshold, but the SSRIs in general, you shouldn't really worry too much about. And then, of course, with depression comes the risk of suicide, and we know that within people with epilepsy, this is increased, this increased about 3 or 4-fold from the general population. Of course, as in general population, affective disorders, previous suicide attempts are, increase the risk massively, but also in treated depression and early onset of epilepsy. I'm not going to talk about the rate of anticonvulsants because I'm not have time, but if anyone wants to ask later, I'm happy to expand. And then the interdictal psychosis. So again, this is a psychotic illness that is independent of the seizures. So the person is as psychotic before, during, or after the seizures. And again, the prevalence is higher, is lower than depression, but you can imagine the impact is, is a very serious illness, prevalent 7 to 10%, which is higher than the general population. The risk factors, again, for someone having interdictal psychosis is early age of onset epilepsy, family history, or a lower IQ. The symptoms, again, there is some kind of research that the symptoms are a bit different in people in schizophrenia, that maybe, again, the religious type of symptoms, again, for all intents and purposes, very similar to someone who have schizophrenia. However, is a bit different in terms of there's less deterioration of personality and cognition. You know, people with psychotic illness or schizophrenia, there's a massive deterioration in personality and cognition is not so kind of intense, and there's a more benign course with a better response to medication. And we're talking about medication again. There's the anxiety about antipsychotics reducing seizure control, which quite a few of them do, particularly high doses. However, they also save, for example, risperidone, and unlikely to increase your seizure threshold, aripiprazole. The key here is a slow titration and stick to the lower effective dose. And again, consider interactions. Remember, enzyme-inducing medication will lower the levels of your antipsychotics. You might increase doses. Clozapine is clearly epileptogenic, even in people who do not have epilepsy, and this is dose-related. But if someone is very psychotic, I had 2 or 3 patients that we have had to start them on clozapine. So moving into, this is kind of the last bit, and talking about iatrogenic harm. So people with epilepsy do have a higher rate of psychiatric problems in its own right, but also what we do to them to treat these put them at higher risk to developing psychiatric problems. So the main offenders here would be the medication itself, the anti-seizure medication we treat, or epilepsy surgery. So, for example, post-epilepsy surgery, about 25% of patients would develop either low mood, anxiety, mostly very, very common, or emotional lability. That's more likely after temporal lobectomy. Tends to present within the first 3 months, usually quite soon after surgery, but also tends to resolve within 6 to 12 months. But we also know that about 10% of people will develop severe depressive episodes, and that 1% people will develop a de novo psychosis. And then there is the issue of the burden of normality. Again, if anyone wants to ask, I don't have time to expand, but this is people who have a sudden improvement of their seizures after surgery, and they struggle to adjust of a life of not having a chronic illness, and sometimes would develop dissociative or or psychogenic seizures. So in terms of medication, the anti-seizure medication, we know that when we look at people with epilepsy in general, regardless of the anti-seizure medication, about 8% of drug would report behavioral side effects of any medicine in people with drug-resistant epilepsy. An anti-seizure medication that are used to treat for psychiatric patients, for example, motrigine, sodium valproate, in patients with epilepsy might have a paradoxical response, or benzodiazepines for that matter. And in patients with past or current psychiatric conditions are at higher risk to developing this. So if you already have a history of psychiatric problems, or you already have problems, you're more likely to have very psychiatric side effect of an anti-seizure medication. Therefore, it's important that when we start this medicine, we let people know that this is a potential side effect, and that people can be vigilant about that. The key here again is a slow titration, because you know a fast titration puts the person at risk, and monitoring. Also screening for people who are at higher risk of developing these, particularly people with previous psychiatric conditions or currently having some psychiatric problems. So this is just a kind of general, and just to say, if you Google any antibiotic drug, you'd find that case reports of all sorts of psychiatric complications have been in most medications. Levetiracetam is, well known to for people with anger and irritability and maybe depression. I want to make the point here that it is a small percentage. It is significant, and what happens is very disabling, but it's only a small percentage. So I think it's important, because what you see a lot is these medicines now get disregarded very quickly or get blamed for side effects that actually are not side effects. So someone starts on levetiracetam to 150 milligrams, it's a tiny dose, and within a week they say, well, they've developed anger and they stop. And this is not really the case, because it's also dose related. And I think you have to also bear in mind that for people with drug-resistant epilepsy, this may be, they have a limited option. So you disregarding drugs, it may have a big impact into these people. You know, carbamazepine, vigabatrin, that, you know, again, higher rate of psychosis, phenytoin, topiramate, depression, psychosis, lamotrigine, insomnia. That's the case for levetiracetam as well. Perampanel, anger, irritability, you see it very much dose-related, and valproate, depression. So this is just to get a flavour of the potential psychiatric side effects of anti-seizure medication. So then, because Professor Cross is normalization, and again, in my view, this was the actual definition is people developing psychotic symptoms following normalization of EEG. So is it an EEG diagnosis? This was described many years ago initially for children successfully treated with succinylcholine, but it's been described in other patient scenes with abrupt resolution of seizures. So essentially, you give them medication. There's a rest. The EEG normalizes, and the person becomes psychotic. I've seen it very, very few times, unless this textbook definition. What is more normal is the alternative psychosis. This doesn't require, you know, it's not an EEG definition, but is more of a clinical phenomenon that you would certainly see. And again, as Professor Cross said, is multifactorial, where there seems to be a reciprocal relationship between a normal mental state of behavior and seizures. So the person has a lot of seizures, and this behavior or mental state is not an issue, or the seizures stop, and then the behavioral or psychiatric problems emerge. So this is more likely, and this you would recognize that more frequently. So finally, and just to finish off the epilepsy, there's no doubt it carries a significant disease burden in terms of comorbidities due to psychosocial and behavioral difficulties. It is important to identify because this can be managed, and it has a huge impact on people with epilepsy, and often, you know, as time goes on, less are missed and undertreated. Thank you very much.
Thank you, Professor Otto, for a wonderful overview on neuropsychiatric issues in the epilepsy patients. We can take a few questions.
Yes.
Penny?
Hi, thank you for the wonderful presentation. I'm Hetal from Liverpool. I had a patient who I'd seen for medical legal purposes, and the question was whether there was forced normalization. Now, he had developed psychosis post cluster of seizures, which he usually did not have because there were some changes happening to his medications. Now, one of the legal questions was whether this was forced normalization related psychosis, which we would never know because we would never do an EEG. He had murdered his stepfather. So again, we'll never find out. In these cases, how do you manage their psychosis in the long term?
So to be clear, did the person remain psychotic?
No. So after treatment with antipsychotic medications and optimization of the treatment for epilepsy, we don't know which one worked. But he settled, stable in his mental state. We'll never be able to take him off those medications.
I mean, the way you describe, as I said, you know, an unusual cluster of someone who never has clusters, and depends on the pattern, you know, and usually self-resolve, but actually the same way I was saying post-ictal confusion and it's, you know, aggression is not normal. Aggression in post-ictal psychosis may be an issue. And aggression or self-harm during post-ictal psychosis. So it's one of the ones that you probably need a forensic description of what, I mean, of course, would be unusual to do something like that, but you know, I wouldn't, if you'd said the guy was just post-ictal, I would say, no, that can be, because you don't get any directed, it requires planning. But if someone was very psychotic due to a post-ictal psychosis, aggression has been described. So this is a possibility.
If I can add to that, during my years at Chalfont, we've seen very severe acute behavioral outbreaks in the context of just having had a seizure, so technically post-seizure. So we had one guy, for example, who used to play billiards every day. And of course, this is a place where a lot of people with epilepsy are living. And he just took his billiards cue and severely beat up his companion who was playing with him. We also had one guy go off the third floor of the building, not in Chalfont, but at Queen Square. And we had one gentleman, a Japanese colleague, described a gentleman who cut off his penis. So there are sort of descriptions in the post-ictal state of severe aggression or severe behavioral outbreaks. And I guess while it's hard to say whether it's a forced normalization episode, obviously in the absence of an EEG, you know, you can have severe aggression, I guess, as part of sort of a temporal correlation to a seizure. And I think it's a very confused and disoriented state that the person is at that point in time, apart from being psychotic. And of course, all descriptions of post-ictal psychosis they talk about a lucid interval and they talk about, in general, a 48-hour period when you're psychotic. Very rarely up to 7 days is the description. So don't know if your guy was in that time window.
So there were periods of lucid intervals previously. We didn't see it at the time of the offense. I think the worry is, do we continue treating the psychosis as post-ictal psychosis? Because you don't need to continue treatment for that forever. Or do we trial taking him off and then risking another serious aggressive incident, which I think within the NHS, no one will probably have the you know, the guts to consider.
Yeah. I think, and I think this is the risk, isn't it? But my point about post-ictal behavior is that it is rare. So I just think this it is very, so in terms of stigma and all this, and you don't want people to get the idea that people have seizures and then they go around hitting people. So I think my point is, yes, I have seen it occasionally. Yes, in people with learning disabilities or autism, post-ictally, they can be really disinhibited and aggressive. But in general, I think the message should be this post-ictal confusion. People are normally, they're not aggressive. So it's more to, yes, we've all, I suppose, if you've I've seen enough people with epilepsy, you would see that. But the message is that in general, people are just confused and it just need a bit of time to calm down.
As a continuation of this, we have one more participant, Dr. Srivatsa, who has asked a question. Are there definitive criteria for forced normalization and alternating psychosis of epilepsy? Do we have any criteria?
So in terms of forced normalization, yes, it's an EEG. So you need an abnormal EEG that normalizes after treatment, and then, but for alternating psychosis is much more wider. So essentially what you get is it's more of a clinical experience, someone who is having loads of seizures that suddenly stop, and then you start having problems with behavior and psychiatric, which you didn't have. I don't think there is a strict criteria. The forced normalization, you do need an EEG.
If I can add to that, there was a whole book on forced normalization edited by Trimble and Schmitz. And there's a chapter there where Professor Trimble and I have proposed criteria for force normalization. So unfortunately, it's not a published paper, it's in a book. And it's been cited quite a few times, but essentially we've talked about both definitive and probable force normalization as part of those criteria. But it's not in a book. It's not a published paper. So yeah.
Are there any more questions?
Because there are some cases of hot water epilepsy. I've come across one or two cases that I've read and I came to know also. Even there is some identity dissociation during that time when taking a hot water bath used to exhibit some kind of identity dissociation. They say in some parts of Karnataka, this hot water epilepsy is common. Would you like to throw some light on that?
Sorry, I don't think I understood the question.
I think it was about hot water epilepsy.
Oh, yes. It's I've read about it. It is very interesting. It's one of these reflex epilepsies. I don't know if Helen maybe has more to add, but this what you get is a pleasurable sensation. So people may induce the seizures themselves, but I don't think certainly I've never seen in the UK. I think it's more common in India, maybe. And is this there are other reflex epilepsy like eating epilepsy, but I think that the distinguished thing about the hot water epilepsy is that you get a pleasurable aura, and that people sometimes would trigger seizures.
Just to add on the hot water epilepsy, because from the NIMHANS under Professor Satish Chandra, there is a gene involved which preclude the hypothalamus to regulate the temperature inside the brain. So when we pour the hot water on the head, and it's lead to the seizure. But there are other like photic sensitive type, like there is a reflex epilepsy called the Pokemon epilepsy, which happened after the children watched a particular episode of a Pokemon. So in our 2013 book, we have they had a chapter on that. So there was a Pokemon and a Mahjong epilepsy while people playing and get so excited that they got the seizure. And it is well documented in China and Seoul in South Korea. Bright lights.
Yeah.
How common is catatonia in epilepsy? For example, if it's not part of autoimmune encephalitis, I want to know how common is catatonia as part of epilepsy? Have you come across catatonic episodes as part of epilepsy?
Epilepsy itself, no.
Yeah.
No, I've seen it a lot, and you see it in NMDA encephalitis, but catatonia just as a result of seizures. I suppose if someone is very psychotic, might go catatonic, but I mean, if you see seizures and catatonia, you would think NMDA encephalitis, really.
Mm-hmm. Okay. Thank you.
Yeah. Thank you for your wonderful talk, ma'am. Is there any phenomenological difference between interictal psychosis and primary psychosis? Phenomenological difference?
Well, that's what I've made the point. I think if you read enough papers, there's been people who have done studies, but it's inconsistent. The findings are inconsistent. So you'd read, some people would say, there is this more religiosity. But actually, if you've seen enough people with schizophrenia, religious delusions are very common, even in people without epilepsy. So I think aside from the more benign course, the less deterioration of personality, if I suppose if I was somebody, another speaker would say yes, that the phenomenology of the actual psychosis is different. But if you read the papers, there is no consistency. So some authors would say yes, and particularly usually the emphasis on all this religious thing. Certainly in a postictal psychosis, this affect where people
Affect.
present as kind of manic psychotic is, you
Yeah.
see it all the time, there's no doubt about it. But if you ask me, and if you read the literature, some authors would say yes, and some authors would say no, and I'm not sure it's particularly helpful in terms of clinically.
Clinical. Thank you.
Thank you. So we have one more question from Dr. Srivatsa. So he is asking, are there any clear risk factors in epilepsy for people with epilepsy to develop force normalization with the newer anticonvulsants? So in his experience, he's seen that when patients are changed to Briveristim, most of the time patients appear to behave, settle behaviorally. So he wants to know your thoughts on it.
I think that is more the effectiveness of the anti-epileptic drug rather than the anti-seizure medication itself. So I think is this abrupt resolution of seizures. So I don't think it's the Brivatirastam or, for example, the Vigabatrin. So some of the reported psychosis as side effects might have been a kind of alternative psychosis because it is so because of the effectiveness. So I don't think it's a single, so it's more Brivatirastam is a very effective anti-epileptic drug. So it's the same as the surgery. It's this kind of abrupt resolution of seizures overnight that triggers the potential change of mental state rather than the actual seizure itself. So the more effective the anti-seizure medication, the more likely that you may tip into one of these abrupt changes in your mental state.
Sure, thank you. So if there are no more questions, I think we'll bring the session to an end. Yeah.
Thank you.
Thank
I'm
you for the
sorry.
wonderful.
Yeah.
Thank
Sorry for
you.
being late.
No, not at all. So thank you, Professor Helen Cross and Professor Maria Otto for the wonderful talk and the chairpersons. So I would like to, yeah. Who will
So we thank Professor Maria Otto and Professor Helen Cross for joining us online from the UK. We look forward to hosting you in person at a future event. I now request Mr. Vivek Mishra to felicitate Dr. Anusha and
Dr. Shri
Dr. Srinivasan.
So moving on to our lunch symposium, what I will request to everyone. So we have Dr. Vishnu Priya here and Dr. Raj Halimani who will be presenting their talk. So the talk remains of 20 minutes each. Please, meanwhile, everyone can get their lunch plates and come back while we can listen to the speakers. Dr. Vishnu Priya, please.
What we'll do is we'll start presentation, then we can do the thing.
आप करते कैसे हो नहीं यार एक बार समराइज करके क्रिएट करके हमने आईडी we use it for clinical not clinics but you turn it on and then you got which is task right so this could not be kind of
Okay.
A very good afternoon, respected seniors, and I'm really thankful to the organizers for providing me this opportunity to display my humble work on validating induction protocol and mapping phenotypic diversities in children with functional neurological symptom disorder. I'm Dr. Vishnupriya and I'm a psychiatrist working at Child Development and Early Intervention Center, where I'm a part of the multidisciplinary team comprising of the pediatric neurologist, developmental pediatrician, and the therapist. Now moving on to my presentation. So the outline before starting my presentation, I would like to disclose that the entire study is based upon our clinical experience and there is no conflict of interest or any external funding for this work. And we have received the consent for the videos which we have used in that presentation. So at the outset, I would like to start my presentation with the previous terminologies which is being used for children with functional neurological disorders and the existing research evidence on the induction protocol in such children and the profile of children who presented to our clinic with functional neurological disorder, the induction protocol steps which we used in our population, and how did we map the childhood dissociative checklist scores versus the induction protocol technique that we have used. And I would like to highlight few key messages from our study and followed by the clinical implications for the training of the residents and the future directions. Now moving on to the study. So the introductory part, I would like to start the presentation with a few terminologies pertaining to the functional neurological disorder. As we all know that the different classificatory system, especially the DSM-5 and ICD-11 have various terminologies for the same, and DSM-5, they give the term called functional neurological symptom disorder, and that is why the functional neurological disorder is used worldwide. And coming to ICD-11, they have a category called dissociative neurological symptom disorder. And they have classified the movement subtypes as subtypes only, like with non-epileptiform seizure, with gait disturbance, or with paresis. These are the specifiers as per ICD-11. But still, even now, many of the researchers use the age-old terminologies like psychogenic, non-epileptiform seizure, psychogenic seizures, and pseudo-seizure. So I would like to start the presentation with this paper which got published in Epilepsia recently. So this was a proposal for a new diagnostic label for the functional neurological disorder, and this was formulated by the ILAE Task Force, FND Society, and FND Hope, which is a patient advocacy society. So in that they have proposed that a new term called functional or dissociative seizure, that is FDS, must be used for all the seizures that are not caused by any abnormal electrical activity in the brain. So they have also proposed that the consideration for making this terminology is for wider patient acceptability, for diagnostic accuracy, for explaining the illness mechanisms to the parents in the case of children, and for formulating the treatment provisions and to address the socio-cultural factors, because the term psychogenic or pseudo is not well received in many of the cultural areas. So next. So this is an experience from a PNES clinic, that is a movement disorder clinic from Ohio, where they state that the prevalence from the age of 15 to 19 years is nearly 60% per 1 lakh population of the adolescents. And majority of the children who are referred to a neurology clinic for evaluation of seizure do have this non-functional seizure. It is nearly 20%, and functional along with comorbid of epilepsy is also nearly 20%. So this is a data from Ohio. And now moving on. This is one of the study which was done in Indian population on induction protocol. This was done by a neurologist from SGBJ Lucknow. And they have used various induction methods, and they have stated that all the induction methods have a diagnostic yield of nearly 69%. And for them, the most effective ones were like the compression of the temporal region, that is the temporal massage. And what they stated that they were able to recreate the same semiology which the child presented to the clinic. And the speed of induction of the seizure was highest for tuning fork. And the maximum discomfort was found with saline injection. As we all know that saline injection is a invasive procedure. Next, moving on, this is another study which was done in adolescents and children from Poland. So they have also used some similar techniques only. They have used hyperventilation, they have used photic stimulation, and they have used something called placebo introduction, where they have used the saline soaked cotton swabs, and they instruct the child that it contains a medication that would induce the seizure, and they will apply that soaked cotton over the left forearm, and that resulted in the induction of the non-epileptiform event. And they were also stating that every method had equal sensitivity and specificity for inducing a non-epileptiform event. Next comes this study which was done in the Institute of National Importance, that is AIIMS Delhi. So this is again done by the pediatric neurologist, and they have chosen the population of children with suspected psychogenic non-epileptiform seizure, and they have clubbed verbal suggestion with the tuning fork, and they have clubbed verbal suggestion with a cotton swab, and they found whether they were able to induce the paroxysmal event. And they told that there was equal efficacy of verbal suggestion alone or in combination to induce the event. So with that, so what is the need of this work, and what were we able to observe from the existing research? So predominant studies were done by neurology clinics, by the neurologist and the pediatric neurologist, and invasive methods used even in children and adolescents. And EEG technicians, majority of the time, they did the induction methods. And there was lack of uniformity between the various techniques that was used, and there was no cultural correlation for the same. And psychological factors were not mentioned, or they were not even included. And there were absence of many rating scales, like they have not used proper rating scales to quantify the dissociative score or the psychological aspects. So what really sets our study apart? So we made sure that we will take a detailed psychiatric history before initiating the induction protocol, and psychological factors and stressors were taken into consideration before making the child induce, and the child's native language and rapport establishment was prioritized for the verbal suggestion. And we were very keen that we spoke in the patient's own language before the induction, and we avoided all the invasive techniques, and we did it in a sequential manner, and we were trying to see as to which step works better. So we made it in the sequential manner. So regardless to say that it is definitely not possible without the team help, and we are a team comprising of the pediatric neurologist on board, the psychologist, the therapist, and the speech language pathologist. So coming to the profile of children who presented with functional disorder to our clinic, we collected the data for 1 year, and over the period of 1 year we had 58 such children, and the most common presentation was motor symptom. It can be any paroxysmal abnormal event like seizure or like tremors or some abnormal movements, and the second most common was weakness and paralysis and gait issues, and least common presentations were memory and behavioral changes. Yes, we also got children with functional cognitive disorder, speech difficulties like aphonia, aphasias, and motor and sensory symptoms, some rare symptoms like hiccups, abdominal movements, as well as somatic cough syndromes we were able to get. So the methodology, we chose children from 6 to 14 years of age who are diagnosed with dissociative neurological symptom disorder as per the ICD-11 criteria, and following pediatric neurological evaluation and video EEG to rule out any epileptiform events. And we administered non-invasive induction techniques like verbal suggestion, temporal compression, moist swab application, tuning fork and torchlight in a sequential manner on a subset of 35 children. So we measured the outcomes through the distress scores on a scale of 0 to 10. So we asked the child to score the distress soon after the finishing the induction, and the latency, the seconds taken to the response induction was also recorded, and the child dissociative checklist scores and the relationship with the induction method was also mapped. So regarding the gender distribution of the comorbidities, as any other functional neurological disorder study, the females contributed the majority of nearly 59%, and boys were around 41%, and comorbidities were present in 41% of the population. And surprisingly, in this cohort, we were able to see that only the anxiety-related spectrum, like generalized anxiety disorder, panic or panic attacks, were predominantly found in girls, whereas all comorbidities, like a few children presented with depression, they fulfilled the criteria of somatic symptom disorder, temperamental difficulties were predominantly found in the boys. Now, coming to the duration of illness, though our institute is located in a very remote corner of the northeast India, yet the parents sought medical attention as soon as the symptoms started. That is, over the graph, we are able to see that they brought the child within a span of 1 or 2 months itself, and very rarely it crossed beyond 1 year or 2 years. Even within the 1 year, 2 year period, they were already seeking multiple neurological consultations, and the child was already on multiple anti-seizure medication. So the familial psychopathology, interestingly, we were able to find that nearly 65% of the study population did not have any familial history of psychiatric illness, and substance was commonly seen in the family members. And we also found a pattern that the father's alcohol dependency or the cannabis dependence actually exacerbated the non-epileptiform even in the children. And substance use was followed by suicides in the family. And interestingly, nearly 6% of the children were adopted. So now we are actually seeking more information on the psychopathology in these adopted children. We are planning for a case series. Psychosis and proper epilepsy were very, very less. So there were no modeling as such in the family which was running. So regarding the stressors which were associated with these children, school-related stressors were commonly related, and also we note a pattern that exactly before any exams, like example the quarterly exam, annual exam, or before the term examination, we see a surge of the functional disorder cases in children landing up in our emergency or in the pediatric outpatient clinic. And school-related stressors were common, and in majority of the cases, we were not able to identify any proper stressors also, in spite of a proper psychiatric assessment. And then this is the induction protocol which we administered. So any child with suspected functional neurological disorder with attacks or seizure, he will first visit the pediatric neurologist, and after a detailed neurological history and extensive neurological examination video EEG, when they rule out epilepsy, then the child will be given to our team comprising of the psychiatrist and psychologist. So this is the induction protocol step. In step 1, we will give verbal suggestion to the child. So this verbal suggestion will be in the native language, and we will be focusing more on the stressors which the child is having, as well as the semiology of the pattern of the movements which the child have. And we give 3 cycles of 90 seconds each. So when it fails, then we go to the temporal massage or compression of the temporal region. Again, we give 3 cycles of 90 seconds each. Then we'll go to the moist swab application, where we put saline on the cotton swab, and we will apply it constantly over the temporal region. Again, 3 cycles of 90 seconds each. Then followed by tuning fork application, as we know that it lasts only for 50 seconds, and followed by the last step of torchlight stimulation. So if we are not able to induce with that, then we will award the total this thing. So these are like few videos of the children whom we induced. So this is verbal suggestion. So we are instructing the child to be comfortable in her own native language, and we say that if the child starts to have the abnormal movements, then we are there to help, so that the anxiety of the child is addressed. So next is the temporal compression, or the compression of the temporal region, which we do. So after this, the child was having some paroxysmal movements of the lower limb. And this is the moist swab application, where we will apply the saline soaked gauze to the temporal region. And this is the tuning fork application. And finally, the torch-like stimulation where we will display the torch over 15 centimeter away from the pupil. So what are the prerequisites for a proper induction? So we were able to observe that the detailed psychiatric history and psychological assessment is definitely required for a good rapport establishment, and good language proficiency in the child's native language is a definite prerequisite. And factors facilitating induction where when the child had already identifiable recent onset stressors, then the child was able to induce better. And non-invasive nature of the technique, because the child is really scared when we say that we will try to induce the event or we'll try to bring the episode. So the non-invasivity of the technique is an essential thing. And baseline temperament of the child, if the child is an easy child, then it was easy to induce also, rather than the children with temperamental difficulties. Then we plotted the childhood dissociative scores by the various induction methods, and we were able to find that the median scores fell within a range of 7 to 10. But in CDC, it is actually significant only when it is beyond 14. So the dissociative vulnerability, which was measured with the CDC score, it did not vary meaningfully across the induction method. So it is the induction method per se, rather than the dissociative vulnerability of the child, that resulted in the induction of the movement. And in Kurzweil-Wallis test or in Spearman correlation, we were not able to get any correlation between the induction method and the CDC score which were used. And then we plotted the distress scores across the various methods over a scale of 0 to 10. And the median distress was somewhere between 4 and 7. And every technique was tolerated well by the children. Whereas the temporal massage, that resulted in slightly highly distress score rates when compared with other techniques. And when we compared the latency, that is the time required to induce a non-epileptiform event, we found that the moist swab and the temporal compression, they tend to produce a longer induction latency, typically around 150 to 200 seconds. Whereas surprisingly, verbal suggestion led to shorter but variable response rates. So this was the study. So the key messages was like, there was a distinct psychosocial pattern that was found in the Northeast population, that is school-related stressors were more common than the family issues. And we found that induction protocol served to be a safe, cost-effective, reliable clinical tool. And verbal suggestion, when we do it in the child's own language and when the child has already an identifiable stressor, it produced a rapid but variable response. And the children were brought even when the illness duration was within 6 months, and there was stable CDC scores and there were no difference in the distress scores. These are the key findings of our study. So regarding the clinical implications, as discussed today in the brain-computer interface, so the parents bring the child for this non-epileptiform event, and they will be really shocked when the neurologist hand over the child to the psychiatry and psychology team. So this induction protocol served as a tool for us to explain the mind-brain interface in this functional neurological disorder. We were able to explain the hardware-software concept better when we were showing the videos of the child getting induced with our induction protocol. And this helped us to curb the unnecessary anti-seizure medication usage. Few children were even started on ASM for long duration of 2 to 3 years, and we were able to slowly taper and stop all those anti-seizure medication. And we used the video for psychoeducating the parents regarding what is functional seizure, how does it differ from a proper epilepsy. And the parental acceptance was great when we were able to use this as a psychoeducation modality, and they were very much ready for the psychological interventions and even medications when we tried to offer one. And we found that it is a valuable and low-cost tool to aid the clinical decision. So we know that it is a functional neurological disorder, but it is very hard convincing the parents that there is something called a FND exists. And from there, we start the psychoeducation, relaxation, and bodily awareness of the child. And this serves to be the first step before taking the child for any retraining and other awareness training. So soon after this, we used to give them school recommendations, because one main problem which we find in our population is school absenteeism. And the moment the child starts to throw a paroxysmal event, immediately the school authorities send the child home, and they instruct the parents that they should not be brought unless and otherwise it is completely settled. And as we all know that it is a chronic condition and they tend to recur, so we used to give the school recommendation letter countersigned by me, by the psychologist and the pediatric neurologist, and we will state the non-epileptic nature of the event and what the school authorities should do, and how important is reinstituting the kid to the school is in this category. And we have found that many children were able to reinstitute in school with this letter. And we have included this particular induction protocol in our resident training also, especially while this is actually a snippet from the checklist which we use for the functional neurological disorder in children. And we have included the induction protocol in the clinical feature pattern also. And when we started up this functional neurological clinic, even we were not sure like where to intervene, what to do. Now we have set up a SOP, we have set up a protocol, and slowly we have started to get referrals from the entire Northeast and from the peripheral areas of Assam also. The children are getting referred to our team for the management of the functional disorder. And so the therapists, psychologists, and EEG technicians, they assist us in the comprehensive history taking, and they become a part, especially when there is a language barrier. And I'm thankful that I have a multilinguistic team, so when I'm unable to handle the child, my team members are able to handle the children in better manner. And all evaluations are conducted under the guidance and supervision of the psychiatrist, and all the team members are uniformly trained and competent in administering the protocol. And ethics, safety, and child's comfort are ensured throughout the process. Because two major implications which we found in our population, one is financial implication. There have been parents who have spent nearly 5 to 6 lakhs in unnecessary investigations on unnecessary anti-seizure medication before reaching to us. And they very poor knowledge about functional disorder do exist even among the general practitioners and the pediatricians now. So the future direction, we are planning for developing psychoeducation modules for the parents for psychoeducating them. And we are planning to validate this particular study in large multicentric cohorts. And we have also made a few fMRIs, but the results are yet to release, so I did not include it, regarding the functional aspects in these children, whether we are able to get such correlates in children with a functional neurological disorder. And we have trying to make it as a mandatory incorporation into the pediatric neurology and psychiatry training at our institute. So finally, I would like to end my presentation with a few points regarding our Child Development Center, which we have at our AIMS Guwahati. So this is our team. And actually, apart from this functional disorder, our mainstay of interest is neurodevelopmental disorder. So we made this CDAC file. This is actually a comprehensive patient file, and where we do all the assessments together. We have a common assessment where the developmental pediatrician, the psychiatrist, and the therapist sit together for the first point assessment to avoid unnecessary referrals between the different stakeholders. And we do conduct a lot of awareness program, patient support program, and we have released a bilingual autism care booklet in both Assamese as well as in English. And we are in the outreach, we do outreach activities, and we have an Ayush block that is complementary and alternative medicine at our AIMS Guwahati. So we are now including yoga as also a complementary therapy, especially in children with neurodevelopmental disorders. And we have also training the peripheral healthcare workers, that is the national health worker, along with UNICEF. We conducted a training program, and we released module, so that because they are actually the forerunners and they are the first point of contact for any child getting referred to our CDAC unit. And recently, this was an occasion of the Swasth Nari Sashakt Parivar, which was launched by our honorary PM. And we conducted this program for empowering the mothers of children with neurodevelopmental needs. And we are also validating the screening tools like RBSK tool, which is for early developmental screening, as well as MChat. We are trying to validate in our Assamese native population. And finally, we have integrated our CDAC center under RBSK scheme, so that the moment a child enters our center, starting from the pediatric consultation to neurology to EEG to drugs, everything is offered at free of cost, so that we are making sure that no child is left behind due to lack of access or affordability. Thank you so much for this opportunity, and I would like to end this by saying that together we can definitely move towards precision care in pediatric FND. Thank you so much.
Thank you, Dr. Vishnupriya, for very crisp and impactful presentation, the difference you are making in the remote, far-flung Northeast area. See, like, when we talk about the metro cities itself, and then, there is lots of misconception about the FNDs, especially the non-epileptic seizure. So what is your experience, like, what you tell to the parents there about the FND, and especially if you have seen the more adult population, like, between 18 to 24? Because we find it here that when they come and say, like, it is non-epileptic, so then they Google and say, you are telling it's a, like, pseudo seizure, or I'm faking it. And I think Dr. Priyanka from our team, so she handles the, like, more of patient. So what do you tell them? Like, why is it happening?
Okay, so at our center, we do get children till 14 years of age. So our duty is to psychoeducate the parents only. So I avoid the term like non-epileptic seizure or dissociation. I use the term functional only. So that is how we first advise the parents. And we always say that the child is not faking it. 2, 3 points we used to highlight is the child is not faking it. There is some underlying stressors or there is some underlying component which is we are not able to figure out through the objective test which we administer on the child. That is why we are able to induce that particular event. And I always try to educate them by saying that the neurological test, MRI or whatever is available, it's only for the hardware. So the hardware actually functions based on the software, that is the mind. So I advise them saying that there is something called mind. Again, that is also controlled by the brain, which unfortunately we are not able to see through the investigation. But the child is having such a thing only. So we'll make them understand that such category first exists. So making them understand that itself, it's a great trouble for us. So by the time they understood, after that they will never seek any unnecessary neurology second opinions or EEGs or MRIs. So they will get convinced that okay, such term even exists.
So that's a remarkable job you're doing, Vishnupriya.
Thank
Well
you, sir.
done. It's not easy to do these jobs especially in India, but I think you're doing it really well. I think my questions are, number one, this induction thing you're doing, I mean, have you got any long-term data on it? What kind of prognosis you get once you do it? How
Yes,
many
sir.
people?
We have recently started it before 6 months only. So in the long-term data, one thing which we were able to find that the number of seizure episodes actually reduce once the child undergo this induction protocol, because there only will sensitize the kid regarding recognizing the internal cues and whatever is happening with the child. So that one thing we have observed, and the parents who have understood this process better, they actually stick to the psychological interventions, and even they prefer pharmacology in many. I have not mentioned that when many children actually they benefit very well with propranolol, because many of these children have this performance anxiety and generalized anxiety. So they are very much compliant with whatever the modalities which we give, and they're very good in follow-up also, because that is one area which is completely lacking. The follow-up in FND care, especially in India, it is very, very lacking because they do doctor shopping a lot. So these two things we were able to find.
That is true. That is true. So in terms of children who do not respond,
Yes, sir.
do you see any trends in them in terms of risk factors? I don't work with children, but I have got few children. In Australia, it's not very well specified, but and I have seen a trend in this population, especially non-epileptic seizures in children, and the risk factors I have identified. So I'm curious to know whether it's the same, like autism, ADHD, undiagnosed autism, undiagnosed ADHD, trauma, and gender dysphoria. Do you see any of these risk factors in these children?
No, sir. Actually, this protocol, we have taken children without comorbidities because our prime aim was to validate it. So the common things which we found in children who does not respond is, one is whether it's from our side, where if we are not able to establish a very good rapport, or because of some time constraints, in that case we fail to get a response. That is one thing. Second is children who are extremely anxious, like they will be keeping on opening their eyes, they will not respond to our verbal cues. In that case it is a failure. And third is temperamentally very difficult children who have this ODD contact things, and they want to escape from something. That is why they are having this non-epileptiform. Even in that case our induction protocol fails.
Do you see more girls or boys?
Girls, I see a lot more girls in this.
Yeah, thanks.
Yes.
Think it's a very good presentation because focusing on FND in children. Now I'll just start with just talk like any risk factor for children where these psychogenic non-epileptic attacks are persisting. Like one of the risk factor, like the article published by Dr. Salpekar, it's a parental psychopathology. When a child with FND, you're treating them, but still FNDs are persisting. Now you straight away look at the parents, whether maternal anxiety, parental anxiety might be one risk factor, where because you're treating the child best, but the parental anxiety is so much that they are reinforcing the FND symptoms. So that might be one thing. So we have to look in. And regarding this, like I think induction protocol, one way it would help is so in communicating FND to the parents. So one study has found that if you tell them about what are organic features, what are non-organic features, maybe their acceptability increases. So that way, showing them induction protocol, yes, these are all non-epileptic. So that will increase their acceptance about FND component. So that way, it would be a good one. And second is like sending a letter to school is very important in children because like teachers often tell the teachers, very important message to teachers is it's a non-emergency thing. That is what we have to communicate them because often they think that it's epilepsy and they take him to a sick room. And also sometimes reverse also happens. They say that now if you say it is psychological, they'll tell he's faking the symptom. He doesn't want to study. That's why he's so very sending a letter to school is a very important thing. My one question is, what about dual diagnosis patients where you have epilepsy with FND? How induction protocol you'll do in
This
such?
induction protocol we have not tried in such cohorts, sir. We have tried because we don't know how far it is valid. So we have tried only in children without comorbid epilepsy. And this one thing I would like to add is like regarding the familial psychopathology, that pattern we observe in our population also. Like children with mothers who themselves have this dissociative seizure and who have the family history of substance abuse, they tend to have this recurrent non-epileptiform events that we have.
I will, for the paucity of time, we will move on to the next presentation. Thanks, Dr. Vishnupriya. Dr. Nagaraj Harimani. So we have 20 minutes.
This one? That point. So, okay, so, right. Let me know when should I start. Let me. Okay, shall I start?
Please.
Yeah. Okay, good afternoon. This is, I'm going to show our work. I'm going to show our work on developing AI model for the diagnosis of MCI in Alzheimer's disease. I'm Dr. Nagaraj and my colleague, Dr. Selva Kumar, he's not here, but we work together to build this model. So this is our iBrain Center for Precision Neuropsychiatry. So yeah, so we do work together. I'm a neuroscientist and he is a computational neuroscientist, and we do develop tools for precision neuropsychiatry. Oops. Yeah, so we all know we have this, great issue in neuropsychiatry. We have the subjectivity in diagnosis and also, heterogeneity in the disease symptoms and also individual biological differences that makes diagnosis a bit difficult and also subjective. So to overcome this, we need to develop objective biological markers so that we can be more efficient in diagnosing and also in treating so that we don't treat one size fits all approach. So for this, early detection is critical, but it's not easy. So precision medicine is what we all aspire to in neuropsychiatry. So what is the solution for this, the subjectivity in diagnosis? And also, so we have this, the disease heterogeneity. So we are trying to use AI to leverage advances in neuroscience and neurotechnology and to build multimodal models using objective biomarkers in different diseases for prediction and personalization. Okay, because AI can handle big data and then it can see the linear and
nonlinear relationship between different disease aspects, which we cannot see ourselves. So that's an advantage. Okay, so let's come to Alzheimer's disease, which we have built an AI model for. So as we all know, Alzheimer's disease is a multifactorial and heterogeneous disorder with characterized by neuropathological hallmarks of amyloid beta, tau tangles, and neurodegeneration that is classically known as ATN. And so it has this is very interesting because 60%, 65% of the risk factors are potentially modifiable, which is very important because which means you have to detect early, and then you can implement effective intervention so that 65% of the risk factors can be avoided. So this is this is how the disease develops, where the pathology develops decades before the symptoms appear, even the first symptoms like MCI. It's in a mild cognitive impairment. It appears when the pathology is almost complete. You can see amyloid beta plaques. You can see neurofibrillary tau tangles almost reach the highest level when MCI stage is detected. Because MCI stage detection is important because not all MCI cases turn into or convert into dementia. Up to 1/3 of the MCI cases convert to dementia over a 3-year period, and some of them remain stable over years. Some of them can improve. So that's a very important stage where one can do some intervention to stop the disease progression. Okay, so that was the therapeutic window. So I'm sorry. That's that yellow box you see is a window of opportunity where one can intervene for early and accurate diagnosis. So we have used these multimodal biomarkers to capture the diverse and heterogeneous aspects of the Alzheimer's disease. Like you have the neuropsychological assessments, the genetic testing, that is ApoE4, that has the biggest risk factor for the disease. You have the neuroimaging, structural, functional, and fluid the fluid biomarkers from CSF and blood, A-beta 42, p-tau, total tau, and multi-omics that can be used to detect the disease early in its stage. Okay, so basically, the multimodal biomarker helps us to stratify the patients, and like we can subgroup the patients based on the different combination of risk factors and the pathology, which I'm going to show you later. So this is this can be done using AI because it can identify the complex relationship between different risk factors and the pathology in an individual based on the biological differences in an individual. And there are so many I'm going to come to that in a while, sorry. Okay, so there are so many machine learning models that's been developed to classify individuals as cognitively normal or mild cognitive impairment or Alzheimer's disease, based on various clinical biomarkers, including EEG, MRI, neuropsychological assessments, and proteomics and gene expression studies. The one thing so many of these AI models miss is they don't pay much attention to the clinical heterogeneity that exists among the population. Patients differ substantially in so many aspects, and for example, like ApoE4 carriers are known to exhibit accelerated hippocampal atrophy, which is very important, and they form a subgroup. They are, they have a different pathology to start with, and these things are important to identify. And and also so many AI models that we see in the literature, they don't have clinical relevance because they don't capture the clinically important information. Okay, so we have focused on detecting MCI using AI model, and also to assess the accuracy level of the AI model to differentiate between mild cognitive impairment and cognitively normal across different population subgroups based on the risk factor combination, which I'm going to show you what it means. The overall level of cognitive status of an individual, it depends on the degree of combination of the diverse risk factors or the biomarkers. So we have taken into consideration that our AI model uses data that is clinically relevant and cost effective. Okay, this is just an abstract of what our AI model can achieve. It can differentiate, taking these the different risk factors and biomarkers into consideration of an individual. It can differentiate cognitively normal individuals from someone who has mild cognitive impairment, and also it can identify someone who is slightly towards MCI, who is also towards cognitive normal. It gives risk score, like someone with normal cognitively normal can have a score of 0, and someone with MCI can have a score of 1, but someone in between can have a score of 0.3, 0.4, which means they're more towards cognitively normal. Someone with score of 0.7, they are more towards MCI, which means they have more risk and they should be more careful. Okay, so what we have done is like we have used the multimodal inputs. We have taken like so many different areas in the brain, and then we have measured the volumetric, the regions, and then we have used biomarkers like CSF, amyloid beta, tau, and p-tau. We have used the genetics like ApoE4 status, whether they have one allele or no allele of ApoE4 or two alleles. So we also used omics data, that is gene expression, and also we have used proteomics that are important to differentiate between cognitively normal and mild cognitive impairment. So we also use the cognitive assessment test that's all used in any clinic, any memory clinic, and something unique to our AI model is we have used depression, history of depression, because history of depression is very it's one of the most important risk factors for dementia. Of course, we have used age, gender, education. We have used education, race, ethnicity. So in total, we have like 68 input features that involve all these data types. Okay, so basically, we have used feed-forward neural architecture to build our AI model. We have this is a a deep learning model that uses, ReLU activation, categorical cross entropy as a loss function, and we have used 5-fold cross validation of the various input data, and then this AI model can give explainability of the different risk factors that's being used to give the risk score. I'm going to show you what does it mean. Okay. Okay, so that's a little bit more technical. Let's skip that. Okay, so what we achieved is classification accuracy for between the cognitively normal and mild cognitive impairment. So using only the biodata, like for example, the MRI, PET scan, CSF, ApoE4, of course, and the clinical data, the accuracy level we achieved was 74%. And when we added gene expression studies, the accuracy level improved. And when we added further plasma proteomic data, we achieved even more, like 87% accuracy. So the multi-omic data integration increases accuracy. And I mean, of course, it's not easy to do these omics tests for the every patient, but it can improve the accuracy. Okay, so this is something, see, where you can have an AI model, you can get an accuracy level to identify the different clinical subtypes, but the clinician should be able to understand what is AI model doing to all the data that we give in, all the input features that goes like clinical data, MRI data, the CSF data, the cognitive function data, what is happening to them in each individual. What is AI model using it? How is AI model using all the input data? So this can be explained by something called Shapley values. Shapley values gives the feature importance. Like for example, when we sorry. So what we have here is like top 10 features, mean top 10 features to identify any individual as cognitively normal. It uses a hippocampal volume. It uses the gender. It uses, entorhinal cortex, so many, and it also uses ApoE4, education. So these are the top 10. Okay, we have like, 50 features, but the contribution of other features are not very important here. But let's, focus on some of the important features that contribute to the, diagnosing, someone as not having any MCI. So what does it mean? Left hippocampus is contributing, left and right hippocampus is contributing more towards identifying an individual as cognitively normal, means they have a bigger hippocampus. If they have a bigger hippocampus, that's enough to say the individual is cognitively normal. If in the case of MCI individual, if the hippocampus is smaller than the mean value, then they are more likely to be MCI. So these are the important things, and you can see down like it's this is called these are called waterfalls. So what you see is again the same thing, the increasing contribution of hippocampus. The bigger the hippocampus, the individual is cognitively normal. The smaller the hippocampus, the individual is more likely to have MCI. So this is what you see when you, as an output, this is what you see, that the clinician can relate. Okay, if the individual has MCI because he has a smaller hippocampus, so that's easy for the clinician to understand what's going on. And also we have we are able to identify certain subgroups within the with individuals, because like, for example, if the individual has ApoE4, at least one allele of ApoE4, because they have the like at least 3 to 4 times the risk increases if they have at least one ApoE4 allele. And also if they have depression, if they have both, then you can see the prediction accuracy of our model is around 85 to 90%. And there are also some individuals who are in the group called like they have one allele of ApoE4, but they don't have history of depression. In that case, the AI model accuracy goes down. Okay, and then when there is no ApoE4 allele in the individual, but they have the history of depression, the accuracy level goes further down. And then when the individual had no ApoE4 allele and no history of depression, the accuracy goes down. So we have this. What is important here to know is the hippocampal volume is dictated by the presence of ApoE4 allele and depression. The bigger the hippocampal volume, the individual is more likely to be cognitively normal, or less likely to be MCI. And if you have history of depression, or if you have ApoE4 allele present, the hippocampal volume can reduce so much. You can see already. Yeah. Okay, I'm going to finish. Okay, so we have this in different subgroups that gives different accuracy levels. So our model is able to identify so many different subgroups in the entire population. Okay, so that's about subgroups. That's about the Shapley value, the Shapley values for the subgroups. And yeah, this is our model that can be, this model can be used to screen elderly individuals even before the symptoms appear. One can also use the model for the clinical trials to recruit patients at MCI stage, or even before the MCI stage, or you can have a risk score of MCI, and then this is easy for recruitment into drug trials. Okay, so that's basically inputs AI model. That's the output is a score between 0 to 1. Okay, so I don't want to go into the details, but again, the conclusions cover whatever we have identified some new genes from this AI model that are involved in MCI that we can discuss later. And what I want to add is adding the multi-omics data improves the accuracy of our model, and we have identified the inflammatory markers in our proteomics data. Yeah, so we want to work on the conversion rate from CN to MCI, MCI to AD. And also we need to validate the model using external data set. Thank you very much.
Thanks, Raj, for showcasing your work to us. I'm afraid we don't have time for questions, but we have got your contact details. So maybe ask the audience to write to us or approach you directly for any questions. I think we'll move on to our next talk. Krish is chairing that session, so I'll pass it on to Krish. If we could put on the slides or the, what do you call, the introduction for the next one.
Jay, can we invite you to join us? Yes. And Hitil as well on the table, please. Thank you. Good afternoon. It's great to have a session on traumatic brain injury, and thanks to Jas and Vivek for an excellent program, which is keeping us all really engaged. We have 3 excellent speakers lined up. Neeraj Agarwal, we miss you. It would have been nice to have you here.
Yeah, I miss you. Good afternoon. I'm sorry
Hi.
I couldn't make it this time.
I know. It's always a pleasure. Nice to see you online. And of course, we have Dr. Jay Salpekar and we have Dr. Hetal. Dr. Neeraj Agarwal is a consultant neuropsychiatrist in the Southwest London and St. George's Mental Health Trust. He's an honorary senior lecturer at St. George's and vice chair, faculty of neuropsychiatry of the Royal College of Psychiatrists, 2008 to 2014. Member of the examination subcommittee of the Royal College of Psychiatrists since 2008. Involved in setting and reviewing MRC Psych exams, and editor and board member for several prominent psychiatric publications, including Acta Neuropsychiatrica and the Australian New Zealand Journal of Neuropsychiatry. Neeraj, over to you.
Thank you. Thank you, Krish. Thank you for organizing such a lovely conference. I'm impressed by the program. I'll talk about TBI in adults. It's a very broad topic. Only so much can be done in half an hour. I'll try and give it a go. I know Jay is going to talk about children, and Hathel very helpfully is going to talk about sleep. So that makes probably my job easier. So I'll start with basics. And quite often people get confused about some of the terminology in brain injury field, and often confused between acquired brain injury, traumatic brain injury, head injury. And I think this is just for the juniors in the audience. And what I'm not going to talk about is the non-traumatic brain injury part of acquired brain injury. So any brain injury we acquire after birth is acquired brain injury, and that could be non-traumatic or traumatic. And non-traumatic brain injuries commonly we see in neuroscience as anoxic brain injury, but quite often people label things like cerebrovascular accidents, strokes, or infections as non-traumatic brain injury, but I'm not going to talk about that. And traumatic brain injuries could be open brain injuries when there is breach of dura and fracture of skull, quite often in relation to assaults or falls, or it could be closed brain injury, which is more often the case. And people often confuse between head injury and traumatic brain injury, and there is artificial differentiation, particularly in neurosurgical fields, about people who have had an impact to the head or some kind of injury to head, but did not result in any obvious neuroradiological evidence of lesions in the brain. So they try and differentiate, but we do know a number of people with mild to moderate traumatic brain injury would have normal CT or normal MRI brain scan without appropriate sequences. So brain injury could be caused by several different mechanisms, commonly direct impact injury, either with assault or hitting head against some hard surfaces. And that could result in focal injury to the area which is impacted on, but they can be contra-coup lesions on the opposite side. They can be without impact, they can be acceleration, deceleration, or rotational injuries, resulting in damage to various parts of the body, or it could lead on to diffuse axonal injury. The third mechanism, which again I'm not talking about today, is the blast injuries, which is common in war situations, or even in other civilian situations with some kind of terror incident. And the other way of looking at brain injury is whether it's a primary injury, and again, as I said, it could be either focal on the site of impact, resulting in skull fracture, coup contra coup contusions, or epidural, subdural, extradural hematomas, or it could be more diffuse, resulting in axonal shearing, diffuse axonal injury, or diffuse brain swelling. And secondary injury mechanisms can be sometimes forgotten. They could be in relation to cerebral hypoperfusion. Sometimes we see people may have, dissection of carotid artery, or, some other mechanisms which are resulting in cerebral hypoperfusion or dysregulated metabolism, resulting in excitotoxicity, mitochondrial dysfunction, and that could lead on to neuroinflammation and apoptosis. And when we look at impact injuries, so obviously, as I talked about, they can be hematoma or contusion on the site of injury or contra-coup contusions. But the most common sites of brain injury are frontal and temporal pole or inferior surface of frontal and temporal lobes. And that could be visible on either postmortem studies or radiological studies, such as a good MRI brain scan. So severity of brain injury has been described on these three main criteria. They were initially proposed by Russell, and they have been adapted in several subsequent classification systems, including VADOD or DSM-5, and essentially looking at the GCS score 13 to 15 is mild injury with post-traumatic amnesia of less than 24 hours, whereas severe injury is GCS 3 to 8 with more than 7 days of post-traumatic amnesia. Of course, vast majority of brain injuries are mild brain injuries. Different studies quoting about 85 to 90% of brain injuries are mild, and about 10 to 15% of brain injuries are moderate to severe. And Mayo Clinic criteria, which is more commonly used more recently, includes neuroradiological abnormalities as on CT scan, particularly intracerebral hematomas or contusions or fracture of skull with breach of dura. And also it creates a category of symptomatic possible traumatic brain injury where people have symptoms suggestive of a mild to moderate brain injury, particularly early neurogenic symptoms like blurred vision, confusion, dizziness, headache, along with other neurocognitive and neuropsychiatric problems, without a clear evidence of mild, probable, or moderate to severe injury. So their GCS score would be 15, and there's no loss of consciousness, there's no PTA, but people think there may have been a symptomatic injury. When we are looking at treating people with brain injury, so quite often I would get involved once people have been already dealt with on the site by ambulance services or air ambulance. They're taken to A&E department, they've been dealt with over there, they get admitted then either to neuro ITU or in our brain injury ward, and that's where we would get involved. And quite often services in elsewhere and many places in the world still, unfortunately, are very good in dealing with neurological or neurocognitive side, but neuropsychiatric elements like emotional and behavioral problems can get forgotten. So, so today I'm going to touch about a bit of behavioral issues in relation to moderate to severe brain injuries, but then I'm going to move on and talk a bit about mild traumatic brain injury. So this is the list. Essentially, these are the symptoms listed on Headway, which is the brain injury, the main brain injury charity in Britain. And they describe these symptoms, including agitation, anger, irritability, lack of awareness or insight, impulsivity, disinhibition, emotional ability, and the list goes on with depression, anxiety, and one can see this is not a comprehensive list, but we are looking at whole range of emotional and behavioral problems, and we would see specific anxiety disorders, including PTSD or specific phobias. We'll see issues with drug and alcohol, and some of those I'll touch upon. And many of these conditions may not neatly fit into a specific standardized psychiatric diagnosis, and quite often a number of clinicians in brain injury field would take more symptomatic approach than a syndromal approach of a particular DSM-5 diagnosis. And this is an example of referrals we would receive in outpatient clinic, once people have been through the acute neurorehabilitation and subacute neurorehabilitation, they've been back in community, they've been through community-based rehabilitation, they've just been out of all brain injury pathways. They're living in community, but problems quite often don't go away, particularly from neuropsychiatric perspective. So this is a young man who had moderate to severe brain injury in a road traffic accident 3 years previously, clearly had evidence of diffuse axonal injury grade 3 with microhemorrhages, and continues to remain quite irritable, argumentative, managed to get driving license back, but showing road rage, getting inappropriate in his behavior, showing lots of risky behaviors, including disinhibition, that issues with financial spending, decision making is poor. And I think families get more and more concerned and frustrated themselves about managing an individual who they thought, been through all the brain injury pathways would be better by now. But these problems persist. And looking through, this is one of the old studies, I think Scandinavian studies have long-term data, and using DSM criteria, the rates of various problems are higher than general population, and you can see a whole range of problems there. We see lots of people with organic personality and behavioral change. That's the diagnosis given for all sorts of neurobehavioral problems. But we would see a whole range of problems. Psychosis rates are increased. Depression is higher than general population, anxiety disorders, etc. But many people do not, as I said earlier, fit in neatly into some of these diagnostic categories, and it becomes difficult to think about which diagnostic category to use within DSM-5 or ICD-11. And quite often we think about brain injury, we think about where is the brain damage, what's the extent of brain damage, how big was the contusion in the frontal lobe. But that's not all of the story in terms of why somebody might present with those problems. There can be a number of other factors simultaneously that could affect the presentation, neuropsychiatric presentation after brain injury. There can be issues with mental constitution, pre-morbid personality. There can be past psychiatric conditions. There might be ongoing psychiatric problems at the time of injury. And we know young people, particularly with cluster B personality traits or cluster B personality disorders, could be more impulsive and risk-taking, and might be involved in road traffic accidents or get involved in fights resulting in assaults or brain injury. There can be issues in relation to circumstances of injury, and quite often psychological reactions, including post-traumatic stress disorder or depression or anger, could be related to the repercussions of injury or circumstances, how it resulted. There can be subsequent environmental factors, including issues with employment and finances or relationship, that could affect psychological reaction to their condition or predicament. There may be subsequent iatrogenic factors. People may develop post-traumatic epilepsy. People may have infections. They might be on medications that might be causing problems. There might be reactions to their cognitive impairment and difficulty. So there are a whole range of issues which could lead on to various neuropsychiatric issues. And one of the problems, again, in terms of terminology of how we label various behavioral problems, sometimes people describe problems as neurobehavioral problems or agitation, and quite often agitation word gets used in a very vague way to describe a number of these behavioral problems. Somebody might be presented with aggression or anger. People might just use the word agitation, or interchangeably these words can be used. But there is a whole range of problems, including emotional dysregulation with lability, somebody presenting with frequent changes in mood, low frustration tolerance, irritability, and anger. They might be disinhibited not only sexually, but generally verbally, in the way they might talk or overshare their information, creating various risks. And impulsivity itself can be defined as, unplanned actions without thinking through the consequences of their action. And it's a multidimensional concept, and it could be behaviors are due to different factors, different underlying etiology. It could be motor impulsivity, where people are getting up and doing and acting without thinking. It may be more cognitive, where some decisions are made without considering the consequences, or or non-planning impulsivity. Barrett described as a reactive form. You just see something, you react again without thinking through, and all of these can be associated with its own problems and day-to-day behaviors. And those neurobehavioral issues, aggression, impulsivity, again, it's not just based on the severity or nature of brain injury or degree of cognitive impairments. And again, cognitive impairment, particularly executive impairments, are important in this area. But they can be pre-existing personal factors, pre-morbid personality, pre-morbid psychiatric issues, drug and alcohol issues. There can be issues about concomitant psychological state, their degree of anxiety or depression, and their self-confidence. And there are a number of other environmental factors which could contribute to it. And we have noted several different ways of describing some of these behavioral problems. Frontal lobe syndrome, again, one of the terminology which sometimes goes on. But it's not just a frontal lobe pathology that leads on to some of these emotional and behavioral problems. But of course, ventromedial or ventral surface or frontal lobe, it does lead on to a degree of behavioral problems, which was previously described as pseudopsychopathic, whereas prefrontal lobe and dorsolateral surface quite often leads on to more of dysexecutive dysfunction, more neurocognitive, but it could be associated with its own behavioral problems. And we do see people with frontomedial surfaces, pseudodepressive kind of pathology with prominent apathy and abulia, which can be confused with depression, but it's different, and of course, treatment has to be different. And one of the things which get talked about, particularly in neuropsychological circles, is the concept of frontal lobe paradox. And essentially, it's seen in, again, people with more inferior surface of frontal lobe pathology, where people would perform reasonably well in structured neurocognitive assessments, but would struggle in day-to-day life. They would show a number of neurobehavioral problems. And neuropsychologists, it was described in 80s and 90s as frontal lobe paradox. But in my view, really, is there a paradox? We do know different part of frontal lobe lead on to different kind of presentations, and I don't see it as a paradox, but I think one has to be aware of that. People can do rather well in structured setting during our assessments, but they may not be able to behave in real life situations appropriately. And alcohol and drug misuse is a big issue. Quite often, particularly young men, they already had pre-existing personality problems. They may have pre-existing alcohol and drug use. But after the brain injury, post-injury neurobehavioral problems, neurocognitive impairments can make it very hard for them to be able to control their drug use, and they could continue to be affected. And then that, of course, then leads on to a negative impact on their mood or neurocognitive functions, and it becomes a persistent problem. Yesterday, Zarina talked about the concerns about TBI and criminal behavior, and particularly in prison setting. I'm not going to go and talk about that, but of course that remains a problem. And risk of suicide is increased after brain injury. And I think it's initially people used to think it's only moderate to severe brain injuries, but even in mild injuries, the risk of suicide is increased. And that's more common, particularly people who have pre-existing psychiatric issues or pre-existing personality or impulsivity problems. Okay, so I'm not going to go and talk more about moderate to severe brain injury. Generally, like I said, there can be other range of emotional and behavioral problems. People present with depression, which is more likely to be treatment refractory, more likely to be persistent. And that's more common if people had past history of depression or anxiety, or more common if people had ongoing depression at the time of brain injury. And that needs to be identified and treated. And a whole range of anxiety disorders, people can have post-traumatic stress disorder, which is probably more common in milder end of this mild to moderate end of the spectrum than severe, but even severe brain injuries with significant post-traumatic amnesia, people can have post-traumatic stress disorder. And many people may develop other phobic anxiety disorders. They might be phobic of certain situations like crowded places, busy places. They might be intolerant to noises or lights, and that can create phobic responses in superstores or town centers or pubs or restaurants. People may have specific phobias to travel or using public transport. And I think that could lead on to significant dysfunction. So again, I'm not going to go a lot more into that, but let's talk about mild traumatic brain injury, which, as I said earlier, is vast majority of brain injuries. And unfortunately, the situation remains in vast part of the world that people may present with mild traumatic brain injury to A&E. They may or may not get a CT head scan, and quite often they are discharged with a reassurance and a leaflet, and they then subsequently receive very little input unless they continue and go and seek and knock doors of their doctors again. But our systematic review showed that just providing reassurance and leaflet was not sufficient as a treatment outcome and wasn't leading on to the best possible outcome. People did need more robust psychological and behavioral problems and looking at the underlying individual problems. And this is particularly a concern now in sports field and in children. And I'm sure Ajay probably would be talking about some of that later on. And sports, it has become a big issue, and so much so that more recently in British rugby, people are given a specific helmet, and there are studies going on. There are lots of prospective studies going on where there is very robust data in concussion in sports and schools, and there is vast amount of money being spent, and rightly so, because some of these sports and some of these situations lead on to recurrent and more than one concussions, and we do know repeated concussions can lead on to more significant problems. But again, there are a number of controversies, and particularly more recently, there are issues about terminology and diagnosis. So as we know, in ICD-10, there was a category of post-concussional syndrome, and it was a syndromal approach where people presenting with a range of neurological, audiovestibular, neurocognitive, and neuropsychiatric symptoms, and if they lasted for more than 3 months, were diagnosed as, or more than 3 symptoms lasting for more than 4 weeks were diagnosed as post-concussion syndrome. But that category has now been removed from ICD-11 as there is more growing desire to diagnose those symptoms individually, more specifically rather than using a syndromal approach. But that may not always be possible, and people continue to present with the same range of symptoms and problems in clinical life. And as I said, word concussion is not only being used still commonly in routine clinical practice, it's becoming even more prominent in certain fields like sports-related concussion areas, or all the studies in children are commonly using word concussion still, even though it doesn't exist in DSM-5 or ICD-11. And this is one of the recent papers from Jenkins and Clark and Dave Sharp's group from Imperial College, and they essentially said that we need to look at specific clinical diagnosis of individual symptoms, and which is a good idea when we look at neurological or audiovestibular problems. So if somebody is presenting with dizziness or unsteadiness, is it BPPV? Do they have any other central or peripheral vestibular problems? And they should be assessed, diagnosed, and treated. Similarly, headache, if it's a migraine or post-traumatic headache, or if somebody develops epilepsy, and those kind of things, need to be assessed and treated appropriately. But when we come to neurocognitive or neuropsychiatric problems, their proposal to try and diagnose them as depression or anxiety or PTSD, and whilst some people do have those conditions, not everybody can be diagnosed as depression or anxiety disorder in these situations, because these people present in a different way. They are not typically depressive symptomatology, although depression is one of the symptoms. And the other proposal by some of the groups more recently has been to diagnose them as somatic symptom disorder or functional neurological disorder. And while some of the mechanisms in maintaining some of these symptomatology could be similar to FND, that's not always the case. And some of the studies have shown that. And I can understand the discomfort that some of the clinicians, particularly neurologists, would have on making syndromal diagnosis, because neurological diagnoses are quite often etiological diagnosis and specific diagnosis, whereas in psychiatry we are more comfortable in making some syndromal diagnosis. Most of our diagnoses are a syndromal approach with a constellation of symptoms. And there will always be lumpers and splitters, and whatever we do, I think, to me, it is unhelpful to reassure a patient that you had a very mild brain injury, but actually you have 10 different diagnoses caused by that, and you'll be fine in 2 months. And I think there is inherent issue with that. So the other controversy about mild traumatic brain injury is about persistence of symptoms. And I know I still meet clinicians, and particularly in medical legal setting, where somebody would say, well, this person had a mild traumatic brain injury, their GCS was 14, their post-traumatic amnesia was 2 hours, they should not have any symptoms beyond 3 months. And that's not true. None of the studies show that. Our studies consistently show a significant minority of patients have persistent symptoms. This is Tato's group from Toronto, Canada, and they found about 12% of people had persistent symptoms after 2 years, with median duration of 7 months, and range was 0 to 26 years, and quite a number of symptoms. The average number of symptoms was 8 in their study. And a number of those people had more than one mild traumatic brain injuries. And there was a whole range of symptoms that persisted. So it wasn't just psychiatric symptoms. They had persistence of physical somatic symptoms. They had affective and cognitive symptoms. The whole range of symptoms persisted for the brain injury. And what was worrying was anybody who had persistent symptoms for more than 3 years in their cohort didn't show any further recovery. So not only there are persistent symptoms, but if they are not dealt with early on and managed appropriately, those symptoms are persistent and are unlikely to improve. And this was a sizable cohort, and I think it didn't include people who were going through ongoing litigation. So one of the factors people often worry about is litigation. In their group, it wasn't the case. And not only these problems are persistent. They are also associated with problems, disabilities, particularly employment. And in this track TBI study, about 20% of people were not in employment at 1 year after mild traumatic brain injury. So these are persistent problems, and they could be associated with disability and dysfunction. The other issue
Neeraj,
people raise
about 3 minutes to
Oh,
go.
3 minutes. Okay, I'll try and wrap up. So other concern people raise is about non-specific symptoms, and they previous studies they said, well, these symptoms could be seen in orthopedic injuries where there's not been any head injury, but track TBI shows when comparing with orthopedic control, people who had the top two lines are men and women with a mild traumatic brain injury, and you're looking at cognitive, emotional, and somatic symptoms, and they are at higher level then. So these are not just symptoms which could be, yes, they are symptoms which could be seen in other conditions. So sleep disorder or irritability or anger or anxiety or inability to concentrate could be seen in a number of conditions, but this is a particular way people present. And again, in this study, they found that the odds ratio was 1.57 for people when compared to mild traumatic brain injury compared to orthopedic controls. Some people get concerned about that these are they are having symptoms, but they are not due to brain injury. When you look at the comparison with mild traumatic brain injury, complicated mild traumatic brain injury, and comparing with the moderate to severe brain injuries, there seem to be a dose response curve, which again indicates that there is impact of brain injury. And I'm not going to go into details of that due to lack of time. And in this study, when they compared track TBI data with center TBI, when they looked at the disability itself using Glasgow Outcome Scale Extended, when they looked at people just with disability score less than 8 in the first set of table, then there was impact of neuropsychiatric factors. But when they looked at specifically people with score less than 5 who were bit more disabled, neuropsychiatric factors were not relevant. So there is effect of brain injury, and this old confusion, is it what patient brings to the injury more important than people with mild traumatic brain injury, or is it what injury brings to the patient? And it seems like it's a bit of both, and we cannot ignore the fact that injury does affect people, and it's not just all non. And in this study, the Cambridge group, they looked at people who presented with persistent post-concussional symptoms, and there was thalamic hyperstimulation. This is, again, another study when people have looked at using biomarkers, particularly NFL and GFAP, and that could help in identifying who are the people who should go for functional MRI or DTI, and that could help with the symptoms. So there are a number of these myths which can be debunked, and we got to start to take a mild traumatic brain injury seriously, and we have to recognize there are persistent symptoms which are disabling, and they are not just non-specific, and we have to go back to what we heard from Hippocrates. No head injury is too severe to despair of. We can deal with. A number of people with severe brain injuries do well eventually with appropriate rehabilitation, but there is no injury we shouldn't be ignoring, particularly mild traumatic brain injuries. Thank you. Sorry, I think I may have gone a couple of minutes extra.
Thank you, Neeraj. No, you're quite on time. That was just me being nitpicky.
No, not at all.
Thank you for a nice talk. We'll take questions in the end, if that's okay.
No problem.
Now we have Dr. Raman join us as co-chair. Dr. Raman is a consultant psychiatrist in Chennai and works in the Apollo Hospitals, Vanagaram. Dr. Raman, would you like to introduce the next speaker, Dr. Jay Salpekar? Okay, switch on that mic.
You can change your button. Sure.
So, good afternoon, everyone, and sorry for being late. Thank you for the opportunity, sir. The next speaker would be Dr. Jay Salpekar, and he is currently the Director of Neuropsychiatry at Kennedy Krieger Institute and Associate Professor of Psychiatry and Neurology at Johns Hopkins University. He has almost 25 years of experience as an academician, and he's in the journal editorial board in 5 journals. And he holds leadership positions in almost 3 professional organizations: American Epilepsy Society, International League Against Epilepsy, and American Neuropsychiatric Association. And he's a past medical staff president at Kennedy Krieger Institute. Almost over 400 publications, including original research, commentary, book chapters, and 1 textbook published and 1 in press. He has a lot of invited lectures on 5 continents. And he's a distinguished fellow of 3 professional organizations and Kaufman Award of Ethical Neuropsychiatry. So it's a pleasure to hear you, sir. Over to you.
Thank you so much. It's a great pleasure to be here and to participate in this symposium. The lectures have been uniformly wonderful, I have to say, and I've learned a lot, and I'm glad to be talking about this subject also. So this is part of our neuropsychiatry program, and rather than give a really meaty talk here with a lot of details and all that such thing, I'd like to talk about what we do and maybe be a little challenging to maybe our accepted notions. After all, that's what children do to us. So why not I turn it around and return the favor? So in any case, I have spent a long time at Kennedy Krieger Institute as director of the Neuropsychiatry Center. And mostly I want to bring this back to us. You know, what are we doing? Is this one field or 2? Maybe it should be 1. But in every sense, there's a paradigm shift. Otherwise, we can't properly understand these illnesses. And specific illnesses reflect a marked overlap. Some of the ones that are particularly prominent include TBI, which is our subject today, movement disorders, tics, epilepsy, intellectual and developmental disabilities, dysautonomia, and neuroinflammation. There are others that fit into that category, and certainly I would call your attention to our textbook, a Pediatric Neuropsychiatry Case-Based Approach. It is available online, and I'd be very happy to provide anyone with a copy of it. Second edition is coming out soon. So neuropsychiatry is about overlap. We see this all the time clinically, and the more that we do research and study it, we will see it in the research realm as well. Epilepsy and anxiety is very common, not only as an ictal state or a periictal state, but also interictally. Tourette's and OCD, we heard a very nice lecture about that from Dr. Epen. ADHD and learning disabilities, we've heard a lot about ADHD. And I'm going to make the point to you and be persuasive, I hope, that there's overlap between ADHD and TBI. If not etiologically, then certainly phenomenologically. TBI sometimes is hard to understand and hard to sort out, but I think if we use our ADHD lens, we'll understand a lot more about what's happening with TBI. And I think in pediatrics, that lens is even more focused. So I won't repeat everything Narouj said, but at least know that TBI is common, certainly more common in males, especially in younger ages. For a pediatric point of view, it's usually as a pedestrian or riding a bicycle that we see a lot of these head injuries. For adolescents, it's often sports or motor vehicle accidents. One thing to know is that American football is probably the #1 source of concussion for males. Soccer or football in the rest of the world is #1 for females. So do keep that in mind, that many females will have head injuries and potentially concussion symptoms. And actually, soccer is not so safe for males either. It's #2. There are varying degrees of reasoning why that is the case, but we can discuss that if there's time available. And 90% of traumatic brain injury is mild. We're not really talking about the moderate or severe symptoms at this point because most of what we see will be mild. Even if it is mild, the effects can be quite traumatic, and in pediatrics especially, we may interrupt development. You can imagine that if there is a sensitive period of development, cognitively, socially, after all, if you have a young child who's just beginning to develop and consolidate networks of concrete reasoning, logical sequential processing, and if there is a concussion or a traumatic brain injury, those types of developments may be delayed. Not only that, a single episode versus a repeat episode is very important. That's why we're very keen to give precautions to our athletes once they've had a concussion, because sometimes a single concussion is not the riskiest occurrence. It is really the second, or we don't want to think about that, but a third concussion can sometimes be quite damaging. We've heard a lot about the effects: mood, sleep, memory, cognitive functions, headaches. And just note that if the injury, even if mild, we may have localizations of axonal injury or encephalomalacia that can be identifiable on MRI scan or PET scans. And at worst, sometimes these can develop into seizure foci. Remember that the brain is a moving target in children, and a lot of these networks do not consolidate until early 20s at a minimum sometimes. And what happens during much of adolescence is consolidation of these networks, myelination, and significant develop and refinement of cortical and subcortical connections. If those don't happen properly, then we will have ripple effects. There will be consequences. So, ADHD, I'm going to talk a lot about this because it helps us understand what happens with traumatic brain injury at this age. Now, no surprise, ADHD is associated with more injuries and more emergency department visits. No question about that. In fact, I have one particular anecdote that I've repeated many times. I had a family with 3 boys with ADHD. Every time they went on vacation, they would literally test drive a route to the nearest acute care center or emergency room, because every so often, more than every so often, they wouldn't end up availing those services. So better to have a practice run. Yes, they don't look before they leap, so they can suffer more injuries. They don't plan ahead. And no surprise, they will have more injuries. But also note that recovery from TBI can be influenced by ADHD, and both conditions are characterized by impulsivity. These are frontal subcortical connections. And if you have disinhibition or some sort of frontal disconnection, a lot of the symptoms that we will see have to do with impulsivity. They have to do with a lack of cognitive throughput or processing. And we do think that that is probably the most robust, at least anatomical finding in ADHD, is some sort of subcortical pathology, maybe inefficient caudate nucleus processing or lack of metabolic efficiency in subcortical structures. And that is a very robust finding for ADHD. No accident then that we're going to see some sort of symptoms resulting from a mild traumatic brain injury. Note also that the subcortical structures, caudate, putamen, and globus pallidus, are highly GABAergic. That's gamma aminobutyric acid. GABA is an inhibitory neurotransmitter. When GABA is binded, when it is triggered, it opens a chloride channel. So we have hyperpolarization of nerves. A lot of these GABAergic nerves are on interneurons. So GABA is widespread, but particularly in subcortical structures like the basal ganglia. So if we are lacking apparatus for inhibition, then we will become more impulsive. And that's what we see with some of these basal ganglia pathologies like ADHD, like movement disorders or Tourette's, and a head injury that causes some sort of disconnection may also yield impulsivity in that case. So let's talk about what we see. Sleep disruption is probably key. Sleep disruption, headaches, we see that more than anything else, I think. There are others, but once someone has a head injury, there's a homeostasis that seems to be disrupted where we can't actually settle or tune down to the degree that sleep onset can be efficient. Migraines or headaches, sometimes people get very photosensitive and they need to have accommodations in order to address the headaches. Visual problems can be quite significant as well. Sometimes diplopia or difficulties with accommodation. Of course, concentration problems. More than anything else, people complain about reading problems, it seems, because reading requires a lot of cognitive skills in order to eliminate stimuli that are distracting, requires significant concentration, a lot of information throughput. So reading is a complex task. And for an adolescent or pre-adolescent, that's usually what you do. You're assigned to read, you're assigned to write. So that's a big problem. And then mood change. We heard Naruj talk a little bit about irritability and impulsivity and depression, dysphoria. That's very common. And certainly irritability is common for mood disorder. It's probably the sine qua non for dysphoria in children and adolescents. So if we see irritability and mood change as a result of a concussion or a mild traumatic brain injury, we have to be very careful about the presence of depression. So we should address some of those issues, reduce the amount of reading, use audiobooks or other types of information sources that can reduce eye strain and significant concentration difficulties. Most people that I see that have had a mild brain injury need some kind of flexible schedule for schooling. They just can't tolerate a day-long school day with numerous reading tasks and writing tasks. We'll have to break that up and be flexible. They don't have the stamina. Lighting changes and reducing stimuli, sometimes that can be a very easy but clever accommodation that can improve stamina for some of these kids. So keep those things in mind as well. This is Jeffrey Max actually in his chapter wrote about the NIH toolbox testing. And these are some very good measures. I have to admit that I don't use them all, but most concussion and mild traumatic brain injury is assessed by neuropsychologists, and they will, of course, obtain all of these measures. The problem that I see is a lot of these scores and a lot of the results can be very subtle. Sometimes, especially if someone has a high intellectual ability at baseline, their scores can be quite high and they will still be high after a concussion. So there may not be a whole lot of variance post-concussion. So sometimes the measures are not particularly useful. Now, all bets are off if it's a moderate or severe brain injury, and then we can see a signal. But for the most part, some of the mild TBIs, we won't see a whole lot of change. But these are very good tools, and if we do need to set a baseline or have a detailed analysis, then this can be helpful. Additionally, I will say that sometimes to justify accommodation changes and flexible school schedules for different school districts or administrators, sometimes you need to have some sort of test results, and these would be a good place to start if such data is required. Okay, we're going to talk about ADHD for a little bit. So children with ADHD have more concussion-like symptoms at baseline. This is going to be a theme. So even without a concussion, they have symptoms like balance errors, hyperactivity, instability, and it's really a result of impulsivity and not looking before they leap and being careful about how they're moving because they're hyperactive, they're impulsive. So we will see that they, in fact, can perform similarly to children with ADHD. So look at all these symptoms. Now, if you have ADHD, you're more likely to have severe symptoms. If you don't have ADHD, you're unlikely to have them. But think about our kids that have had a concussion or a mild traumatic brain injury. I see double. I feel sick to my stomach. My neck hurts. I get tired. I have troubles remembering. I daydreaming. I get confused. Well, those are all the symptoms that we see with concussion. It's as if they have ADHD acquired following that sort of injury. So it's a very interesting dichotomy between ADHD and concussion that may not actually be a divergence. It might be the same type of phenomenology that we're talking about. Now, not only that, but an early traumatic brain injury actually may lead to ADHD, especially if it happens early, before age 10. And we see this with epidemiologic studies, and this has been replicated, not as well, but these are very interesting studies where we say, you know what, think about the recovery time. You know, if it requires, Narouge gave us data that it can take 1 to 2 years to recover from a concussion. Well, if you're an adolescent or a pre-adolescent, you don't have 1 to 2 years, you know, or 3 years it can take to recover. You're going to have significant developmental difficulties because of this injury. So there we go again. Acquired secondary ADHD. The data suggests that this is a real phenomenon. And it's even worse if it happens in preschool. So at an early age, and think about these subcortical networks. The caudate nucleus and other basal ganglia structures, these are early maturing structures. So if you disrupt the consolidation that will happen in these structures, we are going to have more impulsivity. We're going to have more distractibility. It is going to be very difficult to filter out extraneous stimuli as a result of this injury. So we talked about this a little bit. My family certainly underscores this point that if you have ADHD, you increase your risk. That's perhaps intuitive to expect that. And that has been replicated a couple of times. Twice as many youth with ADHD had a parent-reported history of a concussion compared to youth without ADHD. That's amazing. I mean, if we, had a class action suit with those kinds of numbers, I think there would be a lot of activity, a lot of litigious activity, perhaps. But that's it. ADHD increases the risk. Now, even then, you may have identifiable ADHD years later, 5 to 10 years later. And this is a really clever study looking at children with no ADHD pre-injury and then following them for a long period of time. So 5 to 10 years, and this is in JAMA Pediatrics from 2018. So good study. And what we know is that the ripple effects from a TBI are quite significant, and it makes people look a lot like they have ADHD. So I hope I'm being persuasive at this point, but in fact, even if you have ADHD, your recovery time will be longer as well. So it's harder to recover even after an injury, particularly for specific learning aspects, attention span, cognitive processing and thought processing criteria, all of those neuropsychological parameters that were in the toolbox. Now, I'll get to treatment in a little bit, but this is an important point as well, because sure, there's a lot of overlap between ADHD and TBI, et cetera. But if you actually treat the ADHD, which I think we've heard from Dr. Coghill and from others, at this conference, that not everybody gets treated, and sometimes not the correct people get treated. But if you actually treat ADHD that is comorbid or associated, then we will recover from the concussion as well. And you can see that, with matched controls, if you actually use a stimulant, you can improve quite a number of parameters, memory, motor, etc. So what I would suggest for any patient who comes in with a TBI or a concussion, there's a few things we have to do right away. Number one is to encourage rest. Don't try to power through it because the stamina will take a long time to recover and it might just cause frustration and irritability, and frustration tolerance will already be low in that situation. Sleep is an important parameter to measure. If you can regulate sleep or have it be more predictable, then often that enhances recovery. Make some accommodations in school. A stimulant for attention or memory problems, certainly if ADHD is present. We don't want to, this is not a good time to reduce stimulant doses or to try a medication-free trial period. This is a time to continue that medicine. Alcohol or other substances, it's pretty amazing how a lot of adolescents, in fact, they will turn to substance abuse after having a concussion. Remember, these were often very functional teenagers. They were athletes. They were in a position where they could get a concussion because quite a few of them happen from sport. So all of a sudden they have to change their ways. They will get depressed and they'll be vulnerable to other types of temptations. And then the most important thing is to avoid repeat concussions because it may not be the first one that is damaging. It's the second one and then the third one that can be particularly damaging. So there have been studies. I did not want to put them here because there really are too many confounds. Some of the best data is with methylphenidate. I think that's probably a nod to the overlap between ADHD and concussion, that there's a co-occurrence of those two conditions quite often. We might as well treat, so we can use methylphenidate post head injury. Certainly if it's within the acute phase, within the first 90 days, then we can see some accelerated improvement. There's reasonable data for amantadine as well. I say reasonable because none of these things are very robust. And the problem with both of those studies is that after about a year and a half, both groups, whether they're treated or not, they look about the same. So I'm not sure what to think about that. But certainly you want to identify depression, identify substance abuse, and have a family focus, because there are studies that show that the family environment, the family dynamic changes significantly. You can imagine parents, rightly so, being very afraid about a second concussion. So they will guard their children and prevent them from doing any of the normal risky childhood behaviors because you don't want to get a second concussion. There are some good resources. The military has done a very good job of studying concussion, and the unfortunate gain from a lot of blast injuries has been that we've learned a lot about what happens with concussion and axonal injury. So we do have information on that, and there is support that can be obtained by looking at those types of things. So definitely consult resources as they're available. But I'll sum and just say, I hope persuasively, pediatric concussion and ADHD frequently overlap. ADHD increases injury risk and can significantly slow recovery. The symptoms may look similar. I think that's no accident, especially in pediatrics, because think about cortical, subcortical networks, disconnection, and think about areas of the brain that mature at different rates. And if we catch some sort of development at a vulnerable state, then we can have significant consequences. And then I would say managing both conditions together improves school mood and recovery outcomes. And we will leave it there. Thank you.
Perfect timing. Thank you both. Our next speaker is Dr. Hetal Kumar Mehta, and I'm going to request again Dr. Raman to do the introduction. We will take questions at the end.
So our next speaker for this part of the symposium is Dr. Hetal Kumar Mehta. His current affiliation is consultant neuropsychiatrist, sleep medicine service, Aintree University Hospital and Brain Injury Rehabilitation Service, Mercy Care NHS Foundation Trust. He's been trained in forensic and neuropsychiatry. He's completed legal practice course and a degree and master degree in law as well. He's completed his master's in diabetes. His past positions include Associate Director for Research within his NHS Trust between 2022 to 23. Was an editorial member of, board member of British Journal of Forensic Practice. He was a lead for neuropsychiatry and interim lead for addiction service, job planning manager, medical member.
That's enough.
Yeah, sure. Okay, so the topic that Dr. Hetal Kumar Mehta will be touching upon is TBI and sleep disorder. Over to you, sir.
Thank you so much. Thank you for the generous introduction. I'm already feeling dwarfed after the two excellent speakers and their presentations, and my presentation is going to be a little inadequate. Let's start. Is it this? Yeah, so I'm going to talk about sleep in acquired brain injury. My disclaimers. So I want everyone to, well, I don't want everyone to get out of their chair and do a little jig, but at least wave their hands so that I can know that they are all awake. Yes, and I'm going to test this hypothesis today. Yes. So let's see if my lecture puts you to sleep or not. So I'm expecting you to sleep. That's my null hypothesis. I have no financial disclosures to make and no conflict of interest. Okay, I'm going to try and talk a little bit about normal sleep. I introduced that just last night because I thought there were a number of students in the audience. We'll talk a little bit about my audit findings on my ward. I'll focus mainly on moderate to severe brain injuries because that's what my practice is. I'll talk about the sleep journey of TBI patients from post-acute stage up until 3 years and what the research actually shows around their journey. I'll talk a little bit about TBI and circadian rhythm, insomnia, excessive daytime sleepiness, and what I feel researchers should look at. I'm a primary clinician, I'm not a researcher, but I think there are a couple of things that we need to look at. Hey, so normal sleep. I love this definition of normal sleep. It's a reversible behavioral state of perceptual disengagement from and unresponsiveness to the environment. I think that perfectly fits normal behavioral sleep. We usually spend about 75 to 80% of our time in non-REM sleep, which is the slow wave sleep. Go from stage 1 to stage 2 and then stage 3 and 4. Usually stage 3 and 4 are clubbed together, but separated out for research purposes. The ascent out of sleep is with body movements, 1 to 2 minutes into stage 3, and then go up to 5 to 10 minutes, go into stage 2, and then we all go into REM sleep. REM sleep is usually just 20 to 25% of our normal sleep. And what happens is in the first part of the night, we all go into non-REM sleep. And then as the night progresses, we have more REM sleeps. Okay. Just a little hypnogram and the EEG waves to identify the different stages of sleep. I won't go into too much detail about this. What is important to note is I'll come to what is a subjective state of feeling sleepy or being in sleep, because it's quite important. So like I said, non-REM sleep during the first third of the night, driven by the homeostatic system. So there's sleep pressure, and then there is the recovery phase. I like this definition of non-REM sleep, that it's a relatively inactive yet actively regulating brain in a movable body. So that's quite important, because when you contrast that with REM sleep, it's an activated brain in a paralyzed body. That's quite important because we see a lot of REM behavior disorders where the paralyzed body bit is affected. So the atonia is lost. And REM sleep is driven by the circadian system. A little anecdote, and I'll come to that maybe a little later. Okay, so age transition. So what happens is, in infants, when they wake and then they go into sleep, they go into REM sleep. And as we progress through our childhood, you can see that the sleep-wake cycles consolidates around 6 months of age. And then the slow-wave sleep is maximal in younger children up to the age of 10 years. By adolescence, we could skip the first REM cycle and continue with the non-REM sleep. And then suddenly, in the second decade of life, as the brain matures, like you were talking about, the maturity takes about early second decade of life, slow wave sleep reduces by 40%. And by age 60, it reduces in men even further. Now, REM remains stable, but you will see that the REM gets affected in progressive neurological conditions. So that's an indicator for progressive neurological condition. And people might know that people with REM behavior disorder, there is a likelihood of an 8% conversion rate to Parkinson's disease on a year-on-year basis. So stage 1 onset of sleep does not usually coincide with subjective feeling of sleep. And a lot of my patients will come to me and say, I've not slept for several days. And that's not possible. People will go into sleep. It's just that the subjective feeling is not there. And that's why it's very important to establish what is their subjective feeling and what are the factors that are related to that. So it is not a unitary concept. So sensory awareness is affected, and there are several studies around that. Latency of response to a stimulus is affected. If you remember the definition, it's disconnection with the environment, a temporary, reversible state. Continuity of logical thought is affected, memory is affected, self-awareness or consciousness is affected, and then there are changes in the brain, EEG. And all these combined will give a subjective sense of being in sleep. So sleep onset is different functions get depressed in different sequences to different degrees in different subjects on different occasions. So this is very apt because there are different parts of the brains that get depressed in different sequences in a number of patients to a different degree. So we'll see a lot of non-REM parasomnias where different parts of the brain get depressed in different sequences and different degrees, and that's why we get those disorders. Simple behaviors can actually continue in and out of sleep. fMRI studies have shown that certain areas of the brain are activated in response to meaningful stimuli when they are in stage 2 of sleep. So if their names are called out, they will respond. But if you hear a non-meaningful sound, you are unlikely to respond to that in your stage 2 of your sleep. Then when people were given word pairs to remember for the 10 minutes before they fall asleep, there were 2 groups. One was woken up after 30 seconds into their sleep, and the other was woken up after 10 minutes. And they found out that people who were woken up later on, their memory for the 0 to 3 minutes before sleep was impaired. They could not remember the word pairs. What that tells us is that it takes time for memory to get consolidated in sleep. And there wasn't enough time for the encoding to happen to allow for recall. So a lot of our patients will tell us, I don't know exactly when I fall asleep, because the memory just before you're falling into sleep is always impaired or mostly impaired. And then there is this concept of sleep deprivation. So this is what I was going to talk about, and I have experienced this recently. So I went to Tirumala, was awake for about 38, 39 hours, sleep deprived,
And then I was supposed to wake up again early in the morning the next day, and I slept through 3 alarms. And I think that is what had happened, because my sleep deprivation caused the slow wave sleep to rebound. So it was very difficult for me to wake up. And what happens is the REM actually rebounds second and third day after the sleep deprivation. And I'm actually experiencing that now, because last night was terrible again, and it was more with a lot of dreams. And you'll know that we dream or we remember our dreams a lot in the REM cycle. So what I tell my junior doctors is the easiest way to differentiate between night terrors and nightmares is that you remember your nightmares. Yeah. So remember is REM sleep, REM, remember, and night terrors are non-remember. So non-REM. That's how you distinguish between your night terrors and your nightmares. And then just some effect of some drugs on sleep. I won't go into too much detail of this, but it can affect both your slow wave sleep and your REM sleep. Okay, so last year's data, unfortunately, I did not get time to update it, but 30 patients, predominantly male, average age was 55 years. 1/3 did not report any sleep problems post-acute brain injury. Now, this is moderate to severe brain injuries, includes all types of brain injuries, not just traumatic brain injuries. One of the patients was unable to tolerate any sleep study, and I'll just present that patient after this slide. So what you'll notice that this is similar to what you'll find in other observational and longitudinal studies that have been published previously as well. So this patient was an adult male, had an aortic dissection, had a cardiac arrest, went into anoxic brain injury, had cortical blindness, had complete reversal of his sleep cycle. And we thought he had other sleep disordered breathing and sleep, probably obstructive sleep apnea as well. But he could not tolerate the sleep study at all because he probably had autism as well. We couldn't get his childhood history. He was the most difficult patient to treat, and his sleep reversal was so entrenched that we tried everything that we could. We tried melatonin, we tried light therapy, we tried we tried to give him sedating medications as well at the time. The problem was, and we realized that later on, was that he had developed a fear of the staff at night as well alongside, and that sustained his sleep problems, and we could not work on that. The most commonly used questionnaires on my ward, Stop Bang and Epworth Sleepiness Scale. I'm assuming everyone will be aware. Sorry, did you want to take a picture, Josh? You got it. So 1 could not tolerate the sleep study, 2 declined, 3 were awaited at the time when we looked at the data. All of them, if you look at them, they all had some sort of sleep problem or the other. I'm not going to list all of them, but I'll summarize them at the end. So 5 patients had obstructive sleep apnea. All of them were males. 3 of them had traumatic brain injury. 1 had HSV encephalitis, 1 anoxic brain injury. 2 others had developed circadian rhythm problems with reverse sleep-wake cycle. 10 were already on melatonin, 2 for circadian rhythm disorder. But the other 8, the melatonin was started in the ITU, and out of them, 4 had no complaints. And I suspect that was because a couple of years prior to this, I had given a lecture to the major trauma ward within the region. And we talked about the importance of sleep and recovery post-brain injury. So I have now noted that all the patients coming out of major trauma are on melatonin. Whether it's beneficial or not, only time will tell. Couple of them had non-specific sleep issues. we suspect that was related to trauma. One of them had developed sleep talking after the TBI. It did not have any previous history. And one had developed restless leg syndrome, but they were on an SSRI, which can trigger restless legs. Okay, so another case, this was the most difficult patient, again, I found to treat on my ward, TBI following alcohol use, history of severe cardiovascular problems, history of severe respiratory problems, probably even had premorbid ADHD. I could not get the childhood history, but both the partners, ex and current, both reported symptoms suggestive of that. Had no sleep complaints, but had severe fatigue. So we decided to do a sleep study and we found that he had severe obstructive sleep apnea. Now, initially, he liked the feeling of having that air through the CPAP mask and called it oxygen, but then struggled to use it at night and he continued to smoke. So it was difficult to treat him. So just to give you a flavor of how difficult it is to, one, report symptoms after a brain injury, diagnose them, and then to treat them. So you see that what are the factors that actually impact on sleep after brain injury? Most commonly I find on my ward is pain and the medications related to that. Then there is headache, then seizures, then mental health, brain injury itself, and then there are premorbid problems. Initial observational studies, and I've focused mainly on moderate to severe brain injury. What happens is, and this is observed in clinical findings as well, after a patient has a moderate to severe brain injury, they spend a significant amount of time in ITU or major trauma wards. And they are sedated. When they are weaned off anesthesia, they continue to be sedated because of PTA and agitation related to that. They are in a dark environment, artificial lights. You don't get enough lux as you need to stimulate your photosensitive cells to manage your circadian rhythm. So once they come out of that period, they become very agitated. And what we have noticed is that they develop insomnia or difficulty to fall asleep and maintain their sleep. And as they progress through their journey, what we have noticed is that insomnia resolves over a period of time and reduces, and they then develop excessive daytime sleepiness. And we'll see that along the journey of the patients. So 3 months post TBI, another observational study noted 2/3 had disrupted nighttime sleep, similar to my observations on my ward, that 2/3 had sleep problems. A number of them were treated with medications. And this study actually noted that the estimated cost difference for those who had sleep-wake disturbance was $16,000 per patient per admission in rehabilitation. When they moved on to 3 to 6 months post TBI, out of the 87 patients that were studied, 46% had abnormal sleep studies. So nearly half of them had sleep problems. Majority by this time had started to develop, if you look at it, hypersomnolence, more so than difficulty in falling asleep. And then as you go on, 6 months post TBI, another study noted that 60% of moderate to severe TBI patients, 72% had new sleep-wake problems, and 77% by this time had hypersomnia. And almost half of them did not have an identifiable primary sleep etiology, which suggested that the brain injury itself, the trauma to the brain itself, was contributing to the excessive daytime sleepiness. And what was observed in the post-mortem studies, and I'll come to that in a bit, was that the orexin was affected. So 6 months post-TBI, again, if you look at it, what happens is there were studies which showed, post-mortem studies and otherwise, that the hypocretin or orexin levels in their brains was significantly reduced. They then recovered 6 months later. None of them had undetectable levels. However, when they compared them with the normal ranges, they were still in the lower range. And this is a wake promoting hormone. So what happens is, initially, when the brain is knocked, what is likely happening is that there's a preservation of the brain going on. Because we all know that sleep actually promotes the recovery. And if you have a lot of wake promoting hormone at that time, it will impair the recovery. So brain is very cleverly, possibly, what is it doing? It's actually reducing those levels so that the recovery is possible. And then over a period of time, it recovers. However, it still doesn't recover to the levels that it should. And when you do the post-mortem studies, we find that there were 20% less neurons in post-TBI patients. So it is reducing significantly. It is having a direct effect on your orexin receptors in the hypothalamus, plus the direct injury to the brain itself is causing hypersomnolence over a period of time. 3 years post TBI, you'll see that when we looked at initially, insomnia rates were significantly higher. Now they are 10%, but all the patients had depression. And if you look at hypersomnia, they're around 40%. So that's how the journey of the patient is post TBI and sleep. Just quickly, circadian rhythm. We know that patients with, again, like orexin is impacted, melatonin secretion is also impacted after a brain injury. It reduces. And in a number of patients, it actually stays reduced. And that's why it affects their circadian rhythm. And there might be premorbid factors to that, and we need to look at this in a bit more detail. So this is just a simple example of how we treated a simple delayed sleep phase syndrome in a patient of mine. Again, TBI, post-alcohol, developed delayed sleep phase syndrome, recovered completely with use of melatonin. If it had not, then we would have given some light as well in the morning. In fact, I actually recommend doing both together, and it has a more beneficial effect. I won't go into the details of the definition. It's just a very simple definition of insomnia, but I'll talk about TBI and insomnia. Like I talked about earlier, initial epidemiological studies had shown 10%, but when you look at it objectively with actigraphy and PSG, it's not a significant number of patients. And there are a number of contributory factors, including mental health problems, headache, pain, dizziness. What we have noticed on my service is that it significantly impairs both the insomnia and the hypersomnolence, significantly impacts on their rehabilitation. Because if they struggle to sleep, they're tired in the daytime, they can't engage in their therapies. So it's very important to get their sleep disorder treated and get it right. So what we do when we admit patients is we do a detailed sleep study. And we have a rotational policy. So the junior most doctor, the intern, as we call, rotates every 4 months. And then the SPR rotates every yearly. So the cycle repeats. I have to train them. The first day they are with me, I try to train them in taking a detailed sleep history. Because I have connection with the local sleep service, I can easily get my patients reviewed by them and investigated by them. And they kind of get a priority because they are inpatients and they are struggling and their recovery can get affected. So we mostly end up doing the respiratory studies with a probe on the leg to look for restless legs because they're mostly on psychotropic medications. But I think we should start doing a bit more of other studies like actigraphy and PSGs. However, the waiting list for those studies in NHS can be quite significant and it's difficult to do. And melatonin saliva measurements are not available across the NHS at the moment. only in research settings they are available, but that would be a useful tool to target the use of melatonin, because research studies have shown that if you time your melatonin correctly with the help of the sleep diaries, you only need around 0.6 milligrams. And we tend to go up to 10 milligrams or 12 milligrams unnecessarily. And again, non-medication treatment and psychological treatment and the nursing behavioral implementation on the ward in a rehab setting is quite important. There is significant evidence for CBT in insomnia in TBI patients as well. So if that is available, that should be used. And again, one of the research considerations is, should we consider daridorexant? It has been recently introduced in the UK. Now, when they did the initial study, they had excluded all mental health patients. So my trust is a little reluctant to give it out to most of the patients. So this will have to be under research considerations. And just very quickly, I'll touch upon hypersomnia. I've already talked about this. And there is this gradual increase of excessive daytime sleepiness and hypersomnia over a period of a year and up to the next 3 years. We've looked at this. There is a little definition of what should be considered as hypersomnia post-TBI. So there should be a 2 hours increase or more per 24 hours compared to pre-TBI need for sleep. And that's how you would define hypersomnia post-TBI. Again, we need to do a lot more investigation. And if there are secondary reasons, then we need to exclude them. I rarely see secondary narcolepsy. I only have one patient in my clinic with secondary narcolepsy with hypothalamic damage. But if there is a suspicion, then we need to explore that as well, because we have seen that orexin neurons are knocked out. Again, there are studies which show that stimulants are very useful in these patients. And I would propose, again, research questions whether pitolisant and solriamfetol, which are used for narcolepsy, will be beneficial in this patient group as well. I think that's it. Finished in time? Okay, thank you. Awake.
Exactly on the
I
dot.
have failed my hypothesis.
So we've had all 3 lectures, so I think we will take questions. I will start with a question which is online. What are the most common causes of pediatric TBI, ABI?
Bicycle injuries, pedestrian versus vehicle, or vehicle versus pedestrian, and then for adolescents, sports. Those are the most common.
Right. I had a question. I was wondering, what role does pre-morbid personality play in TBI outcomes? Neeraj, and then I'll let the others weigh in as well.
Yeah, I think that's a good question. I think pre-morbid personality is very important in terms of subsequent neuropsychiatric presentations. So people who have cluster B personality traits, or people who have pre-existing personality disorders, particularly antisocial or emotionally unstable, they are more likely to be risk-taking. They're more likely to be abusing substances. They're more likely to have traumatic brain injury. And those people then are probably more likely to have subsequent substance misuse. They're more likely to have your behavioral problems, particularly impulsivity, emotional dysregulation. They're also more likely to develop subsequent depression and associated problems. So I think that's very important to establish clearly.
Can I just add to that? So in my previous life, when I was a forensic psychiatrist, I used to see a lot of offending behavior post TBI, and a lot of them had premorbid, like Dr. Agarwal said, premorbid personality disorders, including DSPD or childhood conduct problems. And they would usually get exacerbated because of the especially if they had a frontal lobe injury, the inhibitory effect of the frontal lobe is lost. And so the offending behavior increases qualitatively and quantitatively.
Yeah.
ADHD is not included either in IDEA, that is IDEA, in USA or RPWD Act in India. Recently in 2016 only they included SLD. See that ADHD as an independent disorder or with comorbidity. Even one of my research work, I found many comorbidities. It is having impact throughout the life. It is chronic, unlike earlier days. So why we are not including RPWD Act ADHD or even in other countries also?
think, Dave, would you like to weigh in? Should ADHD be a registered disability?
Yes, yeah.
Yeah, we ask that question of our government all the time. In Australia, well, it depends how you mean registered as a disability. By schools, it is. But by the people who fund disability services, it's not. And the reason in Australia is that they've completely separated health and disability. So Professor Troller, who's going to speak later, knows that much better than me. But there is a complete dissociation. So if I argue that ADHD is a health condition, I'm arguing against it being considered as a disability. But if you want to know my real thoughts on it, we have a thing called the National Disability Insurance Agency and Scheme. Over half of that money is now used by people with autism. And because families of people with autism have such strong lobbying powers, including many government officials who would be quite happy to say, yes, my family has been touched by ADHD, they get all the money. And if you were to give it to ADHD, which is at least 5 times more common, and just in my argument as serious, it would break our national economy. And so we now in Australia have nobody diagnosed with autism level 1, because you don't get money for autism level 1, you only get it for level 2. And in some places, 10% of boys have a diagnosis of autism level 2. And so it's actually very complex. But as you kind of point out, it's a policy issue, not a health issue. And we're caught between some difficult stones.
Thank you. I think we have another question here. Yes.
A couple of very quick questions. First to you, Jay. I was sitting with my colleague, the good children of young age, and the debate was around the role of helmets. So I think this is very debatable still, right?
What's your take, and where do we sit with it? Wearing helmet in sport related?
I think helmets are complicated because in American football, there's an argument that helmets have actually made it more risky because then the collisions will happen more forcefully. And whereas in rugby, there's actually fewer concussions because people tend to protect their heads. But I'm not sure what the answer to that is. There haven't been too many devices that have been shown to prevent concussions, but there might be some devices, there's some being tested right now that might actually reduce the severity of an injury. So I think that's promising. And then the third thing is to say that neck strength seems to have something to do with concussion vulnerability. And that might be one reason why females could potentially have more concussions in sport than we would expect.
The last one to all three of you. What about the role of a pituitary screen in brain injury patients? I mean, is it something you recommend regularly? Because I can take that if you want. So we have a policy on our ward, and it's a nice guideline recommendation as well, that 3 to 6 months post TBI, if you have a basal skull injury or a severe traumatic brain injury, then you have to do pituitary screen, including cortisol at 9 a.m. And to screen for that. So we routinely do that on my ward.
Yeah, I would agree. I think pituitary screening is very important, particularly if people are having problems like, prominent fatigue, there might be mood issues, sleep difficulties. So there are lots of things which can be related to that. So I think it's very important to screen for that.
Yeah, we actually do it after a year as well. So it is repeated as well. I have one question, sorry, to Professor Salpikar. I'm going to labor this point, and Professor Coghill can actually help as well. And I'm going to ask the same question again. Post-TBI ADHD, the courts in UK will ask whether there is a causal relationship. Now, to establish that, we need twin studies. That's not happened. But is there robust, persuasive evidence to suggest that it is more likely than not that it is caused by TBI in certain cases?
I'm convinced. So I don't require more evidence about that. But we'll see what Professor Coghill says. But
your view?
In a lot of ways, it's hard because this is a heterogeneous disorder. So right away, we can't nail things down precisely. We have to estimate.
I mean, I have no doubt that some ADHD occurs post-head injury, but I think a lot of the studies, even including some of the ones you showed, are not good at causation because there are not good assessments prior to the head injury to really say, just because you didn't get diagnosed before the head injury doesn't mean it wasn't there. And you've shown very convincingly, and we know that people with ADHD have more head injuries than people who don't have ADHD. So the causal chain is very difficult to look at. Maybe some of the longitudinal data like the ABCD study will help us look, because they've done the assessments at baseline. And if they've got then indications of when someone had a head injury and whether there's a change. But you really need population-based longitudinal studies, not clinical sample studies, because there's a lot of Bergson bias in there.
I think that's a fair criticism. And I think the reality is that we're looking to identify something that might be very hard to identify flawlessly. And that's a problem with our diagnostic criteria, et cetera, et cetera. For practical purposes, though, I think that, we have an attorney that can weigh the evidence, and there you go.
Yeah, the courts will decide ultimately.
Sure.
Do you agree, Dr. Agarwal? Do you get this question in the UK?
Well, this is a question, and I think it is a heterogeneous disorder. I think it does lead on to ADHD in a number of cases, but it could be rather complicated because in many ways, if we're looking more puristically, ADHD is a neurodevelopmental disorder. And if somebody never had ADHD, they had the brain injury in their late 20s, early 30s, they had no pre-existing ADHD, and now they're presenting with acquired phenotype which resembles ADHD. Do we call it ADHD? And I think it becomes complicated because, of course, people are going to have problems with impulsivity, behavioral problems like I've described. People would have neurocognitive impairments where with inattention, memory problems, the whole neurocognitive profile. And they are happening together after a brain injury. Do we call it ADHD, or these are manifestations of brain injury which resemble phenotypically with ADHD? And so it becomes complicated.
Can I comment on?
I think we'll.
Can I just make a quick comment on that?
Sure.
I mean, I think just to remember that the diagnostic criteria for ADHD on purpose have no comment on why the ADHD is there or not. and actually the response to treatment is exactly the same, irrespective of the cause. So whether or not you call it ADHD doesn't, in a sense, matter, as far as that doesn't indicate whether it was there pre or post. And so I think it's just important to remember that. Just like if someone has a head injury and becomes depressed, you don't call it not depression. If someone has a head injury and has epilepsy, you call it epilepsy. And I think we should treat ADHD and other conditions like that in a similar way. Of course, there's a scientific argument behind that, but yeah, it's my thoughts.
Yeah, no, I agree. I think these people benefit from, and there are several studies which have shown role of stimulants, even in neurobehavioral problems who do not present with ADHD phenotype. So these medications are definitely beneficial.
So for want of time, we'll just like close the session. And it was a wonderful session by all the three speakers. And we have a lot of questions to ponder over this, but I think we'll just like take it as during that break. And I just had just one query. So like, apathy is one area that is post TBI that's a major source of concern for family members, amotivation and apathy. So like, do you have any pharmacological agent that's been very effective that in your practice or?
Yeah, but I think apathy needs to be carefully delineated from a depression with other neurobehavioral problems. We need to look at, as we discussed, pituitary profile, because that could lead on to apathy-like symptomatology. And generally, we would use, depending on is it mainly cognitive apathy or behavioral apathy, we would use either dopaminergic medications, stimulants. I think those are the two main ones which we would use. I think modafinil is used sometimes, if it's associated with daytime hypersomnolence, and that is then resulting in a degree of apathy. So it depends, what is the profile of apathy, and certainly ruling out pituitary dysfunction is important.
Sure. Thank you so much. Thank you. Thank you all.
Thank you, everyone. We're closing this session. There's a quick housekeeping announcement. We are 30 minutes late, but we will not break for coffee, so we will finish on time, hopefully. Thank you.
Thank you, Dr. Neeraj Agarwal, Professor J. Salpakar, and Dr. Hital Kumar Mehta for your presentations. We thank Dr. Neeraj Agarwal for joining us online. We hope to host you in person at a future event. Before moving on to the next session, I request the chairperson, Dr. Innapada S. Krishnamurthy, to felicitate Professor J. Salpakar and Dr. Hital Kumar Mehta.
As the chairperson,
I also now request Dr. Jazinder Singh to felicitate Dr. Vishnupriya, Dr. Raman, and Dr. Nagraj Halmani.
Yes.
Okay, so our next session, focusing on the functional neurological disorder. To chair, we have Professor Tim Nicholson from UK online. Can we have the screen? No, Professor Tim Nicholson. Yeah, so Dr. Tim Nicholson, current affiliation, clinical senior lecturer and Institute of Psychiatry, Psychology and Neurosciences, King's College London, honorary consultant neuropsychiatrist in South London and Mosby NHS Foundation Trust, where he runs a specialty clinic for FND, leads the MSc in Clinical Neuropsychiatry and Institute of Psychiatry, Psychology and Neuroscience, Faculty of Neuropsychiatry, RC Psych, British Neuropsychiatry Association, and Fellowship in Postgraduate Medicine. So Professor Tim is leading the FND movement across the UK, and I will hand over the session to you, Dr. Tim, to introduce our first speaker. Please. Yeah. No, he didn't join now. He have not joined. Okay. Okay. Yeah. So you can put the first speaker slide. I think he would have, because he joined some 10 minutes back and then he left again. Okay. So very eminent faculty member, Professor Kurtla Franz, Professor of Psychiatry and Neurology at Brown University, US. Inaugural Director of the RIH Neuropsychiatry Division and Director of the Veteran Affairs Mind and Brain Program, over 170 peer publications. Fellow of American Academy of Neurology, American Psychological Association, AES, American Neuropsychiatric Association, multiple grants, ILA. Well, I think this slide won't do justice to if I have to put everything in one slide. So the floor is yours, Professor Franz.
Thank you so much for the invitation to speak and for being here.
It's wonderful to be back in Chennai again and to be able to see the wonderful city and to meet more people, increased from last time and added to last time. And so in this talk, I'll be speaking on functional neurological disorders, also known as conversion disorders. I'm speaking from a place of being trained both as a neurologist and a psychiatrist. So I see the brain and mind as two sides to one coin. And when you treat one, you treat both. And when you treat both, you treat one. These are my disclosures. I'll be talking about some of the research that has been published, and some of the materials discussed are from that. So in light of where we are and where we started, I've had some wonderful conversations with some seasoned clinicians here and also with some young clinicians, and asking about different cases and challenges. And also I see the work that's being done around the country with FND clinics being presented this morning. So wonderful to see that the work is progressing. I put this slide up briefly just to show it usually starts with a seed and then it takes a champion. And so to have that, this was the seed for me back when I was in the combined residency in neurology and psychiatry at Brown. During the 5th of my 6-year residency, we had a lecture not unlike this, where we had leaders from around the country and around the world come. And one of the top clinicians at that time said, okay, now we're going to talk about pseudo seizures. We don't call them pseudo seizures anymore. Pseudo means false or fake. These aren't fake seizures. They're real seizures. They're just not caused by abnormal brain cell firing. So he said, we're going to talk about pseudo seizures. Pseudo seizures are really difficult to treat. They need a psychiatrist. Now let's move on to the next topic. That was it. That was all of the literature. That was all that was available at that time. And so at that time, that planted a seed for me of, we've got to do something about this. So I sketched out as a 5th-year resident a 4-arm clinical trial and said, let's try and develop treatments for this. Fast forward 25 years, I'll be presenting on that data now. So for those of you who are champions for functional neurological disorder, whether it's PD or adult, you're going to have some challenging patients. Hopefully this talk will equip some of you in neurology and psychiatry and psychology and physiatry or rehab to be able to take care of these challenging patients. I said fast forward to 2025. Now let's turn the clock back. And here you see what we were doing over 10 years ago here, when Dr. Krishnamurthy had put together a conclave, a knowledge conclave, not unlike what we're doing right now. Another knowledge conclave where we're exchanging ideas, and we are encouraging each other and edifying one another. And so appreciative of Krish and you, all the work that you've done, not only here, but bringing together international groups to have these type of discussions. Thank you. These are my disclosures. So the work that's presented today is because of a team around the country and around the world, and I'm so grateful for the team. Next is what we'll talk about here, which is functional neurological disorders, conversion disorders. I'll explain it like I do to my patients. FND are a neurological manifestation of an underlying psychological conflict or stressor, life events, and they're associated also with brain connectivity changes on neuroimaging. And I'll show you data for both of those. When I started, we didn't have evidence-based treatments. We had consensus guidelines and opinions, and now we do have evidence-based treatments available that you can put into practice in your clinic and with your patients. And from that evidence base, I'll talk about the outcomes for neurobehavioral therapy, one of the modalities that is used around the country and around the world, both in civilian and in veteran populations who've been treated with neurobehavioral therapy and had demonstrated reduced seizures, comorbid depression and anxiety and PTSD, improved quality of life, and improved functioning. Again, turning back the clock, we're talking about what used to be called hysteria from the Greeks, and then now it progressed to somatoform disorders. I've been interested in this as a neurologist and psychiatrist for many years because we didn't have treatments and we needed to do something. So this has been a passion project of mine. And yet it's not done individually, it's done as a team. And you heard about that from some of the descriptions today, whether it is neurology, psychiatry, neuropsychiatry, behavioral neurology, PT, OT, speech. It really does take a group of people, adult, PD, social workers, chaplains, pastoral counselors, whole person approach is where we do this. So to look at some of the prior data, prior literature, functional motor disorder, what has been called psychogenic movement disorder, has been treated for years in the past with inpatient treatment. The most response was to inpatient treatment. However, in the US, we can't get people with functional neurological disorders inpatient because those spots are reserved for highly acute conditions such as suicidal depression or violent psychosis. And in the absence of that, then insurance companies have said, no, they don't need to be inpatient, despite having had good responses as inpatients. And while they were inpatient, they got that treatment that I was referring to, PT-OT speech, CBT, and usually psychotropics. At the turn of the 2020s, they asked us to do a review of what some of the progress was. So I assembled a team of experts from around the world, and we wrote on what were the past decade's advances. And in this review article in JNNP, we looked at common things that were commonly used, which include Botox and botulinum toxin. And these studies have shown botulinum toxin does not treat a motor FND. You can keep injecting them and they may have some weakness, but it's not going to make it go away. The other things that were done were physiotherapy. And Glenn Nielsen has done some great work in the UK where he has looked at PT for patients with motor FND, and I'll talk a little bit about some of the work he's done. Then also multidisciplinary rehab and CBT for motor FND. Both of those approaches have shown some preliminary responses, but it's failed to show longitudinal responses. One program that has been used came out of Mayo Clinic in the US and then was used in Mark Hallett's lab at NINDS. And for those of you who know Dr. Hallett, he is a major influence in the field of neurology, not just movement disorders. He's recently passed away. So we've lost a giant in movement disorders and in world neurology recently, a friend and a distance mentor to me and much missed. But from the work that some of his fellows have done, they used the motor retraining program. And that's one thing I've heard about the Booty Clinic is that you've got different modalities being used and whether neurotechnologies, neuromodulation, neuropharmacology, neuropsychiatry, all of these approaches can be used specifically in functional neurological disorders also. With this motor retraining program, basically a lot of people will say, look, it's a brain disorder, so just treat their brain. I've found personally and also from the literature that just quote unquote treating the brain is not sufficient. And so you'll see in the motor retraining program, along with rehab principles, there are also what they call mental practice. And there's also psychiatric or rather psychological intervention to help with this as a brain-mind disorder. I mentioned about physiotherapy, and again, but when I started doing this over 20 years ago, we didn't have consensus statements. And now an assembly of PTs and others have provided examples of techniques that can be used in the rehab setting. Similarly, occupational therapy provides the same with these consensus statements led by Claire Nicholson in the UK, combining traditional approaches, conventional approaches in rehab specifically for OT, along with being aware psychologically of what is beneficial for our patients from motor FND. Also, from down under, Janet Baker has done some work and in speech and language therapy, which can be used for our patients. So whenever I am sending a consult to PT, OT, and speech, I actually attach these consensus statements to equip the rehab people who might not be as familiar with motor FND. And this just helps to give them some tools that they can use. These are readily available online. Another approach that's been used is guided self-help. There's been some good preliminary work led by Michael Sharp and others that with guided self-help for functional motor disorder and functional neurological symptoms, there was a initial preliminary signal that showed a benefit. However, what I've found is that because these are complex patients, usually guided self-help is not enough. It's going to take some help, some assistance, and that's where we come in as therapists, clinicians, psychologists, others, to therapists to help. So with this, I mentioned earlier about Glenn Nielsen's leadership in the Physio 4 FMD trial, a randomized controlled trial that was specialized PT for motor FND, large study published last year. In that study, they found that there were benefits on secondary outcomes. However, the intervention did not result in better self-reported physical functioning at 12 months. So durability is important. Perhaps it'll take more to maintain the impact that was found initially. Likewise, Dr. Laura Goldstein has done some great work in the space of non-epileptic seizures, dissociative seizures, functional seizures. I'm using those terms interchangeably. And in the CODES trial that Laura led in the UK, there, again, similarly, strong outcomes for seizures and for comorbidities at the 6-month mark. However, the primary outcome at 12 months, which was monthly dissociative seizure frequency in the prior 4 weeks, did not show a significant difference from the comparison group standard medical care. Again, benefit was received and for secondary measures, and so definitely helped a number of people with this, just not at the 12-month mark on the primary outcome. So much of what we do is patients will come to us and they'll say, oh, sometimes the chief complaint to me is, they told me you're the only one who can fix me. That's the chief complaint. It's not I've got a headache or I have insomnia. It's you're going to be my response immediately is to deflect. And my statement is, I don't have the power to fix you. What I can do is I can walk beside you as you do the work. And that's in a lot of ways what our role is. So I encourage in patient-centered care for the patient to realize you're the one with agency. You're going to be the one who does the work. So in doing so, I say we're just along to help as a team. And here we have a multidisciplinary team to help. But I also let them know it's not just about coming to the doctor's office or to the rehab or to the clinic. It's also what's happening in your environment. And so in light of that, healthy home. So it might be prescribing family therapy to address the interpersonal issues in the home environment. They spend about 20 minutes to 2 hours here, but they spend the rest of their lives outside of here. So it's so important to be able to realize that. And then also in the community, so many other resources that can be used. So I tell people, along with coming to clinic, you've got the 3 F's, family, faith, and you've got your, yes? Okay. We're having a little technical issue here. Tim, Sagita, so good to see y'all. Glad that y'all are online. And so what I tell people is, as we're doing that, that having not just coming to the clinic, but also your resources in the community is so important. If I'm remembering correctly, the next slide should be, we can talk about the importance of taking a good history in the diagnosis. Thank you. So we're back online. Good, thank you. And that's been emphasized by a number of the lectures here. And the idea of taking a comprehensive history. What you're going to see is when they come to you and they say, oh, I had a seizure or I had a tremor, realize that you're going to have other functional symptoms. So for the epileptologist, they say, well, you know, I treated the seizure, but then they ended up having another symptom. They developed movements, but I'm not a movement disorder specialist. So I guess my job is done, right? Wrong. You still have a job because this is just symptom transformation, basically, symptom substitution, because you haven't gotten to the core issue for the patient. Once you get that, then you can have a resolution. You're going to see numerous manifestations of this many times in the same patient. When I started this, we had, as I mentioned, consensus statements. One of my charges was to move the field forward by providing an evidence base. I'm not one for reinventing the wheel. One thing that's been written in the wisdom literature is there is nothing new under the sun. So we're not inventing all these great new ideas. We're basically taking something from the past and we're modifying it. I asked for permission for a workbook on epilepsy, a psychotherapy for epilepsy, neurobehavioral approach, where Ryder and Andrews had shown reduction in epileptic seizures with a psychotherapeutic approach. They found that for partial complex seizures, and they gave me permission to modify it. Instead of taking control of your epilepsy, it became taking control of your seizures, a workbook for patients. I added information on the known comorbidities. Half of our patients have depression. Half of them have PTSD. 2/3 of them have a personality disorder. And so we have to address the comorbidities in this population. That was some of the information added. The other, in our prior section, was all on TBI. Many of the people who come to us, half of them report a history of TBI with non-epileptic seizures, many of them involved in some type of a car accident or an assault or something of that effect, or for our veterans, some type of military related issue. And for those people who report TBI, 75% of them, it's mild TBI. And so looking at the relationship, this double hit where you have a physical hit while retaining consciousness because it's an MTBI, and also because you retain awareness, seeing the trauma that's going on around you and inside. That's a double hit of PTSD and MTBI, very common in this population, and you have to treat both. So as we were doing work at that time in non-epileptic seizures, functional dissociative seizures, Andrews and Ryder's group were doing the same in epilepsy with aura interruption and trigger self-control. And we ended up conducting that clinical trial that I mentioned that sketched out as a resident with some collaborators from Cincinnati and from Stanford, and also doing so in Brown. And what we found was in the therapy containing groups, the two arms, there was a significant reduction in seizures. In the medication arm, in SSRI, there was a trend, and then in treatment as usual or standard medical care, there was no significant reduction. That standard medical care is what was being done at all of the epilepsy centers. So what was being done at the level 4 epilepsy centers was not sufficient. We needed to do more. We also found significant reduction in the comorbidities, not just, we found it in the 2 therapy containing arms with the neurobehavioral therapy, but not significant reduction in the treatment as usual. Our theoretical approach is as follows. It was borrowed from the pain literature, where you see non-epileptic seizures here. You can substitute other symptoms, chronic pain, tremor, many somatic symptoms. Here's the way to approach this. There's an injury or a trauma, a remote or acute, or both. And then they develop the symptom. After that, they catastrophize. My whole life has fallen apart. I might be on disability forever. It's that type of thinking. They fear the next seizure. Then they avoid external stimuli, with the lights in the room, or the sound, or whatever the external stimuli is that can quote unquote trigger their symptoms. And they're hypervigilant to internal somatic cues. Every time I get a fast heart, I think I'm going to die from a heart attack, or I developed a tremor. Could this be Parkinson's too? with that, they fall into this pattern of disuse, disability, and depression, this vicious cycle, and overtakes their life. From there, with our tools, we equip them to be able to make the links of this vicious cycle and to use the tools to break the links. Once they've done that, they move from this vicious cycle to this, what we call a virtuous cycle of confronting the fears that they have and moving into recovery. In this slide, you see the approach for neurobehavioral therapy. The reason why it is called that one is because that was the original model, a neurobehavioral approach for epilepsy, neurobehavioral therapy for seizures. Two is because it's not cognitive behavioral therapy alone. There are a couple of the chapters that deal with CBT, but the others are the various other modalities that we use. There's not one best approach in psychotherapy. So during my combined residency, I just took the best of all the different modalities and used them for the targeted pathologies in this population. So you've got things like interpersonal therapy to help people with their communication. I'll say at the end about a disorder of communication, and I'll say more about that. But for the issue here is they can't express distress in a healthy verbal manner, so it comes out somatically. So you equip them to do that with healthy assertive communication. There are things like a schema-focused thought record where you drill down to the core belief. Once the person says the thing that they've known about themselves, but they've never admitted about themselves. When they say, I am worthless. No one is ever going to love me. I'm damaged goods. When they put that down on paper and when they say that and have that realization, for many people, it's an epiphany. It's a scary, scary statement. They've known it intrinsically. Now they're saying it. And once that comes to the surface, then they can actually take a step back and look at the evidence for and against and generate an alternative or a balanced thought. And changing the way that they think can change the way that they feel now that they've confronted this statement. So that's a thought record. We move into psychodynamic elements, and no, it doesn't start with analysis and it doesn't start with dynamic because they're not ready to go there yet. And so once they've got this foundation and these tools, that some self-management and some relaxation techniques and some healthy communication, psychoeducation, then they can move into, now I'm going to address the unconscious processes to make them conscious. Now I can address the implicit and make it explicit. And then we tell them, well, you've got these tools, you can live your life now. And so doing so, I mentioned earlier in a talk this morning to one of the questions, I'm trying to work myself out of a job. I don't want these to be professional patients and have to come back every week for 5 years. I want them to go live their lives. So they've got these 12 sessions, these tools that they're able to use for their symptoms. A lot of people will say, well, how is it different than CBT? CBT focuses on the here and now with a symptom. Neurobehavioral therapy, along with being multimodality, as I mentioned before, it not only focuses on the here and now, it also focuses on the then and there. And making the link between the here and now with the then and there is where the real strength is, because then once they've made that link, they can break that link. During the pandemic, everybody was talking about the need for telehealth. In the Veterans Administration, they have an amazing infrastructure where they're able to treat veterans around the country pre-pandemic. So when pandemic came, we already had 100 patients of veterans who we had been treating for a decade and showed similar reductions in via telehealth versus in clinic. So you can treat people around your country or around your state using telehealth with this intervention. We went from treatment, we developed the treatment first, and then we looked at mechanisms after. We did it backwards, and that's okay. Because you're not always going to find the brain or the neurophysiologic mechanism for everything that you're treating. So we said people were suffering, let's develop a treatment. When we did that, then we backfilled looking at mechanism. And in doing so, we had a 3-arm trial where the control group was TBI, you don't want to use healthy controls as a control group because they don't have anything to compare against. So we used TBI. The second group was TBI plus epilepsy. The third group was TBI plus non-epileptic seizures. And what we found is the two therapy arms, the two arms that had seizures got the neurobehavioral therapy. And over time, post TBI both had a significant reduction in seizures. So we confirmed what we had shown before, reduction in epileptic and in non-epileptic seizures following neurobehavioral therapy. We also looked at somatic symptoms. We looked at a number of other clinical scales, including somatic symptoms and global assessment of functioning. The two therapy receiving groups, the two groups that had seizures who got neurobehavioral therapy had a significant improvement in the comorbidities and functioning, whereas the standard medical care treated TBI alone group that didn't get neurobehavioral therapy had no significant change in secondary outcomes. And then one of the third major findings clinically was the durability. After they had the 12 sessions, those who had improvement maintained their improvement at 12 months, whereas the standard medical care TBI group that didn't get neurobehavioral therapy continued with their symptoms over the course of a year. A lot of that work, as I mentioned before, we started with consensus statement, and then now we actually have initially it was expert opinion, then we increased the evidence base. Now we actually have just recently, this is hot off the press, so y'all are some of the first in the world who are actually seeing this. It was just released a few days ago by the American Academy of Neurology, Management of Functional Seizures Practice Guideline, Executive Summary. This was a 5-year process to get this published and reviewed, because 12 class 2 and class 3 studies, which was the best literature available, found that psychological interventions are helpful in reducing seizures, decreasing comorbidities, improving quality of life, and improving psychosocial functioning in patients with functional seizures. So this really was a validation of what we had already experienced in clinic and what we had seen in our studies. But now to have the American Academy of Neurology saying, if you're going to treat your patients, here's the best evidence to do so. Along with doing the neurology, also doing the psychiatry, Eric Kandel won the Nobel Prize for this learning principle that he used in psychiatry. And just to focus you, he writes that insofar as psychotherapy or counseling is effective and produces long-term changes in behavior, it presumably does so through learning, as I mentioned, by producing changes in gene expression that alter the strength of synaptic connections and structural changes that alter the anatomic patterns of interconnections between nerve cells of the brain. As the resolution of brain imaging increases, it should eventually permit quantitative evaluation of the outcome of psychotherapy. He published this in 1998. That was during my combined residency in neurology and psychiatry while I was getting psychotherapy supervision. And that was a paradigm shift for me, in that saying brain and behavior, we can look at the physical effects along with the psychological effects. And that's what influenced the results. Well, number one, a neurologist started analysis. A psychiatrist started CBT. So I figured, well, a neurologist and a psychiatrist maybe could combine and go the next step with this. And in doing so, we looked at some work that had been done on patients with functional dissociative seizures, where they found a hyperconnection between areas of emotion and motor regions of the brain. But there was a hyperconnection between the insula and the precentral sulcus, almost bypassing the inferior frontal gyrus and the parietal cortex, the executive control areas. I thought that perhaps that could be a biomarker for patients with functional seizures as compared to those with healthy controls. We, in fact, showed that through our treatment with neurobehavioral therapy. With 12 sessions, we did pre and post functional and structural neuroimaging, and with our collaborators at University of Alabama, Birmingham, Jerzy Szaflarski leading the neuroimaging core, we found that there were functional connectivity changes in patients with functional seizures following neurobehavioral therapy as compared to the healthy control group, or rather the control group of TBI who got standard medical care. Not only did we find the functional connectivity changes, we also found white matter changes following neurobehavioral therapy in the TBI plus non-epileptic seizures group, and then gray matter changes following neurobehavioral therapy in patients with TBI and non-epileptic seizures as compared to TBI controls. And so when we say the statement, oh, it's a software problem, not a hardware problem, that helps to explain to patients, but it's wrong. It's a hardware problem too, as demonstrated by our, number one, our baseline studies. And just to make sure people are understanding, the changes not only symptomatically, but also from a network perspective occurred following neurobehavioral therapy. We've got along the lines of different network connectivity in various in the various networks, whether it's the default mode network, the executive control salience findings, and frontoparietal network have all been demonstrated here to have significant changes in patients with functional dissociative seizures and following neurobehavioral therapy. So to wrap up that part, basically it's with neurobehavioral therapy, pre and post, we found reduction in seizures, comorbidities, improvement in functioning, and also brain changes, neuroplastic changes. I'll skip ahead in light of time, basically to show that this is a manualized approach that you can use with your patients. It's been translated into French and has been used around the country and around the world. For those who don't do training with me, remote training, there's a therapist guide that's used also. This is published in the Oxford University Press Treatments That Work series. Patients get the workbook. They come to meet with you 1 hour weekly after they've done the work, and you go through the work that they've done, walking alongside of them, abiding with them. I'll fast forward to say that basically we've got clinics that have been established around the world. I know that Krish has been expanding the Bodhi Clinic to now 5 sites, I believe, around India. And so this idea of when you've got something good, they want to spread it. And in this case, multimodality approaches that treat the whole person. It seems like others, that's happening in India, and it's also happening in the US and North America. Basically, because we're not just dealing with patients with seizures, we're also dealing with patients with movement disorders. We've got a clinical trial that's going on at Rhode Island Hospital right now. We're about 3/4 of the way through enrollment. Hopefully, we'll have that published in the coming year on the baseline features of taking control of your functional movement disorder. You've also seen patients, especially in the TBI, mild TBI group, that have prolonged post-concussive symptoms after a year, and the brain imaging is normal, but they still have all these symptoms. So functional cognitive disorder perhaps is a place to be used, and we've got taking control of your functional cognitive disorder workbook that's being worked on with a great team around the country. I started with explaining FND to patients and to clinicians, neurological manifestation of an underlying psychological conflict or stressor, and a behavioral expression of neural network dysfunction, brain and mind together in the person, looking at the whole person, which is so important. We've had that discussion this whole conference. Biological, psychological, social, and spiritual. Addressing the whole person is the key, I believe, to being able to bring not just symptomatic reduction, but hope and maybe even healing to many of our patients. With that, I will close saying that it's a communication disorder, not just for our patients, but also with each other in those silos that Jay was talking about earlier this morning. If we can break down those silos, not only the ones intrinsic in our patients, but also again with each other in our profession, then I think that's where we're really going to make a strong movement forward. To wrap up, I'll say, to make the diagnosis, get them in to video EEG. I'm not sure what the status of video EEG is here in Chennai and in the state, but inpatient video EEG, if that's not available, ambulatory EEG with video, is that even available here? So you got access to, some places have access to ambulatory EEG with video. Get the diagnosis, confirm it, and then that's going to inform your problem list of predisposing factors, precipitating events, and perpetuating factors, that comprehensive approach that we've been talking about. Then you've got, that's going to prescribe, that's going to inform your prescriptions of psychotherapies, pharmacotherapies, tapering down anti-seizure medications and lone non-epileptic seizures, keeping them on in the 10% of people who have mixed epilepsy and non-epileptic seizures, and then titration of psychotropics for the comorbidities. We've shown over the past 25 years that we've made clinical advances with new diagnostic and treatment approaches. We've introduced novel interventions and neuroplastic changes in the neuroimaging. We've helped to educate clinicians around the country and around the world. And then administratively, we've helped to establish clinics, again, around the country using these novel interventions. So hopefully now you feel confident that you can diagnose functional neurological disorders. You can refer for appropriate treatment with a team. Even if the symptoms don't go away completely, you can still restore quality of life in our patients with FND. And then also, your clinic can be one of the most rewarding clinics because not only are you providing that hope and healing for patients, but also very fulfilling for a clinician to see somebody in a wheelchair coming in and walking out afterwards. I want to encourage you, if this is of interest, come join us in Baltimore this summer in June. Present your information. The abstract site is up for you to submit. If you get accepted, then hopefully we'll be able to meet there and talk more about the advances that you have here in India and also what's been going on around the world. For Functional Neurological Disorder Society, you can go to the website and sign up. And with that, I'll close.
Superb talk, Kurt. Sorry for not being there at the start of your talk, but it was brilliant as always. And for those who don't already know, Kurt has obviously led the field for many decades and is as multiply trained and experienced across all relevant areas of medicine to this complex disorder, which is very rare, and talks as fluidly about psychotherapy as he does about neurobiology, which is in a sort of unique way, which I think is such a gift to you here and also to the field. So I think we're moving straight on to Sigita Priopoulos to cover the pediatric sort of aspects of this disorder, which of course we separate into these two sections, but of course patients' journeys are long and there's no sort of dividing line between the two things, but that's why we're going to be taking questions at the end about both aspects of FND. So if we can get Sigita's slides up, thank you. So Sigita is a pediatric neuropsychiatrist at the Lurie Children's Hospital of Chicago and at Northwestern University. So thank you so much, Sigita, for doing this talk today, and please tell us more about pediatric FND.
Good morning, everyone. First of all, thank you so much for inviting me to participate in this very interesting and intellectually stimulating symposium. I would like to share my slides, and I hope that technologies will work. So give me a second, please. Can you see my presentation? Not yet. Okay, here we go. You are sharing the screen. Wonderful. Can you please confirm that you see my slide presentation? All right, here I am. I just have to move.
I think it all looks good, Sigita. I think it's just if it's possible to start
the bottom
maybe,
right.
Yes, I'm starting. I'm just trying to move my screen so I see my slides. That's what I'm doing. All right. This is Chicago this morning. I'm
Is it
sure.
possible, Sagita, sorry, just to push the start presentation mode so it goes into the full screen for the slide?
Yes.
So to start presentation.
Yes, here we go. Is
Lovely.
this better?
Perfect. Thank you very much.
Okay. So this is Chicago this morning. Not quite this morning, but yesterday was almost like that. I'm sure it's much warmer and nicer in Chennai. Today we're supposed to have about minus 20 degrees Celsius with the windshield. So I think I will be staying home and trying not to walk outside. Let me see if 5:46. I have 30 minutes. Just 1 second. All right. So I have no conflicts of interest pertaining to this presentation. And today I will try to discuss few topics. I will briefly overview functional neurological disorders in pediatric population, with a heavy focus on psychogenic non-epileptic seizure or functional seizures, just because there is more research done and more published articles and data in this field compared to other functional disorders fields. I will briefly touch base on why is it so difficult to diagnose and treat these patients and provide updates on standardized FND management practices that are available in pediatrics, and with specific focus on the review of clinical pathway for evaluation and management of somatic symptom and related disorders. Before I start my presentation, I want to briefly touch upon that even though there are quite a bit of new studies published in pediatric population, it's still a very much under-researched field, and we try to use literature that is available in adults with FNDs. However, there are significant differences in pediatric presentation and in adult presentation, so you cannot just apply. Little kids are not little people, they are developmentally with brain development and psychodynamically with their emerging personalities and the huge impact on family relationships. It's a slightly different population, as one of our mentors, Dr. Rachel Kaplan, says, it's a different kettle of fish. So let's sort of start the background, how we conceptualize diagnostically. And it is very important because we now fully accept that FND, functional neurological symptom disorder, is not a diagnosis of exclusion. It's a positive diagnosis, meaning there is a positive diagnosis, there are positive findings, and now we have treatment specifically identified for this diagnosis. So in DSM-5 Diagnostic Statistical Manual, that's what we use in North America, and that's what most of the world psychiatrists use for research studies, in addition to ICD system. Somatic symptom and related disorders, sort of an umbrella under which FND falls. And FND is the same as conversion disorder. Conversion disorder is a legitimate diagnosis. It's not a null diagnosis, but it's certainly, at least in the United States, FND seems to get the momentum and is being used more and more to describe this group of conditions. And it is basically a broad, it presents with broad range of involuntary symptoms involving three major categories: motor area, sensory area, and cognitive disturbances. functional cognitive disorder is a very, very new concept in pediatrics. I don't think that we have a good understanding of that. However, clinically, we see that quite often. And each condition is different. That's why it's so difficult to study it, because it can present with a broad plethora of symptoms, whether it's weakness or paralysis that involves motor symptoms. So no function, exaggerated function, which is abnormal movements, whether it's tremors, dystonia, myoclonus, gait abnormalities, chorea, tics, swallowing symptoms, speech symptoms, attacks or seizures, sensory loss, or increased sensory experiences, with special sensory symptoms in every single available area of existence and functioning, cognitive symptoms, and most commonly, these patients present with mixed symptoms. And as the illness progresses, the symptoms tend to fluctuate and change. And while one category of symptom can disappear, the other category of symptoms may appear. And therefore, when you work with these patients, if you have a resolution of some certain category of symptoms, doesn't mean that there is a resolution of illness, because the patients may present with other symptoms. And that's why it's so difficult to do research in isolated symptom category, because if you look at one set of symptoms, the patients may present, for example, with PNES, psychogenic non-epileptic. If they resolve, it does not mean that a few months later the patient will not present with abdominal pain, which is very common in pediatrics, or movement disorders. So this certainly is a very complex condition to study. So why are we talking about pediatric FND? We do see significant increased rates in pediatric FND, particularly post-COVID, along with other pediatric mental health problems. Social isolation is not good for kids, and that their various stages of development has long-lasting consequences and effect on their development. So that's the reality. But also, we have significantly increased recognition of these conditions. And in all subspecialties and in primary care, which is a wonderful thing. We worked so hard at least I worked so hard on this for the past 25 years to increase knowledge and appreciation of this condition among child psychiatrists. And actually, we are seeing that. FNDs are associated with high medical care use and cost, and some studies show that treatment, evaluation of new onset psychogenic non-epileptic seizures is similar to the treatment of intractable epilepsy. And some other studies show that it's even more expensive than treatment of chronic neurological disorders such as multiple sclerosis. FNDs are highly correlated and comorbid with underlying psychopathology that often is unrecognized and therefore is often the driver for the somatic symptoms. And it's very important to put those factors together, because the outcome studies that we have show that positive, optimistic outcomes are associated with timely correct diagnosis, early psychiatric treatment, multidisciplinary care, and early symptom remission. And I will demonstrate that later in my talk. So let's talk about the incidence. These are the studies that looked at the FNDs, except Dr. Hansen's study that looked only at PNES, and it was a population-based study in Scandinavia. So the rates per 100,000 range from 1.3 to 18.3. So as you can see, very different rates, different studies, different methodologies, but overall, roughly speaking, it's from 1 to 10%. And the studies that have little asterisk are with low risk of bias. As I mentioned, these are very, very complicated studies to do. So I'm very happy that we have this data. It was lovely to hear Dr. LaFrancis talk on etiology. Unfortunately, in pediatrics, we do follow a bit of adult FND teams and their research. Besides, we look at the etiology from biopsychosocial perspective. And as we study psychological and social factors, and I'll briefly mention some factors associated with that. These are the new and emerging studies in pediatrics that look at the biological aspects. And we now all agree that FNDs, and again, I'm looking at the big picture, FNDs, not PNES, which is my particular area of expertise. But this is a multi-network brain disorder, and we agree with that. From the neuroimaging research studies, we know that there are brain emotional processing regions are overactive and over-dominant, and they over-connect with either motor or sensory processing regions and disrupt the functions, meaning voluntary control of functions. And that's when you have a dysregulated state. When the silent networks have to be at rest, they are hyperactive and they are hyper-connecting. In a few studies that we have, my data in functional neuroimaging can show that that is clearly more active than in healthy controls. However, we do not have studies that would take kids just with FND symptoms, let's say PNES, INA-GNG, and control them with kids who have anxiety disorders or depression with no FNDs. Because I will show later that 80 to 100% of kids with FNDs have comorbid psychopathology and most common anxiety disorders. So, but if we don't have studies to show how it looks in comparison with kids with anxiety disorders. There are studies in patients with anxiety disorders, but that's a different question. So we do have this evidence now of abnormal connectivity between motor control areas and amygdala, insula, alterotemporal parietal junction, and insula cortex. Now, one study shows that there are also neurometabolic alterations in motor sensory, emotional processing, and cognitive control domains at multiple levels of central nervous system, at the neuronal level, at the glial cell level, and in neurotransmission level. That shows also dysfunction in energy regulation. So studies are coming, we're learning more and more, but we need even more than this. So the risk factors. Study after study after study, and we have a large body of literature published in this area, show that the most common risk factors are related to family functioning, to academic performance, to social functioning, and to interpersonal problems. I want to highlight again that in contrast to adults with FND, physical and sexual abuse are reported less frequently. Not to say that these children are not exposed to adversities, and adversities can be conceptualized at different level of one's experience. So, biological vulnerabilities. These children are sickly kids. They have common pre-existing and coexisting medical illnesses and very common pediatric illnesses, infection, inflammation. Also, these children may have higher rates of physical trauma, injury, neurodevelopmental conditions, and about 30% of patients with PNES have comorbid epilepsy. In our study, we showed that patients with PNS have much higher prevalence of pre-existing problems than their siblings. So we took the families and siblings were controls, which gives us a very important insight into the unique presentation of FND patients. We also know that it's more common in female gender beyond adolescence and in adolescence. The average age of onset is about 11.8, 12 years, and very high comorbidity with mood disorders. From psychological perspective, these kids are high somatizers, and it emerges more in young adolescents and adolescents. And what happens at that time, the children become to exhibit separation and individuation from their families. So this emerging transition developmentally into adulthood is a very stressful time with emerging personality traits, with emerging independence. They may have difficulty with coping or independent social problem solving and communication, and development of self-confidence and sense of control, personal, social, academic, sexual. These are some of the psychological factors that need to be addressed and taken into consideration when doing therapy. Now, again, as children grow older, they become more independent. They are exposed to more adversities and trauma. Now, with exposure to social media, kids don't have to leave their bedroom, their house, to get traumatized and to get bullied, cyberbullied, or social media bullied, and have exceptionally traumatic and adverse experiences. So kids are exposed to trauma continuously, and they do evolve into more so complicated social and personal relationships. But what we've demonstrated that one risk factor is rarely a cause or triggering factor. It's the combination of individual vulnerabilities that are interconnected and cumulative. The more problems you do have in all areas, biological, psychological, and social, the more at risk and vulnerable you are. And in our study, multi-site study of risk factors, we demonstrate that the psychosomatic components, psychological and somatic, in addition to adversity vulnerabilities that differentiated kids with PNS from their siblings, there was statistically significant difference. So clinical characteristics in pediatric FNDs. These are the studies that actually looked at the FNDs, and you see these are pretty respectful studies with as large as 200 subjects enrolled in Dr. Ani's study in England. Most common presentation in most of the studies, except Dr. Aper's studies, is a multiple symptom presentation. And each study varies. As you can see, motor symptoms are highly common. In some studies, abnormal movements more common. Sensory seizures or attacks or psychogenic non-epileptic are common, but probably at some point, each of these patients have other symptoms. We are just not catching them, or we are not studying. But the most research is done in psychogenic non-epileptic seizures, at least in pediatric population. Psychopathology is very common, and depression ranges from 2 to 63%, and this is in children with psychogenic non-epileptic seizures. Most common diagnoses are anxiety disorders. And as you know, anxiety disorders in pediatrics tend to, again, fluctuate and range based on developmental phase, from maybe early on separation anxiety in younger children and pre-adolescence. And if that is not resolved, it goes into pre-adolescence and impairs development of independence. Then as they develop more independence, you start seeing more social anxiety that again can significantly impact transition into adulthood. And then you can have generalized anxiety, worries, academic performance, social performance, sports, athletics. These kids often are professional athletes. And then changes or exposures to adversity. We know that youth with PNES have increased risk for pre-existing psychopathology compared to those with epilepsy and healthy controls. In our study, about 40% of kids with PNES already had pre-existing diagnosis, and about 40% of them received a new psychiatric diagnosis in the first 2 years after PNES diagnosis. So very often, which is sad, that these kids have to present with such dramatic somatic symptomatology to be identified as having pre-existing or comorbid psychopathology. This table demonstrates a difference between a statistically significant difference between PNES, epilepsy, and healthy controls. And to no surprise, we have a statistically significant difference in emotional anxiety, OCD, and mood components in kids with PNES, adjustment, PTSD, stress-related disorders, in neurodevelopmental conditions such as ADHD, ASD. However, we see that intellectual disabilities are about the same in epilepsy and PNES. And the study was looking at the treatment. Again, our study demonstrated using standardized psychiatric assessment instrument, KIDI-SATS. It was a prospective study, so we assessed patients with PNES and their siblings, and we found that anxiety, depression, and PTSD were more prevalent in PNES than in youth, in siblings, that the severity of psychopathology, number of diagnoses, was related to having epilepsy and learning problems, and PNES subjects experience greater anxiety sensitivity. This is a very interesting concept, and Dr. LaFrance mentioned that in his talk that these patients are very sensitive to anxiety, to bodily perceptions. So that's exactly what it measures. It's sort of like an explanation of some of this body-mind connection or psychopathology. So basically what happens, these patients are more sensitive to normal bodily sensations. So for example, if they are exercising or they're running and they are breathing fast or they have fast heart rate, tachycardia, they perceive or misinterpret that as dangerous. And these children, we found out, are more inclined to do venting as coping mechanism, meaning solitary emotional expression, keeping to themselves, dealing with issues by themselves rather than expressing and communicating. Treatment. Not too many studies in pediatrics, but we are seeing more and more. The key component is multidisciplinary treatment. So this is sort of basic summary. Most commonly used therapeutic modalities, psychotherapy, is psychoeducation and cognitive behavioral therapy. We do not have randomized controlled studies on the use of SSRIs or other psychotropic medications in pediatrics, so we're using studies in adults that have demonstrated PNES symptom reduction when using SSRIs and CBTs. We are seeing increased use of PT, OT, and rehabilitation medicine, and I think we still are not possible to conclude from the available literature that one treatment approach is superior to another. It's a multidisciplinary treatment that works. Psychoeducation, very important. If you don't do psychoeducation, explaining to these parents and patients body-mind connection in a non-stigmatizing, integrated model, you have very little chance getting these patients and their parents on board with you and using your proposed treatment. So very important. You have to explain FND as a disorder that involves dysregulation within body, motor, and emotional circuits. You have to talk about somatization and stress and relationship between body and mind. We use psychiatric and medical comorbidities using evidence-based practice guidelines. Recognition and treatment of underlying psychopathology is very important. Using medications and therapies. Cognitive comorbidities, although not expressed as intellectual disability or developmental delays, most of the patients, although there's a subgroup of these patients. However, very early identification of underlying learning and speech and language problems is fundamental because these children struggle in school with learning. And these conditions are often unrecognized. And very often they are difficult to differentiate from underlying anxiety symptoms or as well as depression. And the last step is to discontinue unnecessary medications, including pain medications and anti-seizure medications when appropriate. CBT is one of therapy modalities, and it's the most published and researched in this population using standard principles of cognitive behavioral therapy. However, the difference is that why CBT is different for patients with FND compared to patients with anxiety, and we know it works very well. Because these patients, each patient is unique. Each patient has a unique cluster of symptoms, and you need to identify those symptoms and develop individual strategies to change the patient's response to specific symptom triggers that works for them using the basic standardized guidelines and treatment principles. Working both on response to trigger, cognitions, and processing. One of those studies is called REACT by Dr. Fabian, Retraining and Control Therapy. It's a short treatment, 8 sessions, and they are targeting specific symptoms. This is the beginning. This is just the beginning. As Dr. LaFrance said, that's how you build the foundation. You cannot work to underlying unconscious concepts in these children if you do not start with this foundation, symptom treatment first. CBT in stepped care pathways, you have to develop the hierarchical approach to treatment that tailors the level of intervention based on patient's need and progressing from less intensive to more intensive interventions as required as patient is developing more abilities to recognize the triggers, the perpetuating factors, and to talk about it. If a patient has trauma symptoms like flashback, dissociative, you have to address that. Another most important component in pediatrics is family therapy. You have to address dysfunctional communication patterns, specifically psychosomatization. Very often families do not talk about anger, jealousy, trauma, negative feelings. Those patients often present with somatic symptoms, and that is acceptable, and that is okay to talk, but not about the underlying negative emotions. Also, to reduce secondary gain and educate parents on what to do when the child is having symptoms, using supportive but not reinforcing responses. Families are given structured plan, how to respond, how to ensure child safety but not reinforce the behavior, how to give minimal attention to symptoms, and how to address other attention-seeking behaviors and learned responses. Now, more and more studies are coming on psychologically informed physical therapy for patients with motor sensory disturbances. And it's important to know that these specialists are very good at recognizing physical symptoms, but they're not very good at recognizing underlying psychopathology and therefore tend to minimize that. But the most important thing that what works is multidisciplinary integration and rehabilitation. And the
Sagita, just say 2 minutes if you could.
Running through my slides, and I am almost done. One of the so that was outpatient treatment. That's where mostly treatment happens. We do have clinical pathway for somatic symptom and related disorders in pediatric hospital setting. It requires early involvement of mental health team, both during starting with diagnostic evaluation, multidisciplinary communication of diagnosis, collaboration with outpatient providers. So we have a follow-up study implementation that using the pathways saves money, reduces length of stay in the hospital, however, still provides complex evaluation, and outcomes are associated with early diagnosis, early symptom remission. You have very short time. The study shows that at 1 month, there was 70% improvement. At 3 months, 75% improvement. But at 12 months, only 32 had, 89 had complete remission, and 32 had, 32 had complete remission. About 90% had some remission and improvement. So basically what we know in pediatric PNES, that early diagnosis and remission, sustained resolution, a third, and a third. Third improves with resolution, third improves, continues to have symptom, and a third continues to have ongoing symptoms that last into adulthood. 21-year-old study, 23% in adulthood. So in summary, functional neurological disorders is a brain disorder with emerging new research exploring motor sensory, emotional processing, and cognitive control networks. We know that pediatric FND rates are increasing. The risk factors are cumulative, but if they are addressed in a collaborative multidisciplinary fashion, they can be recognized and addressed, and we have now standardized approaches and including management in inpatient setting. This is my thank you from Chicago, our famous bean covered in snow, however, still beautiful. And I hope you come to Chicago, and it's a beautiful city, whether it's covered in snow or in a beautiful sunset. Thank you very much for your attention, and I look forward to answering questions.
Thank you, Sagita, for a superb overview of pediatric FND. I'm just going to take chair's privilege to ask a question, unless there are lots of questions in the room that have emerged or online. I can't see any in the chat, but I don't know, Jazz, if you've got any in the room.
No, you can start with yours, Tim, and then I'll let you know if there are any questions here. Looks like Hetal has got his hands raised.
Okay,
so we got quite
lovely.
a few here as well.
Yeah.
We've got 10 minutes only, so yeah.
Yes, no problem. So yeah, I was just going to ask both of you about the potential role of medications in FND, and obviously Kurt's great study was comparing CBT and sertraline and combinations of the two, I guess many of us wouldn't see medications as having a key role, and as you point out, Sagita, often we're de-prescribing rather than prescribing. But I think and I think that's often our main aim, but I don't know if either of you would comment on the role of medications, both in terms of treating comorbidities, which are common and important and often missed, including PTSD and OCD particularly, but then also of any role of novel therapeutics, which are starting to be trialed. So I don't know if either of you could comment on the medication issue. Maybe start with Kurt.
Tim, Sure. Our first study, as you probably know, was published in the early 2000s. It was the INA-GNG that was starting with the medication SSRI versus placebo. It wasn't powered for efficacy. It did show within SSRI group a 48% reduction in non-epileptic seizures. Placebo group showed an 8% increase in NES. Again, not what that showed basically is you can have some symptomatic reduction, but it doesn't cure or fix the patient, hence moving into psychotherapies. Just like you said, Tim, treat comorbidities. There have been a number of studies that have, or rather there's anecdotal data of using analgesics. Some have used mood stabilizers. Just to also note to clarify, anti-seizure medications don't treat non-epileptic seizures. You may be treating the comorbid depression. I'm sorry, you may be treating the comorbid pain or the headache, the migraine prophylactically, or chronic neuropathy, that type of thing. And with that symptomatic reduction, you may have an impact on the triggers for the non-epileptic seizures, functional dissociative seizures. But as far as do AEDs treat NES? No, they don't. You can still use medications to treat comorbidities.
Thanks, Sugita.
Yes, a similar approach in pediatrics. We treat comorbidities, and these cases are very often, sometimes you have very intractable underlying psychopathology, and we heavily use SSRIs or any medications that are evidence-based for specific comorbid diagnoses. But it requires intensive therapy and various therapies, starting with symptom control, symptom management, into more evolving anxiety treatment, into more evolving, more different types of therapy, supportive and family therapies, very important.
Thank you. Just to flag up some, I think something I find personally clinically very useful is the concept that the patient's whole nervous system is dialed up sort of very hypersensitive, so they often get I think actual organic or pharmacologically mediated side effects and also nocebo side effects more highly than others. So starting low and going slow is often a very helpful tip with people who cannot tolerate. So if you start at normal doses, you might get an adverse reaction leading to not wanting to try medications that could be very helpful for an underlying PTSD, OCD, depression, anxiety, whatever. And also to flag that there are new novel, trials of sort of pseudo-novel treatments such as psychedelics, which there's a renewed interest in. Obviously, there's a lot of sort of hype and hope around these being used for everything. But I think for functional disorders, I think in terms of the way we understand the predictive coding model of both psychedelic action and FND, I think there's a lot of promise there potentially as well.
Just one word. In pediatrics, as everything is a bit more complex, so children's brain are very sensitive to medication dosages. However, their metabolism is much faster, so they metabolize those medications very quickly. So sometimes you actually need to go up on the dosing because they are just, the livers are still young and healthy and they are working. So, so it just sort of a bit of art sometimes to adjust the dose for the kiddies.
Great point. So Jazz, was there someone in the room with a question?
Yeah, I think we have got a few people. Let's start with Hedel. You raised your hand.
Thank you. Anyone has any experience of working with asylum seekers and issue of functional cognitive disorders amongst them? Because there is history of trauma, inherent inconsistencies in their stories, and significant memory issues. Any comments on that from any of the speakers or Dr. Nicholson?
I can say I don't have any experience with this group of patients.
Specifically with asylum seekers, no. There is from the wisdom literature, King David was trying to escape, not be taken captured by his enemies. So he feigned insanity and a cognitive issue. And at that point, he was deemed to be out of his mind, and the opposing enemy king said, "We don't need to waste our time with this guy," and so they let him go. And still, you had King David of Israel survived because of that.
Okay, we'll move on to the next one.
Oh, very
Yes.
quickly to say, I do have some experience of this, and it is quite common because of the trauma often. But the resignation syndrome was a very fascinating syndrome that has particularly occurred in Scandinavia, of asylum seekers who are being threatened for deportation back to a war zone and from a stable life back to a highly threatened life. And this is where they have a sort of functional coma, essentially, where they it's almost like a hibernation state, so they become very withdrawn, unresponsive. It's a fascinating disorder, quite rare, and culturally rare in certain conditions, but it's just shows the potential for very severe functional syndromes in the context of asylum seeking. And yeah, sorry, Jazz.
Thanks, Tim. Krish.
One underlying theme that we see in a lot of patients with FND is dysautonomia. So whether it's a non-epileptic seizure, whether it is some other form of some other presenting form of FND, because we do multidisciplinary assessments that include the physiotherapist, the psychologist, a holistic physician, and a clinical neuropsychiatry fellow for every patient. And we do ANS, an autonomic nervous system checklist with lying and standing BP and pulse for all these patients. And we document clinical POTS in a very large number of them. I just wanted to ask both speakers whether autonomic dysfunction as part of FND has been looked at, because in one circumstance, we've seen this come to the fore. It's in the long COVID symptoms. Many of the people with long COVID symptoms have got unexplained symptoms as well, and they have dysautonomia. And the other, I saw Neeraj's question in the chat box about ADHD. The neurodivergent children, many of them have got dysautonomia as well. So it's unexplained fatigue that prevents me from going to school. I'm refusing to go to school. My parents are upset with me. Those stories keep repeating themselves. So just your experience on this.
Sagita, do you want to talk about your kiddies with POTS, Ehlers-Danlos type 3, irritable bowel, fibro, keep going on and on?
So this is exactly what we are seeing, and that's what studies demonstrate, that 70% of kids with functional neurological disorders have multiple symptoms, and dysautonomia or autonomic symptoms is a huge part, whether it's POTS or headaches or fatigue. Absolutely. Now, very often those young pre-adolescents have tendency to fainting and autonomic dysregulation. It's sort of almost like a biological process when the brain are developing hormonal changes, especially in girls before their menses, and it's a big part of pediatrics, as well as abdominal discomfort, GI problems. Multiple testing, multiple evaluations, rarely finding objective findings. Another factor is that these kids have more and more sedentary lifestyle, sitting in front of the screens, not drinking water, not exercising, not running around and playing. So there are those cumulative multi-factors that affect their overall health and growing and developing. And you add this social difficulties in transition to independence, you have a child with multidimensional impaired symptomatology. And ADHD, very important question. Yes, we see that. So basic evidence, basic population studies on incidences, 10% of boys in United States have this ADHD. So because this is a population where we see more girls than boys and more in adolescents, we often see subjective sense of distractibility and inattentiveness that leads to learning problems. And that's why I said learning issues are very prevalent. However, attentional issues are non-specific to ADHD. Patients with depression have inattentiveness. Patients with anxiety are often have running thoughts, distracted mind. They are very fidgety often. And you have to differentiate what is the driver. ADHD is often, especially an attentive type, is often underdiagnosed in girls. Boys present with combined presentation. They are disruptive, they are hyperactive. In a girl who has attentional issues due to ADHD, sometimes often sits quietly in the corner and does not cause any problem, but she has trouble learning. If you have also anxiety, here you go. You have to address both issues. So very important. When there is ADHD, you treat with stimulants and other evidence-based guidelines.
We
Thank
are
you.
really running out of time. Sorry, Tim.
Yeah, sorry. Yeah,
just-
it's great discussion. Just to add that, that I would say the autonomic. I'll share a paper with everybody about the dissociation between autonomic symptoms and autonomic function. And personally, I would frame a lot of the autonomic symptoms as part of people's complex PTSD, which I would see as an autonomic disorder largely myself. So I think it's framing it as a complex PTSD with autonomic features. And hypervigilance, dialed up nervous system. So it's the pathologization of borderline abnormal autonomic tests, I think, which is also the problem, and the dissociation between that function and symptoms, where functional disorders exist.
Yeah, I have just two quick questions.
No, sorry, Praveen. We have
one question. Okay, one question.
We don't. Okay.
One. So what
has
should
to
the
be quick,
approach
10
in
seconds.
cases with dual diagnosis, say epilepsy with non-epileptic attacks? How will be our approach? Will it be the same, or communicating diagnosis to families with a dual diagnosis where there is epilepsy plus non-epileptic attack? What should be the
Art, would you like to
treat both of them? Sure. Yeah, treat both of them. Make sure that you know the ictal semiology for one and know the ictal semiology for the other. And then don't chase non-epileptic seizures with anti-seizure medications. For the epileptic seizures, use the lowest effective dose of the anti-seizure medication and let the family know we're not going to keep going up on the medications for the other type of seizure. We're going to manage both of these. And you can address both of the epileptic and non-epileptic seizures with psychotherapies also to equip them to address some of their conditions.
Thank you so much, Good. I think we'll close the session here. Thanks,
Right.
Tim. Thanks, Sagita, and thanks, Kurt.
Thank you very much.
We'll set up for the next session. There's also there's also coffee there if anyone wants to go and get it. But we'll start the next session as well. So Shell is chairing the next session. Okay. Sorry, Julian has been waiting for us 11:30 p.m. where he is, so he's dying for his sleep. Thanks.
So Jazz, would you like Jazz, would you like us to start or? Jazz,
just 2 minutes. We'll set up the slides.
Oh, okay, very good. All right.
I now request Dr. Rama Rahu, Chief Clinical Officer, Buddhi Clinic, to felicitate Professor Kurt.
Nice to see you, Shell. I'll get back to you the emails I owe you. Yeah, nice to see you.
Nice to see you too, Tim.
Yeah, I'm confessing to the poor responses. I'll get back to you hopefully today. Nice to see you, Jim. Bye.
It's just like truly global that just like the last session, we have Professor Sigita at 5 o'clock in the morning, Professor Tim in 11 o'clock in India, and the audience in Australia. And here we have Professor Trawler in nighttime in, of course, midnight, Melbourne. Professor Shell is there in, like, is it what, 5 o'clock there? 5:30?
No, it's now 7:30 in the morning.
Oh, it's 7:30. Okay. And here we are in the evening, so we'll just start in 5 minutes.
Okay.
2 minutes. Slide, introduction slide.
So I think we're good to start.
Sorry, Shell, we're good to start. So if you want to introduce, I mean, we've got your slide there.
Sure.
Right? You can
And
do a quick introduction.
is Dr. INA-GNG in the room there?
No.
Is she here?
I haven't met Dr. INA-GNG, and I see she's co-chairing the session.
We'll try to find her, but she's not in the room at
Oh,
the
okay.
moment.
All right. Very good. Well, so I think we are the last formal session of the conference, and Professor Trawler is staying awake for this, and I got up early for it. So, and I guess we don't want to stand between you and dinner either. So, anyway, I'm delighted that I'm sorry I can't be in the room there with you, by the way. I see some old friends in the room, but anyway, delighted to introduce Professor Julian Trawler from Sydney, Australia, University of New South Wales, where currently he is director of the National Center of Excellence in Intellectual Disability, but previously was head of the Department of Developmental Disability Neuropsychiatry at University of New South Wales, Sydney. And Professor Trawler will and Dr. Fischel each will be giving 20 or so minutes presentation, and Dr. Trawler has asked that we discuss questions immediately after his talk so that he can go back to sleep research tonight. So, Professor Trawler, why don't you take it away?
Thank you so much, Shell, and it's delightful to be with you this evening, your time, this morning, or at night, wherever you are. If I don't seem as lively as normal, I'm sorry. I have a respiratory virus at the moment, which is causing some issues, but it's great to be with you. I'm taking a population health perspective today, so I'm shifting gears slightly from the previous speakers. I just wanted to mention a little bit about our national centre here at UNSW Sydney. It's essentially a response to the really huge population health gaps for people with intellectual disability. And I think it's a great encouragement that investment by government has been made in this sort of initiative. And our aim is really to see that every person with intellectual disability in Australia gets access to the high quality healthcare that they need. I need to acknowledge the funding that comes from our Australian government and a number of other sources, and the source of some of the data I'll be using today, which relates to large-scale data linkage that allows us to capture a population of people with intellectual disability living in one state, and our national efforts to ensure we can see that across the country. I'll be talking a little bit about some key metrics for this population in terms of their overall health needs, and looking at two case studies, one around mental health and another around cardiovascular disease. And I'll explain why I've chosen that case study, and then talk a little bit about some actions that we can all take and responsibilities we all have to contribute to supporting better healthcare for this group. We, of course, all in the room should know what an intellectual disability is. It's a developmental disorder characterised by below average intelligence, adaptive deficits, and it's a very variable condition that we see people at the mild and upper mild levels living independent lives, married with children, through to people living with profound multiple disabilities with very severe impacts on functioning. In Australia, we estimate from our latest population data, about 2% of our population are living with intellectual disability. This is about 500,000 Australians. But then when we think about who's impacted and we think about family units here, if we extrapolate from our population data, we know about 1.4 million individuals or family members are living with intellectual disability more broadly. Worldwide, if we extrapolate to 2%, we understand that about 165 million people worldwide live with intellectual disability. The health disadvantages of this group are really quite startling and uniform across different studies. On average, we expect in developed nations to live into our 80s on average. But for people with intellectual disability, frailty is brought forward on average 25 years, and death is premature. And the degree of that depends on the study. But essentially, this health disadvantage at that course level is less linked to the etiology of the disability and more linked to lifelong health disadvantage, particularly around access to preventive health care. And I'll explain some of that in a minute. In Australia, so concerning was the evidence of the discrimination in healthcare and poor health outcomes that we had a judicial inquiry into the experiences of people with disabilities in our community. And largely on the basis of the experience of people with intellectual disability and autistic people, this formal inquiry, concluded that people with cognitive disability, as they were bunched together, have been and continue to be subject to systemic neglect in the Australian health system. This finding is really stark, given Australia has a really robust health system. It has one of the world-leading health systems. It's a public health system that is supposed to address health needs of all. Over time, we've accumulated some evidence that really helped the discovery of those health gaps. In people with intellectual disability, we've shown that the median age of death is 27 years younger than the general population here, and that death from potentially avoidable causes, these are causes that could have been prevented through routine access to healthcare or primary or preventative healthcare initiatives. The potentially avoidable deaths are more than double that seen in the general population. We've shown that mental illness and serious mental illness is very common, and I'll come to that in more detail, and that serious mental illness itself is associated with risk for death when we've looked at predictors of death. We've seen that rates for potentially preventable hospitalizations, these are ones that could have been prevented through access to healthcare in the community, are about 4 times that of the general population. And we've seen that presentations to emergency departments and inpatient admission rates overall are twice that of the general population. We've also shown that healthcare is really inefficient, and I'll come in detail to that, but mental health, after a first ever mental health episode or a first ever episode for a physical health condition such as a first seizure, we see very high rates of representation to emergency departments and readmission for same condition compared to the general population. We've begun looking at other indices of this health gap, particularly screening, participation in screening for cancers, bowel, breast, and cervical are the common ones here, showing lower participation rates and lower adherence over time. And we've also seen in our data sets lower access to vaccinations. So these are signals of a major health gap or health inequality for this group. In terms of the mental health gap, I just wanted to talk about a couple of papers we've published through the year, one on prevalence of mental health conditions and one on predictors of first episode of a mental health issue. For the prevalence data, we've shown that 76% of all people in our large population data set, 76% of those with intellectual disability had experienced a mental health issue, and this is double that of the general population. 16% had experienced a serious mental illness, and that is 3 times the proportion seen in the general population. When we looked at the specifics of that, essentially there's uniform increases, but some are dramatically so. Obviously, you would expect that autism and ADHD co-occur with other developmental disabilities. And so the dark green is representing people with intellectual disability. The very light green is the general people without intellectual disability who are matched for age, sex, and socioeconomic status and rurality. So across the board, for all major clusters of mental illness, whether it's psychotic disorders, anxiety disorders, personality disorders, we see higher proportions. Dementia is particularly common in this group. And if you look at age group prevalence by intellectual disability status, the red line here represents people with intellectual disability, the blue the comparative sample without intellectual disability matched appropriately. You can appreciate that this higher prevalence occurs across the whole lifespan. And if you look at serious mental illness or psychotic disorders, you see a much earlier impact of those disorders compared to the general population at an earlier age, and a much more rapid rise in the numbers of people impacted by major mental illnesses or psychotic disorders. You can also appreciate a much earlier onset of dementia and much higher overall dementia prevalence rate. Of course, risk factors for mental illness are many in this population. Many people experience trauma and abuse in their background. There are biological determinants, major psychological, social determinants, particularly around inclusion and the positioning and the valuing of people with intellectual disability in our society. And the stigma and discrimination they experience is substantial, despite us living in a country which values equity and fairness. We've recently looked at predictors of mental illness, that is a first episode of mental illness. We've seen that risk factors for any mental illness include obviously ADHD and other learning disorders, physical comorbidities, and socioeconomic disadvantage. When we looked at serious mental illness, male sex, having ADHD, learning disorders, prior mental illness, remote living, we have a very dispersed population, raise the risk, female sex and certain other conditions protect. But essentially, if you think of the findings overall, the very, very high prevalence and these predictors of mental illness, we can see that we are under-resourced as far as specific mental health services for this group. That's slowly changing, but there's certainly an underpowering compared with the need. We see an impact of this in the mental health services system. So we see that people are admitted to our mental health units twice as often. They are 5 times as likely to experience very long stays, and they're twice as likely to be admitted more than 3 times a year. And then when we've looked at whether the hospitalisation is effective, after discharge following first ever psychiatric presentation, we've seen that having intellectual disability is the key driver of representation to the emergency department and readmission to hospital, and it's second only to having a drug and alcohol comorbidity. We've also looked at whether the healthcare provision is efficient. In this study, we had only captured 1% of the New South Wales population as having intellectual disability, but they were 6% of all mental health service users, and they were using 12% of our state's mental health budget to meet their needs, 14% in the inpatient unit and slightly lower in the outpatient units. And of course, I've highlighted previously the importance of mental illness as a key driver of mortality in this group. So at a univariate level, the hazard ratio is 24 for having a serious mental illness in relation to risk of death. And in a multivariate model, that's reduced somewhat, but it's still 4-fold hazard ratio of over 4. Of course, there are many barriers to good mental health care, and solutions require both equipping the person with health literacy and tools to navigate their health journey, and those around them, family members and disability professionals that are supporting the person, often lack the know-how. And so there's a lot that can be done to overcome barriers in those spaces. But of course, we also have a under-trained workforce and lack of specialised services, but lack of services that have knowledge or understanding of how to adjust their services and communication and interactions with the person to be able to communicate effectively. We've looked at this systematically in a number of papers and also in a systematic scoping review over time if you're interested. We've done a detailed policy analysis in this area, and certainly despite being an ultra high risk, there's very poor representation in mental health policies, and this is a factor internationally. So we need to do better. Let me talk a little bit about the cardiovascular health gap as case study 2 to complement this mental health focus. Essentially, the reason to focus on cardiovascular disease in this population is that it's the leading cause of death, as it is in the general population. And it's not only the leading cause of death, it's the leading cause of potentially avoidable deaths. These are deaths, as I said earlier, that can be prevented through access to healthcare and through the lifespan in a way that mitigates risks. We've looked at our population health data, and the purple bars are the cardiovascular disease prevalence rates per 100,000 people over a long time period in our data sets, and the green is the comparator population, people matched on all of the right characteristics, but without intellectual disability. This high prevalence of cardiovascular disease really holds regardless of the sort of domain of cardiovascular disease you're talking about: cerebrovascular disease, hypertensive diseases, ischemic diseases, diseases of arterioles, etc., so peripheral vascular. If we look at factors related to death, having heart disease increases your risk in a multivariate model of over about 2.5 times, so the hazard ratio is 2.5 times. That is the strongest driver of any physical health condition of risk of death. We've recently looked at cardiovascular disease outcomes following the first presentation with an acute coronary event or stroke, and compared people with and without intellectual disability. In terms of readmission in the first 30 days after the acute or index episode, we can see that intellectual disability is a big driver in a fully adjusted model. The odds ratio is about 1.6. And if we look at the risk of death following the first episode of an acute coronary event or stroke, we can see that the fully adjusted odds ratio here is about 2.4. So intellectual disability itself carries a substantial increased risk of a poor outcome from physical health conditions. We have fantastic international policies that aim to reduce the burden of cardiometabolic diseases internationally, and some great initiatives in the UK, CVD Prevent, the Million Hearts Initiative in the US, and great initiatives by the World Heart Federation and the WHO. But these documents see disability as secondary to the conditions and don't have mention of disability as a priority population, and don't have any outcome measures that are particularly tailored to the needs of this group. Locally, Australia has a disability strategy, and it has a whole section that we managed to argue should be inserted into this strategy that relates to health and there's a particular feature on preventive health, and this is a major feature of our policy. We have a preventive health strategy that again was receptive to having people with disability named as a priority group, so intellectual disability included under that umbrella, and there's acknowledgement that the social and structural barriers for these populations should be addressed. We have a national action plan for heart disease and stroke, but surprisingly, some hearts and brains are missing from this. Disability is again seen as secondary, and people with disability are not a priority group. And we have our National Heart Foundation has a policy of heart health for every heart, but in fact, some hearts are missing. Disability is again seen as secondary, and priority groups are mentioned, but people with disability are not a priority group. So there are some huge gaps in our policy aspects. But of course, the cardiovascular disease risk management sits within this broader preventive health gap. I've illustrated that around cancer screening, immunisation. We know preventive health checks are lower in this population, and access to preventive health interventions, management of high blood pressure, high cholesterol, obesity, poor adherence to exercise and diet, and management of diabetes are poorly done and underdone in this population, as is mental health and well-being. So we've been working hard at thinking, how do we address this issue? Models of care here are needing to be developed. And we have two foundational bits of work. One is a large preventive health grant, this one on the left, which is really thinking, what do we know around the preventive healthcare gap? So we're measuring that using our population health data linkages. We're looking at the absence in policy and making recommendations. We've interviewed many people with intellectual disability, families, carers, disability and health professionals to ask about the barriers to preventive healthcare and to ask systematically in well-designed qualitative studies for advice on how to design better models of care. And we've taken all of that information and then co-designed new models of care that we're now trialling in a very limited feasibility set of work, which we hope to upscale with time. This is based on a method called health action planning, and I'll show you what that looks like in a moment. We have a second project called the Heart Health Project, which is creating or refreshing a tool that we previously developed, which has a cardiometabolic risk prevention framework and tools and resources for people with disability themselves, families and carers, and disability and health professionals. So it flags concerns, it shows people how to connect with the right resources to do a good job for this population, and then it sets targets that need to be monitored by the healthcare provider. The health action planning toolkits are across these domains because these are the pressing priorities: cardiorespiratory, medication review, because in our emerging data we're seeing impacts of particularly psychotropic medication prescribing on health outcomes, preventive health in terms of mental health planning, immunisation plan, and cancer screening plan. And there are health action plan toolkits for the relevant groups, which connect them with the resources they need to make sure that the focus is able to be addressed for each of those groups. I spoke of the cardiovascular disease algorithm and the resources. This is our mock-up of what the new version will look like. So you can see the red is the sort of signal that there's a problem. For example, take weight. Here we've got waist circumference, BMI. We've got pre-diabetes and diabetes measures, indicators here that we've agreed on. So there's a flag, there's something wrong. There's the carer support and lifestyle supports and behaviours and link to resources that enable someone to participate. For example, if they have pre-diabetes, there's a range of suggested actions and links on the final document with resources that are accessible. And then there's the target in green below. This is where we want to aim to get, having implemented the recommendations in each of these panels. This will be launched early next year, in the first quarter of next year, with all of the new resources. So essentially we can see that we have major gaps in health outcomes, and I think we need to take actions. There's lots we can do in terms of clinical capacity development, training and education of health professionals, improving primary and preventive healthcare, thinking about how we develop more specialised care models for where they're needed, enabling care coordination between the different sorts of supports for the person. And of course, there's lots of action around equipping people with disability and those around them in the healthcare journey. At a higher level, we need inclusion in policy, better models of care, investment in those services, good services evaluation so we know what works, and researcher and research capacity building and better research funding. We've just finished a funding audit nationally of intellectual disability health funding and shown a major gap, major underinvestment. So in reflection, people with intellectual disability do experience systemic neglect in many aspects of their healthcare. Any of the indices I've looked at suggest that that's an international problem, not an Australian problem. And this problem will continue unless we have particular actions. They could be wrapped up in a broader neurodevelopmental framework. In many jurisdictions, I think neuropsychiatrists and learning disability psychiatrists have a leadership role in building that capacity and leading population health initiatives. And I guess my challenge is, if you run a program for the general population, is it accessible to people with intellectual and other developmental disabilities? If not, why not? We're in an era where international conventions and most laws of countries would say that these have to be accessible to everybody. So there are key actions that could be taken. I think inclusion in policy is the key, education and training for our future health professionals, investment in those services, and in larger research and capacity building programs. And I think I'll stop there. You're welcome to sign up to our Centre News. We are creating a one-stop information hub for people with disability, families, disability and health professionals that will be launched next year. And that may provide some resources for you if you're thinking of capacity building locally. And I'll stop there. Hopefully I'll be able
Thank you
to.
very much. Thank you, Professor Trawler, for the 30,000-foot flyover of the Australian care system for people with neurodevelopmental disabilities. I can vouch for your comment about the excellent healthcare system in Australia, having sampled it myself when I was in Sydney, and I was a guest at one of your facilities. So in the 40 years or so that I can account for in my career, there's been a little bit of a change in psychiatry in terms of the attitude towards people with neurodevelopmental disabilities. In our institution in the 1980s, people would come to the neuropsychiatry clinic because the psychiatry clinic would not see them with neurodevelopmental disabilities because they felt they were outside the purview of general psychiatrists. And so when we would do an evaluation and try to refer them to the general psychiatry clinic, say for routine follow-up, they would say, well, we're not sure what to do with these people, wouldn't take them. Now they're seeing them. So we've now seen residents being trained, and we've seen an improvement overall. Now the problem that we see is when we decide that someone might benefit from psychotherapy and they say have ASD or a moderate neurodevelopmental disability, finding therapists in the community who feel they can treat these people is nearly impossible. Is there a parallel experience in Australia?
There is. We really don't train our future health professionals or our current ones how to do this well. An example is we audited nursing and medical schools nationally to look at curriculum content and showed very little curriculum content. And in fact, for the medical curriculums, we had a 20-year comparison because someone had done one previously, a colleague, Nick Lennox, and there'd been no improvement in 20 years. So I guess unless there are very specific initiatives that start to build that capacity and train people effectively, we don't get there. For psychologists, there are some good training materials. We'll be assembling some of those on the Knowledge Exchange Hub. And there are some tips on how to adjust practice to suit the needs. Some of those things are very universal and sensible things around simplifying communication, simplifying steps, for example, in cognitive therapy. So there are some adjustments that can be made that are fairly easy to apply. But then there are people with more complex needs for whom you need actual subspecialization within the area. Bearing in mind, this is an ultra high risk group. Almost universally, 76% of the population in our sample have a mental health issue. So it doesn't make sense to not address the needs. In fact, has a huge impact on lives and on quality of life and on participation in society. So it can have a profound impact.
It strikes me that part of the solution would have to be, I didn't see it particularly in your list, but it would have to be approaching the organizations that are the controlling organizations that define each specialty field in medicine and having them create the expectation that their practitioners include this within the domain of their skills. But we don't see that coming down from on high quite yet. I don't know whether there's hope for that.
There is in some jurisdictions, particularly in psychiatry, though we've hit a bit of a snag here in Australia lately. We've been progressing that, and certainly the Royal Commission I spoke of made a suite of recommendations in the training of current health professionals, including upskilling of key ones. And here we have developmental pediatrics, psychiatry, neuropsychiatry, and rehabilitation medicine and general practice, primary care as the main kind of specialties involved. And so they're the ones that we're trying to target and develop that capacity in.
Are there any questions in the room there? I can only see the table that Jazz is at. I see one hand there.
Krish has got a question.
Quick question, Julian. The challenge we see, and this is commented upon a little earlier in the room, that getting a formal disability status for a person with ADHD, for example, is quite challenging in our environment. Now, the other thing that was commented on, and Professor Dave Coghill, who's in the room, mentioned this, was also the disproportionate focus on autism, which is very much an Indian phenomenon as well. Intellectual disability probably has the same problem of neuropsychiatry, of being a little bit of a ragbag with not, what shall I say, it doesn't have the sexy one name or one person that can, one image that can attract support. So how do you overcome this, and do you even agree with me?
It's interesting you say that. In my experience, having worked intensively with autistic people and looking at population health needs there and people with intellectual disability, and I used that different language intentionally, is that the advocacy around autism is stronger, and that is partly because of the socioeconomic status of autistic people on the whole is better than that of people with intellectual disability. And obviously, the cognitive aspects of autism are variable such that it enables strong advocates to have more of a voice. And so sometimes there's been greater progression in capacity building and addressing population health needs in autism. I'd have to say that in Australia, the historical advocacy, systemic advocacy around intellectual disability health needs has been very strong. And so, in fact, in Australia, we're further ahead with implementation of a new national roadmap to improve the health of people with intellectual disability. And the Autism National Roadmap was only recently developed and now starting to get some funding. So it varies depending on where you are. This is, I think both groups and the broader neurodevelopmental groups are ones of such high mental health needs and have this crossover of need in multiple areas, including epilepsy. You look at the prevalence of epilepsy in people with intellectual disability and autistic people, and that the prevalence is really high. The outcomes are more difficult. So I think as neuropsychiatrists, we have this core contribution to make. It may not be sexy. There are sexy areas to get into if that's your thing. There are neurodevelopmental, neurobiological streams of research you can do in parallel. I guess I felt personally that I could contribute more if I focused away from the neuroscience, which is actually probably my passion, and more on population health, simply because there was more that I could drive at a population level that was of benefit across the range, rather than focusing on a particular syndrome or particular neurobiological elements. But I think you can indulge that if that's your thing. You can do many things, but I think it is a good area to get into if people are interested.
Thanks very much. Are there any other comments in the room? There?
There's one last question, maybe.
Thank you.
Is there any data about the level of intellectual disability and also type of intellectual disability and mental health issues?
Yeah, good question. So the vast majority of people living with intellectual disability, about 85%, have a mild intellectual disability. and then the rest have, obviously a very, very small proportion of that population have profound levels of intellectual disability. What we've not been able to do is to stratify mental health risk by intellectual disability status level. That is because our data captures don't adequately capture level of severity of intellectual disability. We're trying to address this in national data sets. The only way you can feasibly identify people at a population level is to combine lots of different national data sets, because people are identified for different reasons in administrative data, and that usually relates to the use of a services system or support. And there's lack of uniformity across those data sets. Ideally, if you were building a proper data system, you'd include level of severity of intellectual disability, so you could look at those outcomes and how they relate to severity of intellectual disability. In general, people with more severe forms of intellectual disability have much more in the way of behavioural presentations of their mental health symptoms, and sometimes that masks the underlying presence of a serious mental illness. So we still have to be very careful in screening, knowing this is an ultra-high risk population. So I would advise caution to assume that it's just behaviour when it can't be when you can't take a history conventionally. So you need to be very careful in those situations.
Okay. Thank you very much, Professor Trawler. I wish you pleasant dreams tonight.
Thank you so much. Thank you for the privilege it is to be presenting. And it's lovely to see some dear friends, yourself, Shell. Thank you for chairing. And yeah, it's been a great conference. Thank you very much for organising it. Bye for now.
We wish you a speedy recovery as well, Julian.
Yeah, thank you so much. See ya.
Cheers.
Okay, good night.
Bye.
Good night. So now want to introduce the final speaker of this symposium, Dr. Tamara Fischel, who's the head of the Consultation Liaison Psychiatry Service at Sheba Medical Center in Tel HaShomer, Israel. And her flavor of Consultation Liaison Psychiatry heavily interacts with the neurology service. And so she will be batting cleanup, as we say in American baseball, when the final batter's job when the bases are loaded is to come in and hit a home run and clean up the bases. So batting cleanup, Dr. Fischel.
Thank you very much. Thank you also for the promotion I just got, because I'm actually not the head of CL Psychiatry at Sheba Hospital, but I did run a neuropsychiatry of epilepsy clinic there. But I'm actually quite honored to be the last, because there are certain advantages if you'll stay till the very end. And I'm very excited for the first time to be here in India. Actually, when I look at a common line and thread through a lot of the lectures, a lot of people have spoken about how they're not really satisfied with our current frameworks. So really that's what I'm focusing on. I'm taking a bit of a zoom out and looking at global epilepsy as really a prototype for any kind of global brain disorder. And epilepsies have been my focus for a long time. I'm by no means a specialist in global epilepsy. I'm a novice and just starting to get interested. And towards the end, briefly discuss a project that I'm starting that I would be very happy for people here to get involved with. So I purposely paid homage to a story that you all know. It's an ancient Indian parable about the blind men and the elephant, describing several blind men, each touching a different part of an elephant and coming to distinct, incomplete conclusions about its nature. One feels the trunk and thinks it's a snake. One feels the leg and thinks it's a tree, and so on. The lesson is that complex realities can be misunderstood when only one perspective or vantage point is considered, and that a full understanding requires integrating multiple viewpoints, translating knowledge and modifying frameworks to the local environment and systemic system, whilst respecting not only customs and beliefs, but also getting acquainted with different frameworks of knowledge and personhood, not only to ensure successful interventions, but also because we have a great deal to learn from ancient Indian, African, Persian, and First Nation peoples the world over on their better understanding of complex systems, who in truth were the original developers of the One Health framework. This concept is highly relevant to global epilepsy care, where the narrative has been shaped by Western science and researchers. And let's see how that has affected what we know today and how we can look towards a different framework. So, sorry, no, why is that not moving? Okay. So I brought this just for all of us to be minded that whatever we think we know is based on our understanding of and our research, which is based on what we ask and how we question. And that although we're not responsible for somewhat at times dubious history in global health and in psychiatry, we are responsible to understand how our patients have experienced transgenerational trauma and how generations of approaches in public health have affected the way we interact with them now in the system. So to paraphrase Kierkegaard, we need to, in order to move forwards, we have to understand backwards. Why is it not working? Okay, no problem. So I want to bring it back to epilepsy and use epilepsy just as an example. So in post-war World War II world, in an attempt for not only psychiatrists, but doctors in general to disassociate themselves from generations of either colonial medicine and a focus on tropical medicine in the colonies, the attitude was to focus on what they called finding a common humanity. And by common humanity, that essentially meant our Western concepts and frameworks being used to understand global health. And let's just look at, when we look at the prevalence of epilepsy, the global prevalence, how when one looks at a purely global approach, it can often dilute the problems going on in the world. For instance, in the recent data, it looks like there's an overall improvement in overall epilepsy, but that doesn't really show the incredibly high incidence and mortality in low-resource countries, and especially in sub-Saharan Africa. It's clear that there is a distinction, but the situation is even worse than the data presents itself. Other than that, the focus now is on chronic diseases, and we seem to have left, except for HIV and COVID, the whole communicable diseases have now been polarized. So you either look at chronic communicable or non-communicable, but we have this dualistic approach that we don't look at all of it together. And if we look at the other map, looking at the death rate, well, there's just no data because it's not as interesting anymore. And let's look what's happened in the move in psychiatry from colonial to transcultural psychiatry or international psychiatry. Psychiatry disassociated itself from the approach of, the eugenic period and the institutions, the asylums, where we actually were part of institutionalizing people worldwide, also in the colonies, with epilepsy and with mental illness because of their erratic and threatening, what seemed threatening behavior that we couldn't understand. And now looked towards trying to understand a very common, almost homogenous way of understanding psychology. Now, it seems to actually be a more egalitarian way of looking at things, but in truth, what has happened, and especially in one can see it in epilepsy research, is the focus is on cultural beliefs and not actually on the differences that separate people. So the focus has been on looking at the Western world as being a bit more progressive and reflective, psychologically minded, and that in other countries, the focus has been on weird and wonderful, mysterious beliefs about illness, and focusing on stigma, focusing on witchcraft and all these kind of perceptions. But it is a bit disingenuous because the truth is that when at the very beginning, it was not about witchcraft, it was about a concept of spirituality, and it was really the West's difficulty to deal with that we delegitimized it and translated made it illegal and called it witchcraft. So we need to understand our history in order to understand really what's been happening. Now, what's so important about this? Because it's actually affected the data we have. So when one looks at, 1 second, sorry, that was the wrong, sorry about that, looking at the wrong slide. When one looks at, and I'll just give one example to see how the attitudes of psychiatry at the time affected what we actually know, what we think about mental disorders. So when they did an assessment of schizophrenia, they found that there was far less in sub-Saharan Africa, for example, and they interpreted that data to mean that there was less stigma because there was more communal support. And then they also found that the prognosis was better. And then that was our framework. And then we rearranged what we think according to the framework. If we look at the other map and see religious and spiritual beliefs, people dealing with depression and anxiety all over the world with either coping with either religious or spiritual activities, we can see that culture is not what distinguishes us. And in fact, if we look at some of the countries, Ireland, for instance, has the same level of religious beliefs as Ivory Coast. So that's not something that we would could use as a framework to understand things. What replaced then in the, let's say in the 60s with the anti-psychiatry movement, when the notion that mental disorders were being medicalized and the development of what was called the social causation theory, that essentially people were made by their environment and their situation and their circumstances, and that the systems, socioeconomic systems, were what actually resulted in people's vulnerability, which made them vulnerable to distress and mental disorders. And the focus in psychiatry was more on that we're all pretty much the same. Mental disorders are biologically the same, but we just express it in different ways. So the symptoms are just different. The question is, 1 second. No, keeps on jumping. Okay. So how does the global mental health challenge of people with epilepsy, how do we meet this challenge when we're looking at 20% of the research being conducted? Just not. Sorry, it just seems to. Yeah. That most of the research being conducted is actually focusing on stigma, social and cultural. 20% of the publications in sub-Saharan Africa are looking at social aspects and cultural aspects. So how do we reconcile that with the fact, for instance, that a study done in 7 countries saw that for instance, in Kenya, nearly 14% of people. Sorry? Oh, I don't know. Okay, thank you. That would be very helpful. 14% of people were thought to have psychosis. And I'm not going to go into all the different ways that it's been assessed. I just want to look at how the interpretation of these symptoms within the given framework, how there is almost making the data fix the framework. And so let's have a look. Next. So if we look at the prevalence of psychosis amongst people with epilepsy in Uganda, what we find is first that of those 6.8%, which is more than, we don't know what kind of epilepsy they had, so we don't know if it's amongst people with focal, but 60% of people in sub-Saharan Africa are thought to have focal epilepsy, and with the diagnostic gap, the prevalence is obviously far greater than we know. 47% meeting criteria for schizophrenia and 53% for other unspecified schizophrenia spectrum or psychotic disorders. Now, as someone who works with epilepsy, I can say that I don't think I've ever reached those statistics, but that just shows that the framework is a DSM-oriented framework and not in keeping with looking at assessing the psychiatric symptoms according to temporal relationship with seizure activity. But as I spoke to neurologists in sub-Saharan Africa, the conclusion was that they can't really do assessments like that because they don't have EEG machines. So how can they actually assess that way? Ultimately, the risk factors that were associated with psychosis were a history of epilepsy admission and stigma score. The conclusions that were arrived at were that social isolation, anxiety, and depression resulted from stigma, and they exacerbate psychosis in a dose-response relationship. Psychosocial stresses like social isolation and unemployment associated with epilepsy may increase psychosis risk, and so on and so on. And there are some studies that have found that a history of divorce, lack of knowledge, and certain other social factors are directly causal even of psychosis. All of these studies are cross-sectional, and so obviously no causal relationship can be established, but they do present what the basic framework is, which is a continuation of the concept that what distinguishes people with epilepsy in low-resource countries are social economic disadvantage and cultural beliefs, which of course I found incredibly frustrating. And so I decided to contact the modern Wizard of Oz next, who of course I mean ChatGPT, and I asked, what are the main differences in the approach to people with epilepsy in sub-Saharan Africa and in Western countries in terms of their mental health? Next. And this was the response. In sub-Saharan Africa, the emphasis is on access, on diagnosing infections, reducing stigma. The priority was social determinants, poverty, stigma, traditional beliefs. In the Western country, the priority was on individualized treatment, psychotherapy, access, polytherapy, but looking at also distinguishing medication side effects, periictal symptoms, and primary psychiatric disorders. In a sense, if we have a certain framework that we're applying in the Western world, which we know to be more accurate, then I think that this is a case of health inequity if we don't actually share that framework. We just need to learn how to adapt it, or rather we don't. We need to share the framework, and with professionals in the local environment, create another framework. There's almost a fear of discussing differences between people in the wake of the Second World War, as though that's something racist, but I actually think homogenizing the world's population is actually more prejudicial. I came across this next quote, a Bantu proverb: "The earth is a beehive. We all enter by the same door, but live in different cells." And I really like this proverb because the notion is that diversity is something that is almost necessary, but as is the interconnectedness, and also that each different unit in the honeycomb is equal, complex, and contributes to the final outcome. Now, one can ask, what is so important about these differences? And of course, the implications of misdiagnosis and diagnostic overshadowing are enormous, especially in sub-Saharan Africa, which I will show and illustrate that the implications of diagnostic shadowing have an enormous impact on both the diagnostic and treatment gap and on outcomes. Next. So I think it's time for an inclusive transdiagnostic framework for epilepsy in multiple contexts. One that's a brain model, that's not just brain and not just mind, but we need to be courageous and create a new model. Next. We need a model that doesn't go from top to bottom, where health policy and classification symptoms inform our clinical practices. Clinical practices have to inform classification models and policy. We need to have an inside-out model from cell to system. Next. This model is just something that I'm working on. It's neither published or validated. It's just something that I'm looking at, which is basically a modified model of the standard model that was published by the ILE Integrated Mental Health at looking at a framework for understanding symptoms. And the notion is that we compare global factors with actual clinical scenarios to predict the level of burden, but also later to be able to understand phenotypically. So I'd like to start with periictal injury. We all know that. The major comment the aspect I would like to look at is that one may not immediately get the connection, but if one looks at, next, at periictal symptoms, we heard in the last lecture that they're not very common. And I think that that's something that is obviously dependent on people's experience. But I think what's important, that might be a reflection of the level of seizure stability in that given environment. But if we know, and I think that this, next, this study by Professor Kanner is really something that had a major impact on me, and it really started to make me join the dots. In his study, he looked at, understandably, a small group of people, but he looked at a group of people with partial epilepsy over 3 months and looked at periictal symptoms using, there are no actually standardized questionnaires, but there was a research version, and they define something as being habitual if in more than 50% of the cases someone presented with a similar, for instance, 15% of people had post-ictal suicidal ideation, which means 50% of their seizures were associated with post-ictal suicidal ideation. And the conclusion was that 80% of people with medically resistant epilepsy had post-ictal psychiatric behavioral cognitive symptoms, which is really quite enormous. And we're talking about post-ictal dysphoria, mania, cognition. So I thought to myself, well, we're talking about the rest of the world with an 80% or 90% diagnostic gap and a 80% treatment gap and 60% diagnostic gap, with a predominance of focal epilepsies, which are often undiagnosed. Is it possible then that the treatment gap directly affects not only the enormity of periictal neuropsychiatric burden in these countries, and can it also affect the way epilepsy is screened for, if we would include, for instance, basic screening? I'll throw an example that if we're looking at, let's say, some of the brain infections that have a predominant involvement of parietal or frontal lobes, then if we would incorporate periictal symptoms into epilepsy screening, we may even improve diagnostic pickup. So I'm going to now borrow, this is from Dr. Kariuki, who I'm going to be working together in a project, and they, from Kenya, he is a psychiatric epidemiologist who works with the Global Epilepsy Network. And just to illustrate that in sub-Saharan Africa, the levels of active epilepsy and the level of status epilepticus is so much higher than what we see in Western countries. Other than that, the onset of these epilepsies, 90% of people present with epilepsy before the age of 20, 75% before the age of 15. Not only that, when one looks at the classification of what active epilepsy and status means, when one compares it to the Western world, the new classification of status is more than 5 minutes, but they don't have, most of these places don't have EEGs. So, and in addition to that, active epilepsy in many Western publications is defined as, I think, more than one seizure in the last year or two, whereas we're talking about here about involving people who have far more active epilepsy. So the disparity between the level of active epilepsy, 60% of which are focal epilepsies, status, and really all the other risk factors we know for post-ictal behavioral symptoms, including neurodevelopmental disabilities, multiple lesions. In fact, there are many, many of the risk factors that we know to be risk factors of post-ictal psychosis are more prevalent, predictably, in sub-Saharan Africa than they are, and this should inform the way neuropsychiatric burden is assessed. Next. Now, when one looks at interictal, unlike in Western countries, it has to be stratified. It's not only the epilepsy, but then there are the primary CNS disorders, okay, which we could predict having more symptoms from both brain infections and traumatic brain injuries due to gaps in provision of clean water, food safety, and immunization. Looking at the burden of neurodevelopmental disorders, which are barely assessed, but because of perinatal trauma, congenital and early brain infections due to gaps in maternal and perinatal care. We're looking at areas that have gaps in civilian protection and disability rights. So we're talking about increase of burden of trauma-related symptoms due to stigma, discrimination, war, and displacement. And of course, we're also talking about iatrogenic, but completely different to what we know because they're using different medications and they have access to different medications. So if we quickly just look at brain infections, I resisted the urge to present wonderful tables with all these different statistics about different brain infections because the truth is there isn't enough data and I didn't want to present it as fact, but there is such limited information. Next. I do want to focus just on neurocysticercosis, which is endemic in all these places. And there's a lot of controversy as to what extent it does cause epilepsy, but the statistics range between 10 to 30% of epilepsy, which is not only incredible to think that so much of the epilepsy in this world is preventable by having clean water and food safety, but to take it a step further and to think that so much of the world's neuropsychiatric burden might be preventable through clean water is for a psychiatrist quite mind-blowing, to be quite honest. I won't go into the details, but just to show that the information isn't clear, but it seems that depression is very, very common, as is mild cognitive impairment. There are differing statistics about psychosis. And next. And here I'd just like to, next. I'd like to show that if we look at all the, probably can't see from then, I apologize, but if we're looking at cerebral tuberculosis, malaria, river blindness, HIV, of course, meningitis, all of these are associated with seizures, some of them like malaria in having catastrophic effects on neurodevelopment in children, as river blindness with the nodding syndrome, or cerebral tuberculosis, which has a predilection for frontal and parietal lobes, and HIV we're all more acquainted. And with the reduction in foreign aid, it seems that there are going to be far more million people in Africa who are going to be suffering also from HIV and AIDS-related syndromes. What is so clear is that there is very little data available and that there needs to be some kind of new discipline which overlaps mental health, brain health, mental health, epilepsy, and brain infections. Next. And we'll just go to iatrogenic, which everyone is so much more familiar with, but we just need to be reminded that there is no access. And so we need to look at the medications that are currently available, if they are available, and see what the side effects are of those medications, and look at their interactions with traditional treatments, and then their interactions with the many, many antiparasitic and antiviral medications like ivermectin or quinine that themselves cause neuropsychiatric symptoms. So we need to share the knowledge, translate and adapt the knowledge. but we need locally created frameworks. So what I've set up to now is still a very biomedical approach, which is obviously the way I've been taught and the way I think. But if it's going to take root somewhere, it's the local environment that has to think and create a system according to the way they think, and looking at spiritual health, community health, not only in the present, but in the past and the future, not only about doing, but how they know and how they are in the sense of their personhood. Knowledge has to be created locally. And so I just would like to call upon you all to get involved in a project that I'm very, very lucky. Next. Sorry. Next. Sorry, I don't understand. Oh, no, this is really important. Sorry?
That network is slow.
So I don't, okay. And I'm very, very lucky to have these two incredible academics and to be joint coordinators in a project. Simon Kariuki is a psychiatric epidemiologist from Oxford, and he and working in originally he's from Kenya, and he works in Kenya and has incredible public health projects. And Dr. Musa Wetila, who is from Nigeria, currently in Scotland, and from UCL, training from UCL. And we are planning a project together, a complex epilepsy case rounds. The format will be every few months, we will have a different complex case, which will involve the overlapping of mental health, epilepsy, brain infections, public health and neurodevelopment, and all the other things that are necessary. And it will involve a brief webinar and then a case presentation and discussion. The whole idea is a combination of knowledge exchange and capacity building, and developing relevant knowledge for that doesn't exist in the literature about these complex cases, and trying to work out within the system what are the best practices, because the best practices that come from the West are not applicable in these environments. This is for neurologists and psychiatrists who work in low resource settings. And we'd all be very happy if there's anybody here in the audience, or if anyone knows anybody in India who would be interested to join us, or anyone in any low resource country. And so we'd be very, very grateful if anyone would join us. So thank you very much.
Thank you, Dr. Fischel. Before I ask for questions of the room, I'll just ask you for your opinion on something myself. When back in the 1980s, when we started our comprehensive epilepsy center at our institution, began doing epilepsy surgeries, et cetera, I began going to the American Epilepsy Society meetings, and they have like a psychiatric interest group. And I was rather shocked to find out that there was no universal acceptance of the notion that there should be a psychiatric evaluation for people with focal epilepsy who are being considered for interventions like surgery. And then I gradually accumulated experience with people who were in epilepsy monitoring units having terrible psychiatric issues that would arise, eventually led to us doing a case report in the New England Journal of Medicine, as there are no official recommendations for how to use prevention in epilepsy monitoring units to prevent the well-known psychiatric comorbidities from emerging when we take people off of their anti-seizure medicines, et cetera. I haven't heard anything from the WHO in terms of a universal recommendation for a psychiatric or neuropsychiatric evaluation of people who are being considered for an intervention for epilepsy. So I'm wondering whether, as you look at the sort of world trends that you were mapping out, have you seen some sort of a plan for an international recommendation for the involvement of mental health professionals in the treatment of people with epilepsy, especially focal epilepsy?
The short answer, I think the consistent problem, irrespective of where it is, it's just far more magnified and pronounced in low resource countries, that there's still a dualistic attitude towards epilepsy. And so really, it really is quite the case, I think, in a lot of Western countries that don't have specialized units, which are really quite rare, that any distress or difficulty with, in a person who's got epilepsy, that's relegated to psychological issues, whereas in low resource countries, it's social and cultural. But the notion of incorporating a brain-based assessment that is in keeping with your understanding of seizures and epilepsy is just not the way the system works. The DSM isn't framed that way. Using the DSM is useless for someone, I think, who has epilepsy. Well, probably shouldn't be that aggressive about it, but I think that from top to bottom, the system is separated and polarized. So if you have epilepsy and you have depression, that will be calculated as mental health burden, but not epilepsy burden, because they're separate. And if you have a brain infection and you have depression, that will be part of your non-communicable disorder, but not your communicable disorder. So everything is very much separated. And I think that that's how we practice. And I think that trickles down clinically. So in terms of best practices, I don't think, I mean, we've got other people here in the audience who've got far more experience and definitely in management positions in terms of epilepsy, who probably have different experiences because it's more developed. But I can say that in most places, let's just say the research that Professor Kanner did, that had an assessment of periictal psychopathology, used a research instrument, but there is no instrument that's standardized and accepted that looks at periictal psychopathology, which already says that we don't know how to incorporate looking at that. And now, I'm not quite sure if your question was looking at just interictal, but I think that's exactly the issue. I think that when you say psychiatric comorbidity, I think that's already, to me, neuropsychiatric symptoms have to be incorporated into our understanding of epilepsy as a brain disorder, as opposed to being seizures plus psychiatric comorbidity. I think it's all part of epilepsy, just as it is a neurodevelopmental disorder. I think it should be all together. But I don't think we're there yet, so that doesn't surprise me. That I'm not quite sure if I answered your question.
Well, we're looking for, the question is whether
quick
any
answer is
international
no.
body has recognized this problem, that psychiatric issues are part and parcel of having focal epilepsy. Is there anyone in the room that has a question for Dr. Fischel?
Michelle, I wanted to say that, I just wanted to answer your question and sort of add to what Tamara had to say. The International League Against Epilepsy has had a neuropsychiatry commission now for several years. And in fact, the current chair is Kurt LaFrance, who's in the room. Yeah. I was the chair many, many moons ago. We've published the classification of psychiatric disorders in epilepsy in I think maybe the year 2003 or 2004. And there are a number of instruments of research that have been developed and utilized. There are many position papers and task force papers from the ILA. Of course. So the ILA has been quite active. I think there are nuances. I completely agree with Tamara. There are nuances. There are specific areas where there are probably still gaps in terms of tools that we can use. Pre-surgical evaluations in Europe and the UK have always included neuropsychiatric assessments. So if you look at Bielefeld,
so we are the outliers in the US. So Krish, in the US, we are the outliers.
Professor Trimble, with whom
I apologize. I misunderstood the question because I was more referring to low resource countries and not to actually Western countries.
I trained used to comment about this all the time, that you go to an epilepsy surgery unit, a top epilepsy surgery unit like Columbia in the US, and they don't have a neuropsychiatrist. They have neuropsychologists, but they don't have a neuropsychiatrist. I don't know if that situation changed, But this used to be talked about many, many years ago. But neuropsychiatry is part of epilepsy care in the UK and Europe forever.
I misunderstood the question because I mean, there's no question.
Sort of practice difference.
Yeah,
Yeah.
that's quite clear. Yeah.
Hi, Shell. Good question.
Oh, Jay,
what
hi.
I can say, and this will echo, yeah, hey, how are you? What I can say to build on both of the comments is that there are efforts, certainly with ILAE, which is probably a little bit further ahead of AES, the American Epilepsy Society at this point. We have this problem of preaching to the choir quite often.
That's what I want to say.
And yeah, that's really the issue. I think we struggle with how to expand it and how to communicate more to others about a paradigm shift for epilepsy. We haven't quite figured it out yet.
Yeah, I agree. Other comments in the room?
The question was really more about
Hey, Phil.
Is there one in the back? I can't
that.
see.
Yeah, it's Kurt.
Hi, Kurt.
Hey, the other comment to add that Krish alluded to was that the current ILA president, the incoming, is Ala Gecht from Moscow, and she is very much also involved in World Health Organization endeavors, and IGAP is one of the things that is being utilized in epilepsy, that being put on the map for World Health Organization, and with their mental health focus also, we're trying to bridge the two now. So hopefully in the next 5 years, 4 or 5 years, with the Neuropsychiatry Commission and with Allah's involvement in World Health Organization and with the great task forces that we have, we'll be able to bring that more to the fore. The question you're asking, I don't know that we'll ever get to a regulatory body level where it has to be required per se, but it's increasing awareness basically.
And
I'd just
as
like to make a
Krish,
comment.
oh yes,
I
sorry.
think that's no, as far as the IGAP, there's no question that do you want to imply that it's groundbreaking in what I was saying. The IGAP and the attempts of the World Health Organization to integrate mental health into global health with epilepsy and with other illnesses, my major point is that the focus of mental health is on social factors and on cultural factors, on stigma and on adherence. Every single lecture focuses, and almost every mental disorder that could be otherwise in the West categorized as either periictal or something else is understood within a psychosocial framework. And I think that that has resulted in an enormous amount of diagnostic overshadowing. And that is my my key issue that I think needs urgent attention.
So in sum, we've a long way to go. And Krish, your observation from Colombia, I don't think things have changed too much. So it's only a few centers that always have neuropsychiatry involved. Here in the States, we're going to be dragged probably by Kurt and others into the future, but not quite yet. Anyway, thank you very much, Dr. Fischel. This, I believe, is a wrap for the symposium. Unfortunately, it's been in the middle of the night, our time, but the list of presentations and presenters is quite impressive. And I want to thank Jazz and Vivek and Krish and all of the organizers for all the work they did in pulling this together. Very impressive work. I hope to see you all in person at some point. And I know there's other things on the agenda here this evening for you, but thanks very much and have a nice rest of the day.
Thank you.
Thanks, Shel.
See you around.
Now that's the end of the session. I now request Dr. Rama Raghu to felicitate Dr. Tamara Fisher. That's it. So I think just like in the IT companies. Yes. So in the IT companies, there is something called hackathon where people come together, 48 hours, they write codes and create an app. Well, there is no app, but lots of knowledge exchange over 2 days. Like I have the numbers. I was discussing there in person and online, the faculty members were 45 and over 300 participation online. So we are looking at 350 people came together, attended 11 sessions of knowledge exchange focusing on the new Neurofrontiers 2025. And if you are not on the global GNG Global Neuropsychiatry group, I suggest that everyone online and thing should join the group where Jess have put up all the summaries for all the 11 sessions what we have done, and I think it's a great resource. Coming together, like we have in-person speakers, Professor Kurt France, Professor Jake coming from US, Professor David Coghill from Australia. Then we are Dr. Hital Kumar from UK, Dr. Tamara from Israel. So it is like, it's significant. Of course, Dr. Jess, my co-convener traveling from Australia to being with us. And all over the part, like, I see the other psychiatrists coming from, especially the Buddhi Clinic representative, Dr. Nagarajan from Coimbatore. We have Dr. Spush. So it is a global conference in a true sense that some of the sessions I see, there are 3 or 4 country speakers and faculties are together. And the second last thing we saw, like it's across, US, UK, India, and Australia, all participating in one session. Well, that's I think truly deserve a round of applause, and just for making and suggesting all those speakers. Comment from you, Jess.
No, Vivek, you have been a great co-convener. It was a pleasure to be here and honor to be here. As always, great hospitality from Krish and his Buddhi Clinic team. I think everyone has been so nice and warm-hearted and welcoming us and spoiled with good food as well. It was also an honor to meet Jay again and meet Kurt, Hetal after a long time. Tamara, we have been in touch for some time. And obviously Dave Coghill, we live in Australia together. This is the first time we have met officially. So it has been a great pleasure not knowing these are my colleagues, but other people as well. So I think it has been all the effort, a lot of effort had gone behind this. I think what you see is only the tip of the iceberg. There have been so many exchanges, so many effort has gone into this. So we're pleased that the outcome has been good and everyone has liked it. And I was discussing with Krish yesterday, and I think we're a bit disheartened yesterday. We're not seeing many numbers, but the numbers gradually picked up. And then Krish inspired me by quoting a quote from the Gita that we should be more concerned about the duty we have rather than the fruit we get after the work we do. So we'll keep doing the hard work and hopefully we'll keep providing the good quality educational stuff. So thank you everyone for being part of it.
With regards to the poster session, so we have So we have two participants presenting 4 posters, and I should read the thing. So the best poster we chose on the special topic is on the safety and tolerability of TDCS in the persons with aphasia, randomized controlled trial, presented by lead author Swati C. So this best poster award is carries a a reward of 10,000 rupees, which will be once you put your details to the registration desk, it will be credited to your bank account. Congratulations. And next time you can bring your other colleagues and the juniors so they can also present much more posters. Congratulations. I will now like to request anyone else want to have some comments on the 2 days conference, feel free. Anyone from the audience? Okay. If there's no comments, I will ask Dr. Rama to give the vote of thanks.
Compared to the morning, distinguished delegates, colleagues, and guests, it is my privilege to deliver the vote of thanks on behalf of Buddhi Clinic. Neurofrontiers 2025 marks an important milestone in neuropsychiatric education and collaboration. We thank the International Neuropsychiatric Association and the Global Neuropsychiatric Group for creating this valuable platform for scientific exchange. We sincerely acknowledge our conveners, Dr. Jaswinder Singh and Mr. Vivek Mishra, whose dedication and months of careful planning made this conference possible. We also thank our chairpersons, speakers, and discussants for guiding the sessions with clarity and rigor. Our deep appreciation goes to our distinguished faculty from across the world, both in person and online. We make special mention of Professor David Coghill, whose first visit to India to Neurofrontiers 2025 is truly an honor. We are delighted. We acknowledge Dr. ESK for his continued leadership and guidance. We thank our delegates for their active participation and the Marundishwara team for their seamless event coordination. Finally, we recognize the entire Buddhi Clinic team for their tireless efforts behind the scenes. Neurofrontiers 2025 has successfully bridged disciplines and borders, and we trust the knowledge shared will translate into better patient care. We look forward to continued collaboration to the INA-GNG network, and yes, wishing us all a wonderful 2026. Good night. Thank you.
Yeah.